Good evening, everyone. Hopefully, I'm audible and the screen is visible too. Please let me know if the audio visuals are absolutely clear. If they are, then we can begin with the session. Okay, no issues. So, as per the request, I will be using both the languages. ठीक है, हिंदी और इंग्लिश दोनों में सेशन चलेगा. So please don't worry, both of them. Okay, all of you don't worry about anything else. Okay, we'll be covering surgery in a short, crisp, and a concise manner with both the languages properly. Each thing that I say in English, I'll repeat that in Hindi. So all the English viewers, you don't need to think that you are missing out on something. Okay, so don't worry about that. So hopefully we can start. Great, great, great. Don't worry, दोनों में concept बनवा देंगे. Okay, we'll make concepts in both the languages. No issues with that. चलो. Hopefully all of you are doing good. So let me introduce myself first. For those who don't know me, I'm Dr. Omkar Sangita Dilpra Sonone, currently pursuing my MS General Surgery residency. And over here, we'll be revising the surgery for not only your FMG examination, but also for your NEET or next PG examination. Whatever it comes your way, I'll make sure that whatever surgery we are revising, it will be short, it will be crisp, it will be concise, and it will be more than enough to solve most of the MCQs in your examination. I will have a proper focus on all the previously asked topics and the questions. Okay, so we'll be covering all the questions alongside. You don't need to think about anything else. Okay, but the only thing that I will need, yes, don't worry about that. All of them definitely I'll cover it over here itself. Okay, yes, it will be an integrated session because surgery, as I always say, it is a parent branch. So यहाँ पे I will not only focus on surgery, I will definitely focus on all the allied other subjects as well. Okay, we'll be covering a lot of MCQs and a lot of topics from other subjects too, because a surgeon could not say that I don't know a specific thing. So like that over here, once you have studied surgery, you should not say that you do not know anything about the allied branches as well. Okay, chalo. PDF I'll be sharing after the class in the Telegram channel. Dr. Bhanu Prakash Telegram channel. I'll be sharing it with him and he'll be sharing it with all of you. Don't worry about that. Okay, at the end of the session, सबको PDF मिल जाएगी. Don't worry about anything else. Chalo. Yeah, everything with images, everything. So if you're not able to solve your long questions, definitely everything will be easier for you after you watch this session, because I will be giving you important topics, important keywords to solve any question. Okay? So I'll be telling you on the way how to approach a particular clinical unit in a case of surgery and how to approach the MCQs as well. Don't worry about anything else. Chalo. Great. My pleasure it is. Sure. Chalo. Okay, so let's begin without any further delay now. The first topic that I'm about to start will be general surgery. And a lot of people feel that there have not been a lot of questions from general surgery. So let me reiterate the fact, मैं वापस से एक बार बता दूं ये चीज, that nowadays general surgery has a major chunk of questions. Okay, apart from GIT, definitely if they ask you what is the second most important topic from surgery, I'll say it is general surgery. ठीक है, तो सबसे ज्यादा क्वेश्चंस अगर GIT के बाद किससे आते हैं तो वो जनरल सर्जरी से आते हैं. ठीक है, no issues with this anybody? So that you need to remember properly. Now in general surgery, we'll be covering a lot of topics. Okay, we'll be covering the first and the foremost important topic, and that is what is hemorrhage and bleeding. All the aspects about hemorrhage, bleeding, shock, everything I'll be covering. Then further, I'll be covering with all the general topics, that is ranging from your IV cannulas to your surgical instruments to your surgical positions, everything regarding that. Okay? Once I'm done with that, then definitely I'll be starting with the most important topic or subtopic from general surgery, and that is what is trauma. Okay? So I'll be starting with trauma. We'll be winding up trauma, And once we are done with that, we'll try to approach endocrinal surgery as well today. And in endocrinal surgery, we know the most important two topics are usually your breast and thyroid. Okay? Chalo. Let's start without any further delay. Shall we begin? Just give a thumbs up in the chat box so I can begin. No, it won't be deleted. Don't worry about that. Sure. I'm starting now. The first topic that I'm going to start is a dreaded complication for every surgeon. Okay? So it is a dream, rather a worst nightmare for every surgeon, and that is what is hemorrhage. But important is a surgeon with practice definitely knows how to overcome this problem or how to overcome this complication. Okay? So that's the important thing we need to learn during surgery. And that most dreaded complication during a surgery is usually hemorrhage. Rather, in most of the surgeries, the most common complication, if they ask you, usually it is a hemorrhage. Because if you're going to give a cut anywhere, what it will happen? It will lead to some bleeding. And that is what is hemorrhage. So hemorrhage in simple terms, guys, hemorrhage does not mean anything else apart from bleeding. Okay? So hemorrhage का मतलब ही होता है खून बहना. Okay? So bleeding or okay, so bleeding is what is called as hemorrhage. Now, hemorrhage can be of various types. Either it can be a physiological hemorrhage or it can be a pathological hemorrhage. Physiological hemorrhage, that means the normal bleeding which occurs from our body. So does it occur from a male body? No. So usually the physiological bleeding is only seen in females and it is seen every month. That means during menstruation. So the menstruation, the menstrual cycles or the menses, that bleeding which occurs is an example of physiological bleeding. Apart from that, every type of bleeding will be considered as pathological bleeding. So normally जो females में होती है हर महीने, that is what is a physiological bleeding, that is what is menses. ठीक है? उसके अलावा जो भी bleeding होगी, that is considered as pathological bleeding. Pathological bleeding कब हो सकती है? Usually when we have got a cut. Okay, when we have got a cut, there is incision, there is trauma, there is infection. All of these conditions can lead to pathological bleeding. Then definitely bleeding can be, we can see blood with our naked eyes. If we are able to see the blood with our naked eyes, that is what is called as external bleeding, or it can also be called as revealed bleeding. It can also be called as revealed bleeding, whereas otherwise it will be internal bleeding. And internal bleeding, when we cannot see the blood with our naked eyes. अगर तुम्हें blood दिख रहा है, बाहर बहता हुआ खून दिख रहा है तुम्हें, that is what is an example of external or a revealed bleeding. But if you're not able to see the blood outside, अगर तुम्हें खून बहता हुआ नहीं दिख रहा, that is what is the internal or a concealed bleeding. That is what is the internal or concealed bleeding. Now, if the blood is coming outside, if the blood is flowing outside, definitely you can make it out easily. But if you're not able to see the blood, how you are going to make out that the patient is bleeding? So important is, if a patient is having some internal or concealed bleeding, how we are going to make out? अगर हमें खून नहीं दिख रहा तो हमें पता कैसे चलेगा कि पेशेंट में इंटरनल ब्लीडिंग हो रही है? If you are not able to see the blood, how we are going to make out if the patient is bleeding internally? So for that reason, you need to assess the vitals of the patient. तुम्हें पेशेंट के वाइटल्स चेक करने होते हैं. And what do I mean by vitals over here? The vitals मतलब only two important things you need to check. One is the heart rate of the patient and second is the blood pressure of the patient. So if a patient is having a lot of bleeding, a lot of blood loss from the body, what will happen? The blood pressure of the patient will go down. The blood pressure of the patient goes down, and that is what is called as hypotension. So blood loss अगर ज़्यादा हो जाता है body से, definitely the patient's blood pressure will go down, and that is what is hypotension. Now, if there is hypotension, okay, if the blood pressure is too low, will the organs receive enough amount of blood? No, the organs will not receive enough amount of blood. And अगर organs को enough amount of blood नहीं मिलता, what will the heart try to do? The heart will try to compensate. And how does the heart compensate? So the heart will try beating faster. As the heart starts beating faster, what will happen? Definitely the heart rate of the patient will increase. So to overcome the decreased blood supply to the organs, the heart starts to compensate. The heart starts beating faster. And that is the reason why if a patient is having too low blood pressure, the patient will have a reflex tachycardia. The patient has a reflex tachycardia. Okay? And if the patient is having low blood pressure, that is hypotension, along with a reflex tachycardia, that is increased heart rate, both of these signs are suggestive of shock. Both of these signs are suggestive of shock, right? So if there is low blood pressure, that is hypotension, and increased heart rate, that is tachycardia, both are signs suggestive of shock. So definitely, even if you are not able to see external bleeding, you need to check the vitals of the patient, and if the patient is landing up in shock, that is an indicator that the patient might have some internal bleeding or some concealed bleeding. Okay? So that's the most important thing you need to remember over here. Okay? So that's one thing that we need to discuss, and we will discuss about shock in details further. Definitely, don't worry about that, right? Apart from that, if there is a cut to the artery, now how the blood will come out? If there is a cut to the artery, if I give a cut over the artery, the blood will come out with every pulsations. There will be more blood coming out during every pulsations. Why? Because we know in an artery there are stronger pulsations. Artery में क्या होता है? Pulsations होता है. Therefore, if there is a bleeding or hemorrhage from an artery, there will be stronger pulsations, right? So the blood will come out with every pulsation. So if there is a jet-like pulsations, the bleeding is seen as jet-like pulsations. That is what is suggestive of an arterial bleed. Next, if there is a continuous bleed, there is no jet-like pulsations. If there is a continuous bleed, please remember, if there is a continuous bleed, then definitely that is what is suggestive of a venous bleeding, right? Because veins does not generally have pulsations. अगर veins में pulsations ही नहीं होंगे तो jets दिखेंगे तो दिखेंगे क्या? नहीं दिखते. Okay? So if there is a continuous bleed which occurs without any jet-like pulsations, that is what is suggestive of a venous bleed. The third type of bleeding is usually from the small vessels of your body. The smallest vessels of your body are what are your capillaries. And if there is damage to the capillaries, for example, if I only give a superficial cut, बस ऊपर से काटा मैंने, ठीक है? If I give a superficial cut, the capillaries will be damaged, and then there will be a generalized oozing of blood. There will not be massive bleeding which comes. There will only be minimal amount of bleeding, and that is what is called as a generalized ooze. So if they mention generalized ooze, definitely, please remember that is what is suggestive of a capillary hemorrhage or a capillary bleeding. ठीक है? So don't worry Deepu, I am using both the languages. ठीक है, दोनों लैंग्वेज में बात कर रहा हूँ. हर चीज जो मैं इंग्लिश में बोल रहा हूँ, I'm translating it. Okay, but we need to be considerate about all other people who cannot understand Hindi as well, right? So I need to talk in both the languages. Yes, I am talking in both. दोनों languages में बात करेंगे. Don't worry about that. Don't have a FOMO that you are missing out on something. No. ठीक है, चलो. Now these was about the general types of bleeding. Now, if I talk about the surgical bleeding or surgical hemorrhage, if I talk about surgical bleeding or surgical hemorrhage, that means any bleeding or any hemorrhage which occurs during surgery or after surgery. These are called as surgical bleedings or surgical hemorrhage. कोई भी bleeding अगर surgery के दौरान होती है या उसके बाद होती है, that is what is a surgical bleeding or a surgical hemorrhage. Now, these surgical bleedings are classified into three types. There can be three types of surgical hemorrhage. The first one that we have is called as a primary surgical hemorrhage. The first one we have is called as the primary surgical hemorrhage. What do I mean by primary surgical hemorrhage? Any bleed, please remember, any bleed which occurs during surgery. Any bleed which occurs during surgery is known as a primary hemorrhage. तो याद रखना है, कोई भी खून जो बहता है सर्जरी के दौरान, that is what is a primary hemorrhage. That you need to remember. Any bleed which occurs during surgery, that is what is a primary hemorrhage. What is the cause? If we are performing a surgery, okay, what happens usually with a sharp instrument, there can be injury to some of the artery or there can be injury to some of the vessel. Okay, then definitely the bleed which is there, it is known as primary hemorrhage. So what is the primary hemorrhage in short? Usually when we were performing a surgery, there was some injury to a vessel in the surgical site and that is causing a bleed. That is what is a primary hemorrhage. ठीक है, तो याद रख लो, सर्जरी के दौरान अगर किसी भी वेसल को चोट लग जाती है और वो ब्लीड करने लगती है, that is what is primary hemorrhage. What is the cause? Now, if there is injury to the bleeding vessel, that bleeding vessel is known as a bleeder. So the cause of a primary hemorrhage is usually a bleeder. ब्लीडर का मतलब होता है कोई भी वेसल जिस पे चोट लग गई हो वो ब्लीड कर रही हो, दैट इज व्हाट इज अ ब्लीडर. ठीक है, नाउ व्हाट इज द ट्रीटमेंट? एज वी हैव द सर्जिकल साइट ओपन इन फ्रंट ऑफ अस, we have the surgical site open in front of us, so what should be the treatment? So definitely the treatment is just ligate the bleeding vessel. We need to perform a ligation of the bleeding vessel, or if the bleeding vessel is very small, we can just use the cautery. That is what is called as cauterization. So either we can go for ligation of the bleeding vessel or we can go for cauterization of the bleeding vessel. Okay, so that's what about your primary hemorrhage you need to remember. Next one is called as the reactionary hemorrhage. What is a reactionary hemorrhage on the other hand? So please remember, reactionary hemorrhage is any bleeding. It is any bleeding which occurs, okay, any bleeding which occurs within 4 to 24 hours of surgery. Any bleeding which occurs within 4 to 24 hours of surgery. Okay, so that's the important thing. Please remember, any bleeding which occurs after 4 hours till 24 hours of surgery, that will be considered as reactionary hemorrhage. कोई भी खून अगर 4 घंटे बाद सर्जरी के अगर बहने लगता है till 24 hours, that will be considered as reactionary hemorrhage. Now, what is the cause of reactionary hemorrhage? Usually at the end of surgery, you took sutures, okay, and after taking the sutures, you finally tied a knot. Okay, to secure the sutures, you finally tied a knot. तुमने सूचर्स ले लिया और उसके बाद क्या बांध दिए, गांठ मार दी. दैट गांठ इज व्हाट इज कॉल्ड एज अ नॉट. ठीक है, सो यू हैव टाइड अ नॉट, but instead of tying a secure knot, you have tied a insecure knot. Okay, and what do I mean by insecure knot? A knot which can slip off easily is known as an insecure knot. तो तुमने गांठ तो मारी, बट वो गांठ कैसी थी, एकदम ढीली सी थी, इनसिक्योर थी, and therefore it has slipped off easily. So important is, what is the most common cause of reactionary hemorrhage? If they ask you what is the most common cause of reactionary hemorrhage, is what is the slippage of knot or a slippage of ligature. Okay, so most common cause of a reactionary hemorrhage will be slippage of a knot or slippage of a ligature. Okay, apart from that, what can be another cause of reactionary hemorrhage? So you need to remember, during surgery, we ask the anesthetist to maintain the blood pressure on the lower limit of normal. We ask the anesthetist to maintain the blood pressure on the lower limit of normal to avoid any excessive bleeding during surgery. ठीक है, तो जब सर्जरी चल रही होती है ना, तुम एनेस्थेटिस्ट को क्या बोलते हो कि जो ब्लड प्रेशर है ना वो लो लिमिट पे रखो, लोअर नॉर्मल पे रखो. व्हाई? टू अवॉइड एनी एक्सेसिव ब्लीडिंग ड्यूरिंग सर्जरी. ठीक है, so after the surgery is over, after the effect of anesthesia is gone, after the patient comes out of anesthesia, क्या हो जाएगा? There will be sudden spike in the blood pressure of the patient. After the influence of anesthesia gets over, there can be a sudden spike in the blood pressure, and that is due to reflex vasospasm. And that increased blood pressure after surgery can also be an important cause of reactionary hemorrhage. ठीक है, sudden increase in blood pressure after surgery can also cause reactionary hemorrhage. Now here the patient is going to present to me with excessive bleeding or minimal bleeding. So here after surgery the patient is going to present to me with a massive bleeding. बहुत ज़्यादा bleeding होगी. Okay, so the patient is going to present to me with massive bleeding in a case of reactionary hemorrhage. Yes, the other cause can be dislodgement of clot too. Now what should be the treatment over here? Please remember, the treatment in this condition is, we cannot manage this patient in the emergency room. हमें इस patient को कहाँ ले जाना पड़ेगा? We need to take this patient to the operation theater. So take the patient to the OT, take the patient to the operation theater and re-explore the surgical site. ढूंढो कहाँ से bleeding हो रही है. That is what is called as re-exploration. So re-exploration of the surgical site should be done. You need to find that actually which vessel at the surgical site is bleeding, and then go for religation. Again ligate, because the suture has come off now, the knot has come off. Therefore, you need to again religate. So re-exploration and religation at surgical site is what is done in cases of reactionary hemorrhage. The third type of hemorrhage is known as secondary hemorrhage. Another type is known as secondary hemorrhage. What do I mean by secondary hemorrhage? Secondary hemorrhage is any bleed which occurs 24 hours after surgery. Any bleeds which occurs usually 24 hours of surgery is known as secondary hemorrhage. You will say, sir, we have read in a lot of books that usually secondary hemorrhage is the one which occurs after few days of surgery. Yes, because majority of cases or 90% cases of secondary hemorrhage present to us after 5 days of surgery. Okay, so majority or 90% of the cases of secondary hemorrhage present to us after 5 days of surgery. Okay, so commonly most of the books write or define secondary hemorrhage as any bleed which can occur after 5 days of surgery. No issues with this. That's important. जो भी खून अगर 24 घंटे के बाद या मेजरली 5 दिन के बाद बहता है सर्जरी के, that is secondary hemorrhage. What is the most common cause of secondary hemorrhage? Now, if they ask you what is the most common cause of secondary hemorrhage, your answer should be infection. Your answer should be infection. Where infection? At the surgical site. Okay, so infection at the surgical site or a surgical site infection is a cause of secondary hemorrhage. So you will say, sir, how due to an infection the patient can bleed? Yes, the patient can bleed. How? Because the infection will start damaging the blood vessel wall. Okay, it will start eroding or damaging the blood vessel wall. तो infection क्या करता है? Blood vessel wall को damage करना शुरू कर देता है, and due to which the patient has bleeding. Secondary hemorrhage, here the blood vessel wall is completely open or what? No. In reactionary hemorrhage, the blood vessel wall was completely open due to slippage of ligature. But over here, the blood vessel wall is not completely open. There is only some damage to the blood vessel wall. So here the patient will not have massive bleeding. Rather, the patient will come to you only with mild bleeding or minimal bleeding. So important is that, please remember, here the patient only complains of mild or minimal bleeding. That is what is your keyword you need to pick up in the question. Okay? So it is the time of presentation, second is the type of bleeding, and third, they might give you about the cause as well. Now, what is the treatment of secondary hemorrhage? So treatment of secondary hemorrhage, if infection is the cause, treatment will be definitely antibiotics. But antibiotics should be given orally or IV. Definitely the antibiotics should be given IV. And for IV antibiotics, we know that the patient should be admitted as well. Because in one of the previous year questions, the question was, will you give IV antibiotics? And the other option was admission plus IV antibiotics. What is the better answer now? You know. So it is admission plus IV antibiotics, because IV antibiotics are never given. IV antibiotics are never administered or never given on a OPD basis. They are always administered or always given in an IPD basis. हमेशा patient को admit करोगे और उसके बाद IV antibiotics start करोगे. ठीक है? So these are the important types of surgical hemorrhage you need to be aware of. Please remember this. ठीक है? So this is very important and a very commonly asked question from ENT as well as surgery. ठीक है? So they commonly ask you about the reactionary hemorrhage. That is your topmost favorite. And second is the secondary hemorrhage. They're not interested about talking about the primary hemorrhage. They're more interested talking about or asking you about the reactionary or the secondary hemorrhage. Moving further. Now, please answer this question, which you can see over here. This was a previous year question of FMGE as well as your neetpg examination. And what was that question? A patient underwent hernioplasty, okay, and post-operative period was uneventful. And what do I mean by uneventful? For those who don't know, uneventful, that means without any complication. Uneventful का मतलब ही होता है कि कोई complications नहीं हुए surgery के बाद. Okay? He presents on post-op day 7. The patient presents to you after post-operative day 7 with complaints of minimal bleeding. See, he is presenting on post-op day 7 and the complaint is only minimal bleeding from the surgical site. What is the cause and what is the treatment? Make a provisional diagnosis. Which type of hemorrhage is it? Make a provisional diagnosis. Which type of hemorrhage is it? Primary, reactionary or secondary? So definitely what I've highlighted are your keywords to be found in the question. As the patient mentions that the bleeding is occurring after post-operative day 5. That means it is a case of which bleeding, anybody? It is a case of secondary bleeding. Very good. It is a case of secondary bleeding or a secondary hemorrhage. Very good. And what should be done? So we know secondary hemorrhage or secondary bleeding is usually due to infection. Therefore, the treatment should also be IV antibiotics. But IV antibiotics are always administered after admission. So admission plus IV antibiotics. Okay. Done with the concept. No issues with this. And that's how you need to answer your questions. Not reactionary, not reactionary. Reactionary agar hota, then the patient would have presented to us within 24 hours of surgery. Here the patient is presenting to us after post-op day 5. So it is a case of secondary hemorrhage. Chalo. Now talking about once if the patient is having excessive bleeding, what we are going to give the patient? Definitely we need to give the patient blood, and that is what is called as blood transfusion. So we need to administer blood to the patient. That is what is called as blood transfusion. Now take an example. If a patient is suffering from dengue hemorrhagic fever, okay, and in cases of dengue hemorrhagic fever, we know that the patient's platelet count goes very low. Okay? So in cases of dengue, patient की platelet count क्या हो जाती है? बहुत ज़्यादा कम. That condition is what is called as thrombocytopenia. So in a case of thrombocytopenia, will you like to give only platelets to the patient or will you like to give whole blood to the patient? Definitely we will only like to give platelets ना. बाकी खून की उसको जरूरत है क्या? नहीं है. So definitely does not require any other components of blood. He is only suffering from thrombocytopenia. So you give only platelets. So for that reason, please remember, usually in blood banks what is done? We will store whole blood definitely, but we also isolate some other components of the blood as well. ठीक है? So whatever is required, we can only administer that component of blood to the patient. अगर पेशेंट को बस प्लेटलेट की जरूरत है, बस प्लेटलेट दो. पेशेंट को अगर बस आरबीसीज की जरूरत है, बस आरबीसीज दो. ओके, यू डू नॉट रिक्वायर एवरी अदर कंपोनेंट ऑफ ब्लड इन एवरी पेशेंट. ठीक है? सो दैट्स द रीजन व्हाई वी हैव वेरियस ब्लड कंपोनेंट्स. इफ आई टॉक अबाउट दीज इंपॉर्टेंट ब्लड कंपोनेंट्स, first is whole blood. Whole blood, that means we collect the blood from the donor, We store it and we directly, definitely after grouping and cross matching, we will give it to the recipient. Okay, we will store it in the pure form. We are not isolating any component in it. Okay, that is a whole blood. 1 unit of whole blood. Now 1 bag you can say, or 1 unit you can see. The 1 unit is written as like this. Okay, so 1 unit of whole blood contains how much amount of blood, and that has been asked. So 1 unit of blood contains around 350 ml in India, whereas 450 ml in the USA. 1 unit of blood contains around 350 to 450 ml of blood. Important is that you need to remember. And when do we need to give whole blood to the patient? So usually whole blood is given to the patient in cases of excessive blood loss. जब ज़्यादा खून बह जाता है patient में. Okay. So usually in cases of excessive blood loss, we need whole blood in the patient. Okay. We need whole blood. Usually in cases of trauma. Definitely we need whole blood to be given in the patient. Then if I talk about the second component of blood, okay, next if I talk about second component of blood is packed RBC. If I talk about packed RBC, please remember, packed RBCs, here we try to isolate the RBCs mainly. Yes, there is liquid also, but we try to mainly isolate the RBCs in the patient. Packed RBCs, 1 unit of packed RBCs contains around 250 ml of blood. 1 unit of packed RBC contains around 250 ml of blood. And when a packed RBC is administered to the patient, definitely packed RBCs are given to the patient. See, nowadays commonly we give packed RBCs to most of the patients in cases of blood loss also, or in cases of trauma also. But if packed RBCs are not available, definitely whole blood can be given to the patient. Definitely whole blood can be given to the patient as well. Okay, so that's important. Packed RBC, 1 unit contains 250 ml of blood, I've told you. And usually packed RBCs are given in, very good, they are usually given in cases of severe anemia. They are usually given in cases of severe anemia. That means when the hemoglobin value is less than 7. Okay, so 6 to 8. Some books say 6 to 8 is 6 to 8 is moderate anemia, so less than 6. But majority of the books say hemoglobin value less than 7 is considered to be severe anemia. And if a patient is having hemoglobin value less than 7, that means the patient is suffering from severe anemia, and we need to give packed RBCs to the specific patient. Okay, that's important. Next component of blood is what is called as fresh frozen plasma. Next component of blood is known as fresh frozen plasma. Also, we commonly refer it to as FFP, the fresh frozen plasma. Important is fresh frozen plasma. 1 unit of fresh frozen plasma usually consists of how much ml of blood? So it usually consists 150 ml volume. 1 unit contains 150 ml volume. Please remember. Okay? So that's important. And important 2 one-liners about fresh frozen plasma that you need to remember. So fresh frozen plasma is the richest source. It is the richest source of all clotting factors. Please remember. Okay. So fresh frozen plasma is the richest source of all clotting factors. Every other clotting factor is present in fresh frozen plasma. Okay. So richest source of all clotting factors, if they ask you, answer is same. It is FFP or fresh frozen plasma. Next is, as you can see in the name itself, they have mentioned frozen. If it is frozen, that means it will be not stored at the temperature at which other blood components are stored. It is usually stored at freezing temperature. इसको कौन से temperatures पे store किया जाता है? Freezing temperatures पे. So what is the temperature of storage for a fresh frozen plasma? It is stored at minus 42 degrees centigrades. It is stored at minus 42 degrees centigrades. Please remember that. Okay, so it is stored at freezing temperatures. Definitely it is stored at lower temperatures like minus 42 degree centigrades. Next is platelet rich plasma. Platelet rich plasma mainly contains only the platelet. Okay, so it is also known as platelet concentrate a lot of times. So platelet rich plasma का दूसरा नाम is platelet concentrate also. Platelet rich plasma, 1 unit of platelet rich plasma contains approximately around 50 ml of platelets. 1 unit of PRP contains around 50 ml of platelets, and by the name it is evident it is the richest source of platelets definitely. And important is, the question has been, and all of you are going to answer, please remember, below minus 30 degree. Below minus 30 degree. Usually the recommended temperature is minus 42. Okay? So that's the important thing. So usually platelet rich plasma or platelet concentrate is usually given to the patients. Please remember, it is usually given to the patients like in cases of dengue or any condition which will cause low platelet count. And what is that condition known as? Thrombocytopenia. So any patient who is suffering from thrombocytopenia, like a case of dengue, hemorrhagic fever, or it can be a case of ITP, that is idiopathic or immune thrombocytopenic purpura. Okay, because thrombocytopenic now, so that means the patient is suffering from low platelet count. And important is, all of you are going to answer this. Now, platelet-rich plasma or platelet concentrate is stored at what temperature? It is stored at what temperature? And that has been a previous year question in your examination, a very important component. Okay, so please answer it. Platelet-rich plasma or platelet concentrate is the only component which is stored at how much degree temperatures? Please let me know that. Next is cryoprecipitate. Okay, so cryoprecipitate, cryo का मतलब होता है freezing. So again, cryoprecipitate is also stored at freezing temperature. And what is that freezing temperature? The temperature is again same as around the fresh frozen plasma. It is around minus 42 degrees centigrade. Important you need to remember is cryoprecipitate is the richest source of two important clotting factors. Cryoprecipitate is the richest source of two important clotting factors. One of them is clotting factor number 1. Okay, that is fibrinogen. So it is richest source of clotting factor number 1, that is fibrinogen, and second is clotting factor number 8. The second one is known as clotting factor number 8. So please remember, cryoprecipitate is the richest source of clotting factor number 1 and 8. And when do we require clotting factor number 8? Mainly when there is deficiency of clotting factor 8. And deficiency of clotting factor 8 is usually seen in a condition, and that is what is called as hemophilia. So please remember, if they ask you richest source of all clotting factors, your answer is FFP or fresh frozen plasma. But if they ask you richest source of clotting factor number 1 and 8, then your answer is cryoprecipitate. And when do we give cryoprecipitate? When there is deficiency of these two clotting factors. Usually we give it in cases of hemophilia, or we can also use it in cases of von Willebrand disease. We can also use it in cases of PPH, that is postpartum hemorrhage as well. Okay? In multiple other conditions, it can be used. And 1 unit of cryoprecipitate contains 15 ml of clotting factors. It contains 15 ml of clotting factors. Very good, very good. Very good, Mohit. Very good, Vineet. Okay, all of you are right. Please remember, platelet concentrate or platelet-rich plasma is the only component of blood which is stored at room temperature. It is stored at room temperature. And what is that room temperature? It is between 20 to 24 degrees Celsius. It is between 20 to 24 degrees Celsius. And that is an important thing to be remembered. Okay? No issues with this. That has been a PYQ. Moving further now. Moving further, talking about the next important one-liners about blood donation. If I talk about blood donation, guys, definitely, if you need to transfuse blood, if you need to administer blood, हमें अगर किसी को blood चढ़ाना है, तो blood collect भी करना होगा. That process of blood collection is what is blood donation. ठीक है? Because blood cannot be prepared in the laboratory, it has to be donated always. So if I talk about blood donation, these are the important one-liners you need to be aware of. Now, first one that was asked was 1 unit of blood contains how much amount of blood? So that we have already discussed. 1 unit of whole blood contains around 350 to 450 ml of blood. 1 unit of whole blood contains around 350 to 450 ml of blood. Next, now while blood donation is done, during blood donation, a bigger needle is used. Okay, a bigger needle is used, definitely. And what is the size of that needle? Okay, what is? Yes, it is enough for FMGE. Most of the notes don't even cover these topics that I'm covering over here. Please remember that. Okay, most of the notes don't, and that is like I can assure you that. Okay, you can check in most of the notes, you will not find most of the things which are covered. Okay, I'm trying my best to cover each and everything in a very short span of time. Chalo. The size of needle which is preferred for blood donation, it is usually a bigger needle. Bigger diameter is required, and that is what is 16 gauge needle. It is a 16 gauge needle which is used. That was a PYQ. Next, which vein is preferred for blood donation? So you might have seen, if you have donated blood, that the big needle is inserted over here at the level of the cubital fossa, and that vein is what is your median cubital vein. The preferred vein for blood donation is your median cubital vein. It is the median cubital vein. Largest bore is definitely 14 gauge, but the preferred one is the 16 gauge needle that we use. Okay? And the preferred vein is the median cubital vein for blood donation. Next, now once we have inserted the needle, definitely we have a set or a tubing which is connected, and then via that tubing the blood will go and it is collected in a pre-sterile plastic bag. That pre-sterile plastic bag contains some amount of anticoagulants. So why do we require anticoagulants in the patient? Because if anticoagulants are not present in the plastic bag, definitely what will happen? The blood is going to clot. Okay, and we don't want the blood to be clot. Okay, so that's the reason why we have some anticoagulants in the pre-sterile plastic bag in which the blood is collected. The anticoagulants that we generally use is either called as CPD, that is citrate phosphate dextrose, CPD, or the another one that we have commonly is known as CPDA, that is citrate phosphate dextrose acetate. Okay, what is different in both of them? The basic difference between both of them is definitely the shelf life. Okay, shelf life is the duration. कितने टाइम तक जिंदा रहेगा ये anticoagulant. Okay, so CPD का shelf life, the shelf life of CPD that we need to know here, it is around 21 days, that is 3 weeks. The shelf life of CPD is around 21 days or 3 weeks. Okay, whereas if I talk about the shelf life of CPDA, it is around 28 to 35 days. It is around 28 to 35 days, that is around 4 to 5 weeks. So that's the important thing. Please remember, usually so blood can be stored in the blood bank for a period of around 35 days to maximum 42 days. Why? Because after 35 days the anticoagulants will be finished. Okay, and if the anticoagulants are finished in the blood bank, definitely the blood will start clotting. एक बार anticoagulants खत्म हो गए, blood का क्या हो जाएगा? Clot बन जाएगा. Therefore blood could not be stored for more than 1.5 months in the blood bank. That's the maximum. ठीक है? So what is the size of filter now? So what do I mean by the size of filter? A lot of times you might have seen in the hospitals as well that normally if we give fluids like ringer lactate or normal saline, they are given with a normal IV tube. Okay, they are given with a normal IV tubings or IV line. But if we need to give blood to a patient, we do not use a normal IV line, right? We do not use the normal IV line or the IV set. We need a specialized set, and that specialized IV set used for blood transfusion is known as the BT set. That specialized set used for blood transfusion is known as the BT set. Why it is special? Because it contains a filter. It contains this filter. Okay, and they are asking you the size of the filter. Okay, so the size of the filter which is present in the BT set, that filter is also known as leukoreduction filter. That filter is also known as leukoreduction filter, and if leukoreduction filter is used, the chances of transfusion reactions will go down. ठीक है, अगर leukoreduction filter यूज करते हो during blood transfusion, the chances of infections, transfusion reactions will go down. ठीक है, the size of filter you need to remember, it is around 40 microns. The size of filter used in a BT set is around 40 microns. Next, if I talk about the temperature of storage, so the blood when it is collected, then the blood bag is stored at what temperature? So important is the blood bag is usually stored at plus 4 degrees Celsius. So the blood bag is usually stored at plus 4 degrees centigrades. That's important. Plus minus 2. That means if they ask you the range, it will be between 2 to 6 degrees Celsius. So yaad rakhna, if you need to answer best, definitely the single best answer will be plus 4 degrees centigrades. But if they ask you the range, it is between plus 2 to plus 6 degrees centigrades. Please remember that. Okay. Next, if they ask you what is the shelf life of RBC, shelf life is nothing but the duration or the lifespan. So the lifespan of RBC is normally, we know the lifespan of RBCs within the body is how much? The lifespan of RBCs within the body is around 120 days. The lifespan of RBCs within our human body is around 120 days. But if they ask you the lifespan or the shelf life of RBCs in a stored blood, if they ask you the lifespan or the shelf life of RBCs in a stored blood, it is as low as 24 to 72 hours. When the temperature of the blood is not maintained. So important is, why do you need to maintain the temperature of the blood? Otherwise, if you do not maintain the temperature of blood between this 2 to 6 degrees centigrades, the RBCs will start undergoing destruction. RBCs क्या होने लगेंगी? खत्म होने लगेंगी. That means hemolysis is going to occur. Okay, so usually if the blood temperature is not maintained, it will only live up to around 24 to 72 hours. Maximum it can live up to around 42 days if the temperature is maintained. ठीक है, उससे ज़्यादा नहीं. And if they ask you the shelf life of RBCs in a transfused blood, if they ask you shelf life of RBCs in transfused blood, please remember, then your answer should be around 50 to 60 days. In a case of transfused blood, the shelf life of RBC will be around 50 to 60 days. Okay, so that is the important thing you need to remember. Next is, what is the most common complication of blood transfusion? Okay, what is the most common complication of blood transfusion? So the most common complication of blood transfusion is usually a transfusion reaction. The most common, don't worry, we will discuss what transfusion reactions are. The most common complication of blood transfusion is a transfusion reaction. There will be some kind of reaction which will occur after transfusion. कोई ना कोई reaction होगी patient में एक बार blood चढ़ा दो तो. That is what is a transfusion reaction. They can be of various types. So you need to remember the basic term, that is transfusion reaction. Now, important question which has been asked in the recent FMG as well as neetpg examination, and the question was, when the blood is collected, it is screened for all of the following diseases except, and that was the question. So now we need to remember that for which of the following diseases or for which of the following infections we are going to screen the blood after collecting it. So once we have collected the blood, we are going to screen it for which particular diseases or which particular infections. Are you going to screen it for measles? Are you going to screen it for polio? Please let me know that. Okay. So please let me know that. Jaldi se. Are you going to screen it for measles or are you going to screen it for polio? Jaldi se. Let me know in the chat box. Are you going to screen it for hepatitis A, Vineet? Are you going to screen it for hepatitis A? So important is measles, as I've told you. Measles spreads by which route? Measles spread by respiratory route or air droplet route. Okay. Next is polio. Polio spreads by which route? It spreads by fecal-oral route. And I hope all of you are quite aware that hepatitis A and hepatitis E, both of them also spread by fecal-oral route. So if they spread by fecal-oral route, do we need to check or do we need to screen the blood? No, definitely no screening is required if the infection spreads by respiratory or air droplet route or if the infection spreads by fecal-oral route. We only require screening for those kind of infection or those kind of diseases where there is a risk of spread from the blood route or from the hematogenous route. ठीक है, जो infections खून से फैल सकते हैं उनके लिए screening करो बस. And what are those infections? Definitely the most important one being HIV. We screen the blood for HIV-1 as well as HIV-2, both of them. Second one is definitely hepatitis B. Okay, because it spreads by blood route. Next is hepatitis C. Okay, next is important is hepatitis C. The next one that you need to remember is malaria, because definitely malaria can also spread via blood. Okay, because we know the active or the infective forms can be there. Okay, so that's important. And definitely in some countries or in some blood banks, they also screen for the fifth infection or the fifth disease, and that is what is syphilis. Not all blood banks will screen for syphilis, but yes, if they ask you now, which among the following infections do we screen before blood transfusion? All of the following except. So options are hepatitis A, hepatitis B, hepatitis C, and syphilis. Here you know, now the best answer is hepatitis A because it does not spread via blood route. So no screening should be done before blood transfusion for hepatitis A. Great. So that was a previous year question. You need to remember these important infections for which screening is done before blood transfusion. Chalo. Great. Next is talking about the transfusion reactions. If I talk about the transfusion reactions, as I've told you, it is the most common complication after blood transfusion. Which is the most common transfusion reaction you need to remember? So the most common transfusion reaction, and a lot of people are not aware with this name. That name you need to remember, it is FNHTR. What do I mean by FNHTR? In simple terms, FNHTR is nothing but the full form is febrile non-hemolytic transfusion reaction. So they will play with you with this term definitely, right? Because it is a fancy term. So important is you need to remember the most common transfusion reactions which occur after blood transfusion is FNHTR. That means nothing else but febrile non-hemolytic. Non-hemolytic matlab RBC destruction is not occurring. There is no hemolysis. कोई RBC destruction नहीं होता है. Only it is a febrile reaction. What do I mean by febrile? Febrile का मतलब होता है fever. Febrile means fever. Okay. So febrile non-hemolytic transfusion reaction, also known as simple febrile reaction or simple pyrexial reaction. So that can be the option, or usually they give this option in the choice, that is febrile non-hemolytic transfusion reaction. You need to remember this properly. No issues with this, anybody? That's the important thing to be remembered. Okay, so usually that's the reason why once we have started blood transfusion in a patient, we ask the patient after every now and then, do you feel any fever? Are you feeling feverish? That's the important thing, because the most common transfusion reaction after blood transfusion is fever. Next transfusion reaction is severe one. Fever was a mild transfusion reaction, but a severe form of transfusion reaction is that is ABO incompatibility. What do I mean by ABO incompatibility? So ABO incompatibility is also known as mismatched BT or a mismatched blood transfusion. ABO incompatibility is also known as mismatched BT or mismatched blood transfusion. That's important. Okay, so mismatched blood transfusion means, what do I mean by this? So if a patient was having a blood group A positive, if a patient was having blood group A positive, and you have given which blood to the patient? You have given the blood which was B positive. You have given him a blood which is B positive. What can happen now? As the patient is A positive, I hope all of you are quite aware. This A positive blood group is decided by the antigens which are present on the surface of the RBC. जो antigens RBC के surface पे होती है, उससे decide करते हैं patient का blood group A होगा, AB positive होगा, B positive होगा या O positive होगा, whatever it is. Okay, so definitely these surface antigen in a case of A positive blood group is usually a antigen. And if a patient is having A antigen on the surface of RBCs, what antibodies will be present in him? The patient normally has B antibodies in his blood. Now you are giving a B positive blood group. And the B positive blood group is having which type of RBCs? The RBCs which are having B antigen on their surface. As soon as you give B positive blood to a patient who is having a A positive blood group, all these B antibodies which are present in the patient are going to target these antigens. All these B antibodies which are present in the patient's blood are going to target these RBCs which are having a B antigen on their surface. तो जितने भी तुमने RBCs दिए पेशेंट को नए ब्लड में, वो सब क्या होना शुरू होंगे? खत्म होना शुरू होंगे. There will be excessive hemolysis in the patient, and that is what is called as your ABO incompatibility or a mismatched blood transfusion. Please remember. No issues with this, anybody? So I'm using everything, don't worry about that. I am trying to use each and everything English और हिंदी दोनों में समझा रहा हूँ. ठीक है, जो भी टॉपिक नहीं समझा प्लीज आस्क मी. ओके, पायरेक्सिया मीन्स फीवर. पायरेक्सिया in simple terms means fever, बुखार. So ABO incompatibility is also known as mismatched blood transfusion or mismatched bleeding. Please remember that. Okay, and we know how it has happened now. So usually ABO incompatibility or mismatched bleeding is usually which type of transfusion reaction? Mainly if you need to answer single best, because some amount of histamine is also released and some kind of anaphylaxis is also seen. But better answer अगर दोनों में से कुछ करना है, type 1 और type 2 में से, so answer should be a type 2 hypersensitivity reaction. Okay, so please remember you have completed your patho. So please remember ABO incompatibility or a mismatched blood transfusion is which type of hypersensitivity reaction? It is a type 2 hypersensitivity reaction. Next is, what is the most common cause of ABO incompatibility? So the most common cause of ABO incompatibility, you need to remember, is usually a clerical error. That means we made some mistake. Okay, yes, the healthcare professionals, हमारे से कोई गलती हुई है. ठीक है, so definitely there was some mistake while collecting the blood or while naming the blood, okay, or while checking the blood group or while doing a cross matching. So definitely you were not wrong. You said that we want a A positive blood. But what happened in the blood bank, the technician who was there, he gave you the B positive blood. And then after that, what did you do? You administered the B positive blood without checking twice. And that has caused the ABO incompatibility. That is what we mean by clerical error. हमारी गलती हुई है. ठीक है? Most common symptom is usually, most common symptom after a mismatched blood transfusion or after a ABO incompatibility, you need to remember, usually here the patient, symptom is what the patient will complain of. Sign is what that we will examine as an examiner or a clinician. Symptom तुम्हें patient बताएगा, complaint जो होती है वो symptom होता है, जो तुम देखोगे that is what is a sign. The most common symptom you need to remember is usually pain and heat sensation along the vein. The patient will have pain and heat sensation along the vein. जहां से तुम ब्लड चढ़ा रहे हो वहां पे पेशेंट को पेन एंड हीट सेंसेशन फील होगा. ठीक है, व्हाट इज द मोस्ट कॉमन साइन नाउ? As an examiner, what is the most common sign? Definitely, if there is a mismatched blood transfusion, all of these antigen antibody complexes which are formed, these antigen antibody complex जो बनेंगे, all of these antigen antibody complexes or immune complexes, they will go to the kidneys. They will go to the kidneys and they will block the small capillaries of the kidneys known as glomerulus. तो वो क्या कर देंगे? All these antigen antibody or immune complexes will block the small capillaries of kidneys, and that will cause decreased urine output. And decreased urine output is what is called as oliguria. So oliguria in simple terms is decreased urine output. कम यूरिन आने लगेगी पेशेंट में. So oliguria is less than 400 ml per day of urine output. That will be seen. If that is not an option, the second best answer will be hemoglobinuria. The second best answer is hemoglobinuria. You will see a dark or a red colored urine in the patient. Dark brown or a red color urine can be seen in the patient. Okay? If that is not an option, then you need to mark it as tachycardia. Next is, what is the most common sign in an anesthetized patient? In an anesthetized patient, if they ask you, then it is generalized oozing of blood. So anesthetized patient, that means we are operating on the patient. हम surgery कर रहे हैं patient की. So therefore he is under anesthesia. So if most common sign of mismatched blood transfusion is usually generalized oozing of blood. While you are performing a surgery, you will see that blood is coming out from all the vessels. Okay, so that is what is a sign, important sign in a case of anesthetized patient of a mismatched BT or of a ABO incompatibility. What should be the treatment? Definitely, what should be treatment? तुम गलत blood चढ़ा रहे हो. You are transfusing wrong blood to the patient. Immediately stop the BT. Okay, so first line management will be immediate termination, or you can say immediately stop the BT. Immediately stop blood transfusion in the patient. And then to avoid further any complications in the patient, definitely you need to give 3 important drugs to the patient. Okay, the first one, definitely you need to give injection of steroids. And the preferred steroid that we use, that is what is a hydrocort or hydrocortisone. Okay. Second drug that we usually give in the patient is Avil. And Avil you might have heard a lot of times. So Avil is nothing else but antihistaminic drug. Because as I've told you, there will be a release of histamine also in cases of ABO incompatibility. Okay? So due to that, we will give also antihistaminic drug known as Avil. That is known as phenyramine. The generic name is phenyramine. And the third one that we give is usually diuretics. Why? Because the most common sign was oliguria or decreased urine output. That's the reason why we need to increase the urine output by giving diuretics in the patient. And once you have done that, please send all the blood back, all the tubings with which you are transfusing the blood, okay, and the blood sample of the patient immediately to the blood bank and ask the technician for regrouping and recross matching. Okay, ask the blood bank technician for regrouping and cross matching. Okay, तो जितने भी ब्लड बैग थी, जो भी ट्यूबिंग्स थे, एंड डेफिनेटली ब्लड सैंपल पेशेंट का निकालो और वापस से लैब में भेजो एंड आस्क द टेक्नीशियन टू रीग्रुप एंड क्रॉस मैच इट. Next is massive BT or massive blood transfusion. If I talk about massive blood transfusion, what do I mean by massive blood transfusion? The definition says replacement of whole blood volume. Okay, and how much is around whole blood volume? It is around 5 liters to 6 liters maximum. Okay, so how much units will be 5 liters? It will be around approximately 10 units. So either the definition of massive blood transfusion will be replacement of whole blood volume और ट्रांसफ्यूजन ऑफ 10 यूनिट्स विद इन अ स्पैन ऑफ 24 आवर. तुमने 24 घंटों के अंदर अंदर पेशेंट का पूरा ब्लड वॉल्यूम रिप्लेस कर दिया या 10 यूनिट्स चढ़ा दिए ब्लड के. दैट इज व्हाट इज मैसिव बीटी. ओके, रिप्लेसमेंट ऑफ होल ब्लड वॉल्यूम और ट्रांसफ्यूजन ऑफ 10 यूनिट्स विद इन अ स्पैन ऑफ 24 आवर्स. और द अदर definition can be replacement or transfusion of 4 units of blood within 1 hour. Okay, replacement or transfusion of 4 units of blood within a span of 1 hour. Yes, normally 1 unit takes 4 hours. Okay, recommended time for transfusion of 1 unit of blood is around 4 hours. We should give blood transfusion at a very slow rate. Okay, so it usually 1 unit of blood should be transfused in a span of 4 hours. But if we are giving 4 units in a span of 1 hour, when do we require such a massive blood transfusion? Usually when a patient is having excessive or a massive blood loss. In cases of trauma, when the patient is in hypovolemic shock. जब पेशेंट हाइपोवॉलेमिक शॉक में है, जब बहुत ज्यादा ब्लड लॉस हो रहा है पेशेंट में, एट दैट टाइम वी नीड मैसिव ब्लड ट्रांसफ्यूजन. ठीक है. Next is you need to give all of these things. You need to give PRBC, that is packed RBCs to the patient. You need to give FFP, that is fresh frozen plasma to the patient, and you need to give PRP, that is platelet rich plasma to the patient. Why now? You will say, sir, PRBC का तो समझ में आया. We understood why PRBC is given in a case of blood loss. But why are we giving FFP and PRP to the patient separately? The reason is, please remember, if you only give PRBC to the patient, if you are only giving PRBC to the patient, you will cause hemodilution. What will happen? There will be dilution of the blood because you are only giving PRBC. Is it containing, does it contain clotting factors? No. Clotting factors are very minimal in a case of PRBC. Packed RBCs में clotting factors almost नहीं होते, nil के बराबर होते हैं. So what will happen? There will be hemodilution. There will be dilution of blood. Dilution of blood, that I mean there will be very less amount of clotting factors. And if there are very less amount of clotting factors, definitely the bleeding of the patient will stop or it will increase. If there is less amount of clotting factors, clot will not be formed. And if clot is not formed, definitely the bleeding of the patient will increase further. Okay, and that is what is called as coagulopathy, one of the deadly complications in a case of trauma, and that is what is coagulopathy or DIC, that is disseminated intravascular coagulation. So the patient can land up in coagulopathy if you only give PRBC to the patient. That is the reason why we need to give 3 components, PRBC, FFP and PRP, and they should be given in a ratio of 6:6:6. So if we need to give massive blood transfusion, we need to give 6 units of PRBC, 6 units of fresh frozen plasma, and 6 units of PRP. Fresh frozen plasma and PRP are generally given to prevent any coagulopathy, कि ज़्यादा bleeding ना हो patient में. Okay, so that's important. Now if they ask you what is the most common complication of a massive blood transfusion, you are giving so much amount of blood to the patient in a very short duration of time. इतना ज़्यादा blood बहुत कम समय में दे रहे हो patient को. So what can be the most common complication? The most common complication usually is known as CHF. What do I mean by CHF? Congestive heart failure. What is congestive heart failure? Excessive amount of blood is given to the patient. Excessive load, excessive volume load is given to the patient. Okay? So if there is high volume or there is a volume overload in the patient, that will land up the patient into congestive heart failure. तुमने इतना ज़्यादा खून चढ़ा दिया patient में, you have given so much amount of blood to the patient that his heart is not able to handle this much excess amount of blood, and therefore the heart is not able to pump. And if the heart fails to pump, that is what is called a CHF, congestive heart failure. Due to excess of volume of blood, the heart fails to pump. That is what is CHF. Is it seen in every patient? No. Volume overload will only be seen in patients who are not able to handle excess amount of volume of blood, and that is usually anemic patients or elderly patients. That is usually anemic or elderly patients, because their body or their heart will not be able to handle excess amount of blood. Okay. Another complications you need to remember. Now definitely we know blood is stored at how much degree temperature? It is stored at plus 4 degree centigrades. But important is, can we give directly the blood directly to the patient? No, we cannot give blood directly at 4 degrees centigrades. Why? Because if you give a cold blood to the patient, definitely the patient will land up into hypothermia. Normal temperature of our body is how much? The normal temperature of our body is 37 degrees centigrades or 37.5 degrees centigrades to be specific. If you are giving blood which is at 4 degrees centigrades, इतना ठंडा खून चढ़ाओगे, the patient is going to land up into hypothermia. That will not be seen usually. Please remember, that will not be seen when the patient is having sorry, that will not be seen when you need to only transfuse 1 unit of blood या तुम्हारे पास time है. When you have enough time in your hands, you can properly warm up the blood. And how is warming of blood done? Warming of blood is done by wrapping up the blood bag into a blanket. You wrap up the blood bag in a blanket and you keep it usually for a span of half an hour. The recommended time for warming of blood is usually half an hour. You should not warm the blood for more than 2 hours. Why? Because if you warm the blood for more than 2 hours, the patient is going to land up into infections. Because if the temperature of blood increases too much, definitely the bacterial activity increases and the patient will have a lot of infections. But hypothermia kab hoga? When the warming is less than half an hour. When the warming of blood is done for less than half an hour, definitely the patient can land up into hypothermia. And when is hypothermia commonly seen? In a regular blood transfusion or massive blood transfusion? Definitely in a case of massive blood transfusion, it is commonly seen. Why? अगर तुम्हें इतना सारा खून चढ़ाना, if you need to transfuse so much of blood, will you have enough time in your hands to warm every blood bag? No. So a lot of time what happens, we don't let every blood bag to warm. And therefore, a lot of times the patient can land up into hypothermia. Okay, so if warming is done for less than half an hour, the patient will definitely land up into hypothermia. There can be other complications as well. I'm just enumerating it. Important is, there will be excess destruction of RBCs. And due to excess destruction of RBCs, what is present? Which ion is present within a cell or within the RBC? Potassium. So if there is excess hemolysis, excess destruction of RBC, all this potassium is going to be released into the blood. ये पूरा का पूरा blood कहाँ जाएगा? बाहर जाएगा. That means definitely the patient will have hyperkalemia as well. The patient will have increased potassium values in the blood. That is called as hyperkalemia as well. And that can lead to arrhythmias in the patient as well. That will lead to arrhythmias in the patient. Okay? Apart from that, only potassium is the ion which will increase. Okay, only potassium is the ion which increases. Otherwise, the patient has hypocalcemia, the patient has hypomagnesemia, the patient has hypophosphatemia. Why? Because all of these ions will decrease in amount because they are going to bind to the citrate. And where was citrate? Citrate was present in the anticoagulant. So that all these ions which are there, calcium, magnesium, phosphate, they are going to bind to that citrate or to that anticoagulant. Therefore, their values are going to go down definitely. Only one that increases is potassium. Please remember that. No issues with this, anybody? Important. After a massive blood transfusion, two important questions I'm going to ask you. After massive blood transfusion, First case number 1, after a massive BT, the patient is complaining of respiratory distress. The patient is having increased jugular venous pressure. The patient is having edema throughout the body. The patient is having facial edema. The patient is having pedal edema as well. मतलब swelling है उसके आसपास, चेहरे के आसपास, पैरों में भी swelling है, JVP उसकी बढ़ी हुई है, and the patient is having respiratory distress. What is your diagnosis in this condition, anybody? What is your diagnosis? A patient complains of all of these symptoms after massive BT. What is the complication that you are suspecting? Anybody? Answer it. Definitely, it is not cardiac tamponade. It is CHF, but very good. CHF that occurs after massive blood transfusion. CHF that occurs after massive blood transfusion. Cardiac tamponade can occur after injury usually, or when there is massive pericardial effusion. ठीक है? I have not given you any signs of cardiac tamponade as such. Cardiac tamponade में the patient's blood pressure goes down. Okay, there is also muffled heart sounds. I did not mention about any muffled heart sounds. No, I did not mention about the complete Beck's triad. No. Yes, not only right-sided, but also the left-sided heart failure. No? Right-sided heart failure you have suspected because the patient was having facial edema and pedal edema. Okay, and raised JVP. But I also mentioned one thing about left ventricular failure, and that was respiratory distress. Because there was pulmonary edema in the patient was having respiratory distress. So it is definitely a CHF, that is congestive heart failure. So a CHF which occurs usually after massive blood transfusion, it is usually TACO. And that TACO is what is called as transfusion associated circulatory overload or transfusion associated cardiac overload. And the treatment for TACO we know now, the treatment for TACO should be diuretics in the patient because there is excess of volume inside your body, excess of blood volume you have given to the patient. You need to get rid of that excess blood. Okay, तुम्हें वो ज़्यादा volume है ना वो बाहर फेंकना है. That is what is done by diuretics. Next important question that I want to ask you. A patient after a massive blood transfusion now is only complaining of severe respiratory distress and maybe his saturation is falling down. A patient after a massive blood transfusion is only complaining of severe respiratory distress. His saturation of oxygen is falling down and the X-ray, the chest X-ray is usually showing ARDS-like features. Okay, that is ground glass opacities in both the lungs. Okay, the chest X-ray is showing ARDS-like features. That is, hopefully I'm audible to all of you. ARDS-like features are seen. Okay, so what is your diagnosis now? Answer it faster. What should be your diagnosis now? Only respiratory distress, saturation is falling, and chest X-ray showing ARDS-like picture. Not left heart failure usually. Left heart failure mein, there will not be a ARDS-like picture. There will be patchy infiltrates. Pulmonary edema causes patchy infiltrates. और मैं बता रहा हूँ कि पूरे के पूरे lungs सफेद पड़े हुए हैं. The whole lungs are white. Very good. It is lung injury beneath. Very good. And that lung injury is called as TRALI. That is called as TRALI, transfusion related acute lung injury. Very good. Transfusion related acute lung injury. So two things that will help you differentiate a TACO and TRALI. TACO mein the patient, two things that will help you differentiate both of this. First is the chest X-ray and second is your BNP levels, that is B-type natriuretic levels. Okay, so chest X-ray will show cardiac enlargement in cases of TACO, but there will be a normal cardiac shadow in cases of TRALI. Second is BNP levels. BNP levels are elevated in cases of TACO because it is a CHF, but BNP levels are normal in cases of TRALI. So that's the important thing. Okay, and if there is acute lung injury, definitely we need to give ventilation to the patient. In ARDS, do we give high volume ventilation or a low volume ventilation? Low volume. Why? Because the lungs are already injured. Will you like to injure the lungs more by giving high pressure ventilation? No. We will give low volume ventilation. That means oxygen is given to the patient, but at 6 liters per minute, not at around 12 to 15 liters. Okay, we will give low volume ventilation to the patient. Okay, so that's the important thing. Chest X-ray and BNP levels will help you differentiate between both of these. Okay, now moving further, now talking about, once we have done with the blood transfusion, now talking about surgical positions. If I talk about important surgical positions, guys, if I talk about important surgical positions, I am doing shock after this. Okay, shock thoda baad mein hoga, don't worry about that. I'll talk about shock properly. Now if I talk about surgical positions, guys, so these are important surgical positions. Yes, yes. Trally is due to anti-HLA antibodies. So this first surgical position, that is position number A, here you can see the OT table, the foot end and the head end are both at the same level. Okay, and the patient is facing upwards. This is what is called as the supine position. And we know supine position is the most common position during a surgery. Supine is the most common position during a surgery. Important. Okay, for all abdominal surgeries or breast surgeries, you will prefer this position, that is your supine position. Okay, for all abdominal and breast surgeries, you prefer this position. No issues with this, anybody? Next one that you can see, this has been asked to you in the examination. The foot end of the OT table is elevated. The foot end that is elevated. The foot end of the OT table is elevated, and this position is known as the Trendelenburg position. This position of surgery is known as the Trendelenburg position. And we know Trendelenburg position is usually preferred for which kind of surgeries? Trendelenburg position is generally preferred for pelvic surgeries. Why? Because as the foot end is elevated, all the blood flow will go towards the upper part of the body. पूरा का पूरा blood flow कहाँ जाएगा? Upper part of body पे. So usually in the pelvis there will be less amount of blood, and therefore you will get a better surgical view, or you will get a better exposure. तो पूरा blood flow अगर ऊपर की तरफ जा रहा है, तो pelvis will be somewhat blood free, and you will get a better view or a better exposure during surgery. ठीक है? That is what is the Trendelenburg position. Next, the C position that we have. Here you can see the head end of the OT table is elevated. And if the head end of the OT table is elevated, it is completely opposite to that of the Trendelenburg. Therefore, the type C position is known as reverse Trendelenburg position. It is known as the reverse Trendelenburg position. Okay? And reverse Trendelenburg position mein, the blood flow is going towards the lower limbs. Okay, the blood flow is mainly going towards the lower limbs. Therefore, if we need to operate on the abdomen of this patient, like in a case of lap cole. What is lap cole? Sorry, usually in the cases of open cole, that is open cholecystectomy. Okay, that means removal of your gallbladder. Okay, so in that surgery, open cholecystectomy, we can prefer this reverse Trendelenburg position. Lap cole we prefer a supine position itself. No issues with this, anybody? Usually, or for any breast reconstruction surgery, for that also we can prefer this reverse Trendelenburg. Next is this position, which is very important from exam point of view. This has been asked already in the exam. And this important one, you can see there is flexion at the hip, there is flexion at the knee joint. And second, there is abduction of the hip and abduction of the knee joint as well. What is abduction? Outward movement. So please remember, there is flexion at the hip joint, flexion at the knee joint. And there is abduction or outward movement. This is what is called as the lithotomy position. This is what is known as the lithotomy position. So this has been asked earlier in the examination. And we know lithotomy position is generally used for with surgeries. So definitely it is commonly used during a normal vaginal delivery. Okay? So usually it is used for any obstetric and gynecological procedures. It is generally used for OBG, that is obstetric and gynecological procedure. It is also used for some perineal surgeries. It is also used for some perineal or some urological surgeries. So for perineal or urological surgeries, you prefer this lithotomy position. What is the complication of this lithotomy position? If there is over abduction, over abduction of the leg, what will happen? Here we have a nerve laterally in the leg. Okay, at the level of knee or in the leg, we have a nerve over here. That nerve can get injured. And what is that nerve? That is what is your CPN, that is common peroneal nerve. So if they ask you what is the complication of lithotomy position, your answer should be common peroneal nerve injury. And we know if the common peroneal nerve is injured, definitely the patient is going to suffer from a foot drop. The patient will have a foot drop. Next is these three positions, the E, the F and the G. All of these are variants of the same position. These positions are known as the lateral position, or they are known as the kidney position. These positions are known as lateral or kidney. Why kidney position? Because you can see we get a better access to the kidney in the lateral position, and therefore operating on kidney becomes much easier. Okay, so lateral or kidney position definitely will be much easier. Okay, so lateral or kidney positions are preferred for which type of surgeries? Here you can see you are getting a better access to the thoracic cavity and better access to the kidney. So that's the reason why this is generally used for thoracotomy. We will generally prefer it for thoracotomy surgeries, or we can prefer it for pyelolithotomy surgeries. That is nephrolithotomy. Kidney surgeries you can just remember. So thoracotomy, pyelolithotomy or nephrolithotomy surgeries, we prefer this lateral or kidney position. Next one is this, the H1. What is important over here? In this H position, you can see, guys, over here, the patient is facing downwards and the foot end and the head end of the OT table are both at same level. This is what is called as the prone position. If you are facing upwards, that is supine. If you are facing downwards, that is what is prone. तो उल्टा अगर पेशेंट लेटा है, that is what is a prone position. And prone position, you are getting better access to the back of the patient and to the buttocks of the patient. Therefore, prone position is preferred for which surgeries? Prone position is generally preferred for spinal surgeries. Prone position is preferred for spinal surgeries. And second one, it is also preferred for a pilonidal sinus surgery. Pilonidal sinus is usually seen in buttocks, that we'll study further. So pilonidal sinus surgery के लिए भी we prefer the prone position. Okay, no issues with this. The last position that you need to remember over here in this table is what is the sitting position. Yes, sitting positions can also be used during surgery. This sitting position, you need to remember the name of this position. Sitting position during surgery is also known as the Fowler's position. So sitting or Fowler's position are generally used for, you can see all the blood flow will be going towards the lower part of the body. So which part of the body will be blood free? It will be the head or the cranial cavity. Therefore, for cranial surgeries or for neurosurgeries, sometimes we can prefer the sitting or Fowler's position. What is the complication with this position? Here in this position, there will be high risk of air embolism. There will be high risk of air embolism in this position. Okay? So that is the important risk factor. You need to remember that has been a PYQ in neetpg examination. Okay? Which position will have high risk of air embolism? You know it is the sitting or the Fowler's position. Next two important positions which are important from FMG point of view as well as the neetpg point of view. So these are two positions. The first one that you might have seen a lot of times and number of times. Okay? You can see a towel roll is placed beneath the shoulder of the patient. Okay, a towel roll is placed beneath the shoulder. Towel roll place किया जाता है shoulder blades के नीचे. And here you can see why towel roll is placed for two important things. There should be extension at the neck joint. Neck joint is the cervicothoracic joint. So extension at the neck or the cervicothoracic joint, first thing. And second, extension at the atlanto-occipital joint. Atlanto-occipital means the joint between the base of the skull and the first cervical vertebra known as atlas. Okay, so extension of the cervicothoracic joint and the atlanto-occipital joint. Okay, so that you get a better exposure to the neck of the patient or better exposure to the oral cavity of the patient. So usually this is known as the rose position. This classically is known as the rose position, and we know rose position is preferred for three important surgeries. And what are these three surgeries? First one is called as the thyroid surgery because you are getting better access to the neck. Second one is what is tonsillectomy. Both of these are ENT surgeries now. Second one is tonsillectomy, and the third one is adenoidectomy. Adenoids are nothing but the nasopharyngeal tonsils, and when you remove that is called as adenoidectomy. So thyroid surgery, tonsillectomy and adenoidectomy, we prefer the rose position. Important is now when there is extension at the neck joint and there is extension at the atlanto-occipital joint, what will happen? This cervical vertebra, the first cervical vertebra known as atlas, is a ring-like vertebra, and the second cervical vertebra known as axis, both of these connect like this, right? This is the dense of the axis. Both of these connect like this. And if there is hyperextension, ज़्यादा ही extension हो जाता है, ज़रूरत से ज़्यादा. If there is hyperextension of the neck during the surgery, what will happen? This first and second cervical vertebra can dislocate. Will they dislocate completely? No. There is a partial dislocation of the C1, C2 joint. That is the atlanto-axial joint. And this syndrome, you need to remember, is known as the Grissel syndrome. So if they ask you what is the complication associated with rose position, that has been asked previously in exam, and that is what is known as Grissel syndrome. So what is Grissel syndrome? It is nothing but subluxation. And what do you mean by subluxation? It is partial dislocation. So it is subluxation of the C1, C2 joint or the atlanto-axial joint. Okay. Subluxation of the C1, C2 or the atlanto-axial joint is a Grissel syndrome, and it is a complication of rose position during surgery. Next important is this position. What is this position called as? This is classically known as the jackknife position. This is known as the jackknife position. Now, jackknife position was used in earlier days. For which surgeries? You can see there is a better access to the buttocks of this patient. Therefore, this jackknife position was commonly preferred for hemorrhoids. So, for hemorrhoidal surgeries, we used to place the patient in this jackknife position. What is the problem with this jackknife position? क्या problem हो सकता है jackknife position में? All these abdominal organs are pressing against the diaphragm. These abdominal organs are pressing the diaphragm. So will the patient be able to respire properly? No. Will their lungs be able to expand properly? No, because the diaphragm is compressed by all the abdominal organs. Therefore, the patient will have asphyxia. That is, दिक्कत होगी सांस लेने में. That is what is asphyxia or respiratory distress. And due to a specific position as the patient is having asphyxia, that is what is called as positional asphyxia. Okay. So please remember what was the complication associated with this jackknife position. The patient was suffering from positional asphyxia. and that's the reason why this position is obsolete. That means not used nowadays for any type of surgery. Okay, that's important. Chalo. Done with all the surgical positions. Now talking about the next one, and that is what is your IV lines. Okay, a overlap topic between anesthesia and surgery. If I talk about the IV lines or the cannulas, if I talk about the IV lines or the cannulas now, so they are preferred for administering fluid, for administering blood or any type. Okay, when we need to get an access to the veins of the patient, we will insert this cannulas, gelcos they are also called as, or we will insert this IV lines. Now important is you need to remember starting from the earth's crust till the ozone layer, you need to remember the layers now. Okay, so that will tell you about the color of the cannula. Okay, so now starting with the 14 gauge cannula. What is gauge? A lot of people are still confused. So please remember, gauge is nothing but the size of cannula or the size of a needle. Gauge is nothing but the size of cannula or the size of a needle. Important you need to remember is the gauge of the cannula, the number of the gauge is inversely proportional to the diameter of the cannula. Okay, what is the diameter? The bore. Okay, so please remember the number of the gauge is inversely proportional to the diameter. What do I mean by this? If the number of the gauge increases, the diameter of the cannula decreases. जैसे जैसे तो number of gauge बढ़ाओगे वैसे वैसे diameter of the needle or the diameter of the cannula will keep on decreasing. It will keep on narrowing down. That you need to remember over here. Okay? So as the number of gauge increases, the diameter of the cannula decreases. Therefore, 14 gauge cannula will be the widest bore cannula or the widest diameter wala cannula. Okay? 14 gauge will have widest bore or widest diameter. Whereas the 26 gauge cannula will have the narrowest bore or the narrowest diameter. The 26 gauge cannula will have the narrowest bore or the narrowest diameter. No issues with this, anybody? That's important. Now, if I talk about the Earth's crust, what is present in the Earth's crust? It is the lava. And lava is which color? Orange. Therefore, the 14 gauge cannula is orange color. The 14 gauge cannula is orange color. Then what is there? We have the soil or the land. Land is generally which color? It is grey color. So, the 16 gauge cannula will be grey color. 16 gauge cannula is grey in color. Next is what lies above the soil or the land? We have the grass and the trees. And grass and the trees are which color? Grass and the trees are definitely green in color. So that is what is your 18 gauge cannula. Grass and the trees are green in color, and the green cannula is 18 gauge in size. Next is the 20 gauge cannula. What lies over the trees? Trees pe kya hota hai ya grass pe kya hota hai? Flowers. Okay. The flower you need to remember, it is pink in color. So the 20 gauge cannula is how much? The 20 gauge cannula is pink in color. Next we have the sky above. And sky is which color? Sky is definitely blue in color. So the 22 gauge cannula is blue in color. Next we have the sun. Sun is which color? Definitely the sun is yellow in color. So the 24 gauge cannula is yellow in color. And the last one you need to remember, ozone. I'm not saying the ozone is violet in color, but to remember it is easy. Okay. So ozone you need to remember, the ozone is usually violet in color or it is purple in color. Okay. The ozone is violet or purple in color. No issues with this, anybody? Now I'll just explain it to you about three. See, yellow and violet a lot of people easily remember. Grey and orange also a lot of people easily remember. There is confusion between 18, 20 and 22 gauge a lot of times. So now one thing that I'm saying, you need to follow it properly. Okay? Now once you are 18 years old, you will enter into your college. And once you enter into your college, you will see greenery everywhere. हर तरफ क्या दिखती है फिर? हरियाली. तो 18 साल के होते हो तो हर तरफ हरियाली दिखती है क्योंकि कॉलेज में जाते हो. So once you enter your college, you will see greenery everywhere, and that is how you need to remember 18 gauge cannula is green in color. After 2 years of college life, you will fall into love. And जैसे ही you will fall into love, definitely everywhere you will see, okay, हर तरफ क्या दिखाई देता है? गुलाबी गुलाबी दिखने लगता है. Okay, everywhere you will see that love or hearts are coming, and all of those are pink in color. So once you are of 20 years old, definitely you will fall in love, and that will be pink color. Next is definitely once you have 2 years of relationship, you will get frustrated, okay, or the girl will leave you, and then definitely what will happen? Okay, Hindi mein we say आसमान में तारे दिखाई देते. Okay, so definitely आसमान or the sky is which in color? That is blue in color. That's how you need to remember it. ठीक है, तो ऐसे याद रखना है, important. ठीक है, so these three can be remembered easily. Important is orange has the widest bore or grey has a wider bore. So usually what is the flow rate? They don't ask you about other cannulas, but they can ask you about these two. So orange has a flow rate of 240 ml per hour. Okay, whereas grey has a flow rate of around 180 ml. Okay, grey has a flow rate of around 180 ml. No issues with this, anybody? That's important. Now grey and orange cannula generally will be used for, grey and the orange cannula generally will be used for what? प्लीज रिमेंबर व्हेन वी रिक्वायर मोर अमाउंट ऑफ फ्लूइड, जब ज्यादा फ्लूइड चढ़ाना है पेशेंट को, तब हमें बहुत ज्यादा फ्लूइड, बहुत ज्यादा बड़े वाले कैनुलास यूज करने पड़ेंगे. देयरफॉर व्हेन वी नीड टू गिव अ लॉट ऑफ फ्लूइड टू द पेशेंट, वी प्रेफर द वाइडर बोर और वाइडर डायमीटर वाला कैनुलास, दैट इज ऑरेंज एंड ग्रे. So here they are required for rapid resuscitation. What do I mean by rapid resuscitation? That means resuscitation is nothing but the protocol that you follow for saving a life of a patient. That is what is resuscitation. ठीक है? So जब a patient comes to you after trauma, when a patient comes to you after trauma with excessive bleeding and the patient is in hypovolemic shock, you need to give a lot of fluids to the patient. And those lot of fluids, if you need to give to the patient, that is what is called as rapid transfusion. And definitely rapid transfusions will be done either with the help of orange cannula, the best one. If that is not available, the gray cannula. Green one is preferred for an adult male. Green one is preferred for an adult male or during surgeries. Pink one is preferred for an adult female. So females like pink, therefore pink one is used for an adult female. Blue one definitely is used for children. Blue one is definitely used for children. Yellow one is generally preferred for infants. Yellow one is preferred for infants. Whereas the violet or the purple one, as you can see, it has the narrowest bore. Who has smallest veins? Definitely the neonates. So violet or the purple one is generally preferred for the neonates. It is generally preferred for the neonates. Yes, 17 gauge it is there. It is white in color. In between both of these, you have a 17 gauge cannula, which is not commonly used. Therefore, we don't count it over here. It is 17 gauge is white color cannula. No issues with this, anybody? So that's what you need to remember over here, guys. Okay. Now, important is, guys, you need to remember this condition. What is this? So, for example, if a patient was having a cannula inserted for a very long duration of time, तुमने 3 हफ्ते वो cannula वैसे ही छोड़ दिया. So, what will happen now? There will be inflammation of that particular vein in which you have inserted the cannula. And inflammation of a vein is what is called as thrombophlebitis. So, if they ask you what is the most common complication of IV line, so the most common complication of an IV line is a superficial thrombophlebitis. It is usually superficial thrombophlebitis that you need to remember. Okay, so that has been asked. Please remember the most common complication of IV line is definitely superficial thrombophlebitis. What should be done? You need to remove the IV line from that side and you can use another site if you need the cannula. Okay, you can use another vein for cannula insertion. That's important. Very good. Next is this one. What is this tube, anybody? This tube, as you can see, is what is your nasogastric tube. This is what is your nasogastric tube. Okay, you will insert this tube with the from the nose and it will go till the stomach. Therefore, it is known as nasogastric tube. Okay, also known as your Ryle's tube. It is also known as Ryle's tube. And why nasogastric tube is inserted in a patient? Nasogastric tube is inserted in a patient to provide nutrition to the patient. So you will say, why, sir? Can't the patient eat orally? No, that's the problem, na? If the patient is not able to eat orally, that's the reason why we are directly delivering the food into his stomach. And that is usually done with the help of this nasogastric tube. Okay, this is RT or Ryle's tube. And nowadays, as they are approaching towards the next pattern, they are going to more ask you about these clinical things. Okay, definitely they are going to ask you about the topics and the diseases and all of that. But more of them, they are inclined towards this clinical aspects of surgery. Okay. So important is nasogastric or the Ryle's tube. Important is you will insert this Ryle's tube via the nose. And the question was, what is the best position to insert the Ryle's tube? So important is you need to remember the best position to insert the Ryle's tube. The best position to insert the Ryle's tube is usually the sitting position. Yes, the position is sitting position and with the neck slightly flexed. You will ask the patient to slightly flex the neck. Okay, not complete flexion, but just slight flexion of the neck. And then you will take some lignocaine jelly on your hand. You will cover this tube with the lignocaine jelly and then you are going straight from the nostrils. Okay, perpendicular to the nostrils. Seedhe jaoge ekdam. Okay, and then you will ask the patient to sip. Or you will ask the patient to swallow. As the patient swallows, definitely it ensures that the tube will go into the stomach only, not anywhere else. If the patient keeps on swallowing, the esophagus will open up and therefore the tube will only go into the stomach. Okay, so patient ko kya bolo ki niglo baba niglo. Okay, so when the patient will swallow, definitely it will become much easier with neck slightly flexed. That has been a previous year question now. You will say why I'm wasting time on this, because this has the previous year question. This was a previous year question that you need to remember. No issues with this, anybody? Chalo. Moving further now, talking about other type of nutrition. One type of nutrition I've told you is enteral nutrition. So there are two types of nutrition. Just understand. For those who don't know, there are two types of nutrition, guys. Okay? One is enteral nutrition. Second is parenteral nutrition. What is the basic difference between enteral and parenteral nutrition? So enteral nutrition is the one where the food will be absorbed via the intestine. Agar absorption of food is taking place via the intestine, that is what is called as enteral route of nutrition. Whereas if the intestine is surpassed or the intestine is bypassed, absorption of food does not take place via the intestine, that is what is known as the parenteral route. In parenteral route, we are directly delivering the food or we are directly delivering the fluid into the veins of this patient. Okay? So we are directly delivering the food into the blood of this patient. That is what is known as parenteral route. Okay? Yes, it will be more than enough for FMG. I'm covering every other aspect. Please remember that. Okay, chalo. So important is, please remember, it is enteral and parenteral route. So absorption if takes place via the intestine, it is enteral. If absorption is not taken place via the intestine, when we deliver directly into the blood, that is parenteral route. Okay? Now enteral route is definitely preferred. Why? Because it is more physiological route, it is cheaper route. So enteral routes are what? First, oral route. Definitely there is better, the best route will be the oral route. The patient is eating by himself, that is the oral route. Second, if the patient is not able to eat orally, what do we insert? Definitely we insert the nasogastric tube. So usually nasogastric tube or Rice tube is also an example of enteral route, because here the food will be delivered into the stomach, but finally absorption takes place by the intestine only. So nasogastric tube is also an enteral route. Next is nasojejunal tube. We insert a longer tube. Okay, that is what is the nasojejunal tube. Then also the intestine will be responsible for absorption. So all of these are enteral routes. Whereas if I talk about parenteral route, here the food or the fluids will be directly delivered into his blood vessel. And which blood vessels? Mainly the veins. Okay, mainly the veins. Important is, if I talk about parenteral nutrition, which kind of fluids or which kind of solutions will be given to the patient? कैसे solution चाहिए? ज़्यादा energy चाहिए patient को, because the patient is not eating anything, the patient needs more energy, and all that energy you will give via sugar-rich solutions. So for parenteral nutrition, we generally prefer giving sugar-rich solutions. We generally prefer giving sugar-rich solutions to the patient. Okay? What is the best route? Please remember, what is the best route for parenteral? Just a minute. What has happened? Hold on. Great. Sure. So what is the best route for parenteral nutrition? So the best route for parenteral nutrition is the central line. Best route for parenteral nutrition is the central line. So what do I mean by central line? Please remember, here we insert a central line, or here we insert a catheter directly into the central veins of the patient. Which are the central veins? The three veins which are preferred for central line insertion. I'll talk about them later as well. One is the IJV, internal jugular vein. Second is the subclavian vein, the one which lies below the clavicle, subclavian vein. And third is in the groin, that is your femoral vein. Okay? So here if we insert a catheter, that is what is called as the central line insertion. That is the best route to deliver parenteral nutrition. But if that is not an option, you can answer it as PIC. What is PIC? PIC line is peripherally inserted central line. PIC line is peripherally inserted central line. And if that is also not an option, the least preferred one which is there is the peripheral IV line that we discussed now, the cannulas. So peripheral IV lines are the cannulas that we have discussed right now. So peripheral IV line is the least preferred route for parenteral nutrition. Why? Because if you give sugar-rich solutions via these peripheral IV lines, they will undergo inflammation. Please remember, if you are giving sugar-rich solutions, zyada sugar-rich solutions, if you give via peripheral IV lines, there will be inflammation of the peripheral veins, and that we discussed, it is called as thrombophlebitis. So due to the increased risk of thrombophlebitis, the peripheral IV lines are the least preferred route for parenteral nutrition. The best one is central line insertion. What are the indications of parenteral nutrition? So if you are delivering anything into the intestine of the patient or anything into the stomach of the patient, but the intestines have lost its motility. What is the motility in intestine called as? Peristalsis. So if the intestine or the GIT has lost its motility, okay, so agar motility ही नहीं है तुम्हारी intestine में, so definitely will the food be able to pass further? No, the food is not able to pass further. So that's the important thing. In that condition, we cannot prefer a enteral route. Okay, so parenteral route is preferred when the intestines have lost their motility or intestines have lost their peristalsis. मतलब अगर intestines move ही नहीं कर पा रहे, उसमें peristalsis ही नहीं है, तो तुम food intestine में देके कोई मतलब है क्या? नहीं है. So in that conditions, we will prefer parenteral nutrition, and that condition is known as a prolonged paralytic ileus. Okay, that condition is prolonged paralytic ileus. So paralytic ileus means intestine have lost their motility or peristalsis. Okay, if another indication will be acute severe pancreatitis. Yes, in cases of acute severe pancreatitis, initially we keep the patient NPO, nil per oral, and in that condition we need to give fluids to the patient via the IV route itself. Okay, so that is what is acute severe pancreatitis. Next, definitely in acute episodes of inflammatory bowel disease. Why in acute episodes of inflammatory bowel disease we are preferring parenteral nutrition? Because inflammatory bowel disease, matlab what is inflamed? The bowel is inflamed, right? So as the bowel or the intestine is inflamed, can they work? No, they cannot work. So will there be absorption of food? No, there will not be any absorption of food. Therefore, acute episodes of inflammatory bowel disease, we cannot prefer the enteral route. We need to give nutrition via the parenteral route. So at least remember these. And the third one, the fourth one you need to remember is short bowel syndrome. If a patient underwent a trauma due to which major part of his intestine was removed, major part of his intestine was resected, तो अगर बहुत सारा तुमने हिस्सा intestine का निकाल दिया, the part of the intestine which is left behind now, it is a very small bowel or a very short bowel. In that condition also, you will prefer a parenteral route in the patient. Next is, what was the best route for parenteral nutrition? The best route for parenteral nutrition was the central line insertion. As you can see over here, this is how a central line is inserted. You can see a long catheter, and here the vein which is preferred is the internal jugular vein for a central line insertion. So as I've told you, there will be 3 sites for central line insertion. Which is the best site for central line insertion? So the best site for central line insertion is the subclavian vein. The best site for central line insertion is the subclavian vein, which lies 2 fingers below the clavicle. But why is this subclavian vein not preferred regularly? Why it is not the most common site? The reason is because it needs expertise, it needs skills. Because if you are inserting a central line in the subclavian vein, what can happen? What lies below? What lies in the thoracic cavity over here? The lungs. And I hope all of you are quite aware, if you are inserting a catheter over here, definitely that needle can injure the lungs also, or it can mainly injure the covering around the lungs. And what is that covering around the lungs called as? Pleura. And if the pleura is injured, definitely what will happen? A lot of air will collect around the lung. बहुत ज़्यादा हवा भर जाएगी lung के आसपास. And that excess of air will pressurize the lung. This excess of air around the lungs will pressurize the lung. It will not let the lung expand freely. तो lung expand हो पाएगी क्या? नहीं, क्योंकि इतनी सारा हवा भर जाती है, the lung is not able to expand. And that is what is called as pneumothorax. So please remember, the most important complication which is associated with subclavian vein insertion, or subclavian vein central line insertion, is pneumothorax. Okay, so it is pneumothorax. Next, what is the most common site for central line insertion? The one that I've shown you in image, and that is what is called as IJV. Internal jugular vein is the most common site preferred because it is easily accessible. Next is, what is the least common site? So least common site preferred for a central line insertion is the femoral vein. And all of these are one-liners which have come in your exam already. All of these are one-liners. Subclavian vein is the best site. Most common is IJV. Least preferred is femoral vein. And the complications have also been asked. Please remember. And what is the complication associated with subclavian vein insertion? It is pneumothorax. And they have asked, why femoral vein is the least preferred site for central line insertion? क्यों femoral vein को तुम prefer नहीं करते हो? So femoral vein is the least preferred site. The reason being, this femoral vein lies in the groin region, and that groin region is usually unhygienic. That's the reason why there will be higher chances of infection. Okay, there will be higher chances of infection, or there will be higher chances of thrombosis. So if they ask you which route of central line insertion will have the highest chances of infection and thrombosis, you need to answer it as femoral vein, and that is the reason why it is the least common or the least preferred site for central line insertion as well. Next, if I talk about these 2 important staplers, which and one of them have come in your exam recently in FMGE Jan 2023. ठीक है, तो a lot of people are still feeling कि ये जो topics पढ़ा रहे हैं इसका कोई relevance नहीं है. So please remember, I am teaching you topics which are left everywhere, and that's my duty as well. Okay, so important thing is, usually this image had come in the recent examination, so we need to differentiate between these 2 important staplers. The first stapler that we use in surgery is known as a circular stapler. Okay, this one is a circular stapler, and circular stapler is preferred for which surgeries? The one that we commonly perform nowadays, and that is what is called as stapler hemorrhoidopexy. When you are treating hemorrhoids in a patient, for stapler hemorrhoidopexy, if they ask you which stapler is used, your answer should be a circular stapler. And second surgery that we'll prefer in cases of sigmoid colon cancer, it is called as LAR, low anterior resection. In both these surgeries, we prefer the circular stapler. Next one, this one as you have over here in this image, This is what is called as your linear stapler, which was there in FMG Jan 2023 examination. This linear stapler, please remember, is preferred in which surgeries? So linear stapler is preferred in gastrointestinal surgeries. Okay, linear stapler is preferred in gastrointestinal surgeries like a Dohleman's procedure that you will discuss in Zenker's diverticulum. Over there we can prefer this linear stapler. Okay. Next is this drain. Now after a surgery, if you feel there can be collection of a lot of fluid over at the surgical site, okay, so better is to insert some drain after the surgery. Q? Because if you have not inserted a drain after surgery and if there is fluid accumulation at the surgical site, are you again going to open up the patient for that? No, right? You're not going to open up the patient for that. That's the reason why if you are suspecting, अगर तुम्हें लगता है कि fluid collection हो सकता है surgery के बाद, better is to insert some drain. Okay, and when the output will be very less, you can remove the drain. This drain which is there, which is inserted commonly after a surgery, and this is what is known as a Romovac suction drain. This drain which is inserted after a surgery is known as a Romovac suction drain. And this Romovac suction, why suction? Because it works on the principle of negative pressure or vacuum. We press this, okay, we press this and then we fix that suction and then we release it. So a negative pressure or a vacuum is created in the suction, okay, and therefore if there is any fluid collection, it will be sucked out or it will be pulled out. So it works on the principle of negative pressure, and it is used after which surgeries? So it is generally preferred after MRM. What is MRM? Modified radical mastectomy. That is after removal of the breast. The most common complication, I hope all of you are quite aware, that was a previous year question again. What is the most common complication after MRM or modified radical mastectomy? It is seroma. What is seroma? Collection of serous fluid. तो पानी भर जाता है, serous fluid जमा हो जाता है in the axilla after a modified radical mastectomy. Therefore, after MRM, we need to insert a Romovac suction drain in the patient. Okay? It can also be inserted even after a lymph node dissection. Okay? So that's the important thing you need to remember. Next one, talking about few important surgical instruments now. Talking about few important surgical instruments. The first one that we have in the image, usually it is called as the proctoscope. Proctum is another name for rectum. Okay, and scope is the instrument that is used for examination. So usually the instrument that is used for examination of the rectum is what is proctoscope. Now usually proctoscope is inserted via the anal canal by taking some lignocaine jelly, and you ask the patient to relax his anal sphincter so you can easily insert the proctoscope. Then you will remove this obturator and then you will slightly bring out this proctoscope. Okay, while you are bringing out this proctoscope, you are examining the rectum of the patient, and what you will be able to identify? You will be able to identify any hemorrhoids in the patient, piles. Okay, any piles or hemorrhoids in the patient can be identified with the help of a proctoscope. Important. Okay, or any rectal polyps if they are present. Any rectal polyps. So important is investigation of choice for hemorrhoids is proctoscopy. Investigation of choice for hemorrhoids is proctoscopy. That's important to be remembered. Yes, no fancy radiological investigation is required. Okay. But where is proctoscopy absolutely contraindicated? Where is proctoscopy absolutely contraindicated? Now you are inserting such huge surgical instrument in the anal canal of this patient. And if the patient is having excessive pain in the anal canal, is the patient going to let you insert this proctoscope? नहीं. तो अगर patient में बहुत ज़्यादा pain है anal canal में, वो insert करने देगा क्या? नहीं. और अगर हिम्मत कर लोगे तो लात पड़ेगी बेटा, याद रखना, कभी मत करना. So that condition is what is called as anal fissure. Okay, so in cases of anal fissure, definitely don't try to insert proctoscope, otherwise you will get a kick, strong kick from the patient. Okay, next one is this one. Now important is these are all the retractors. What do I mean by retractor, guys? So please remember, when you have given an incision, okay, when I am giving a skin incision, first of all, definitely I need to separate the skin so that I can get a proper view of the underlying structures, and then I'll give another incision on the subcutaneous tissue. Then again I'll retract these structures. Okay, so every incision, after every incision, you will retract the tissues. You will try to separate the tissues. That is what is called as retraction. And that separation of tissues to get a better surgical view is done with the help of retractors itself. Now the retractors that we commonly use, the most common one and which has appeared in the examination also, is this reverse L shape for a retractor. And that's how you need to remember. This reverse L-shaped retractor is known as Lagenbach's retractor. This is known as the Lagenbach's retractor. Okay, it is known as the Lagenbach's retractor. The next one that you have over here, okay, the next one which is completely D-shaped, very concave, this is what is called as your Doyen's retractor. And important is you need to remember, Doyen's retractor is used to retract or used to hold back which structure? कौन से structure को पीछे खींचने के लिए या separate करने के लिए use होती है? So it is generally preferred to separate to retract your bladder, urinary bladder. So Doyen's retractor is used to retract your urinary bladder. Next one that you can see over here, it is a square blade which is there in this retractor, okay, and it has a curved at the end as well. This is known as the Morris retractor. It is known as the Morris retractor. To retract a huge organ like liver, for example, to retract or to bring back the huge organ like a liver, definitely we will use this Morris retractor. Okay, important is that. Next is Sarkari question of your exam, and it is this instrument. What is this instrument? Anybody? Answer. I need an answer for this one now. It is a very common Sarkari question of your exam. Answer it. Anybody? Have you slept or what? Hopefully not. So this is what is characteristically known as your Humvee's knife, guys. Okay, this is what is known as your Humvee's knife. And please remember, this Humvee's knife it is usually used to raise a skin graft. When we need to take a skin graft from the patient's body, so that patient the skin graft that is taken or raised from a patient's body, it is usually done with the help of this knife known as the Humvee's knife. A Sarkari question of your exam. To raise a skin graft, definitely we use this Humvee's knife. And in this Humvee's knife, we can use two kinds of blade depending on how much thickness of graft we need. If we need a partial thickness skin graft, the blade that we commonly insert over here, it is known as a Thiersch blade. The blade that we commonly insert is a Thiersch blade, which is used to take a partial thickness skin graft, also known as a split skin graft. So split skin graft is another name for partial thickness skin graft. We'll see in once. Next, if we need to take a full thickness skin graft, to take a full thickness skin graft, the blade that we insert is known as the Wolfie's blade. Okay, so to take a full thickness skin graft, we use a Wolfie's blade along with the Humvee's knife. No issues with this, anybody? Next one are these two important forceps. And what are these two important forceps? So what is the role of forceps? First of all, the function or the role of forceps during a surgery is to hold any structure. Okay, किसी भी चीज को पकड़ने के लिए during a surgery we use this forceps. Okay, so the first forceps that you can see, these are the two rings, the first and the second ring. Okay, this is what is called as a ratchet. And what is a ratchet? So ratchet is a locking system with the help of which we can lock the forceps and it will not displace. Okay, so we can lock the forceps with the help of this ratchet usually. Next, this is called as the joint usually. Okay, this is known as the joint. This is what is called as the blades. And you can see the end of the blades over here. These blades are curved over here. Okay, the end of the blades are usually curved over here. And definitely both the blades are having fenestration. What do I mean by fenestration? Fenestration का मतलब होता है hole. Okay, so both of these curved blades are having hole at the end. Okay, so please remember there are curved blades which are there, and these curved blades are definitely having fenestrations or holes. So this type of forceps will be used to hold tough structures or tubular hollow structures, delicate structures. So please remember this forceps that is there in the image, again commonly asked in your exam, is known as the Babcock's forceps. This is what is called as your Babcock's forceps. And please remember important thing that Babcock's forceps is generally used to hold delicate structures. Okay, it is used to hold delicate structures generally. Okay. Next one is this delicate structures like bowel, ureter, okay, your seminiferous tubules, okay, sorry, spermatic cords, that is your vas deferens, ductus deferens, all these tubular structures which are hollow. Okay, to hold every kind of structure you can use this Babcock's forceps. Next is this forceps. Again, the blades of this forceps, as you can observe, they are also curved. But what is the difference? You have got these tooth at the end of these forceps. You have got these tooth at the end of these forceps. So here we do not have any fenestrations, rather we have tooth ends usually. Okay, we have tooth ends at the blades, and this is characteristically known as the Ali's tissue forceps. This is what is known as your Ali's tissue forceps. Okay, so if I talk about the Ali's tissue forceps, now it has the tooth, and this tooth will definitely help in firm grip, strong grip या strong hold करने में मदद करते हैं. So this Ali's tissue forceps is definitely used to hold which kind of structures? It is used to hold tough structures like the fascia. It is used to hold tough structures like the fascia, aponeurosis, sheath, the tendon. Okay, for them definitely we use this Ali's tissue forceps. Next important we need to remember is this one. And what is this? You can see these are thick scissors. You can see there is no ratchet or no locking system now. So this is what is a scissor. Okay, so this is what is called as a Mayo scissor, and Mayo scissors are the thick scissors or very heavy scissors. And if heavy scissors are there, definitely they are used to cut what? They are used to cut tough structures. They can also be used to cut sutures as well, but definitely they are preferred for using, they are preferred to cut any tough structures, like again the fascias usually. Okay, to cut the fascias vagara, we prefer this Mayo scissors only. And last important one, this is what is called as your needle. Which needle? This is known as your Veress needle. And this Veress needle, important is, it is used during which surgery? So please remember, this Veress needle is generally preferred during a laparoscopic surgery. Veress needle is used during a laparoscopic surgery. Why? Now I hope all of you are quite aware, laparoscopic surgery mein, we give a complete incision or what? No. We only give small incisions, and we insert our laparoscopic instruments from these small incisions. Okay? We insert our laparoscopic instruments from here. Important is, guys, if you're inserting this laparoscopic instrument, they can immediately injure some structures in the abdomen. Therefore, there should be some gap, or there should be some space between the abdominal organs and the abdominal wall. To create this space, we insert a gas. And what is that gas inserted in the abdomen or in the peritoneal cavity? That has been a question. The most common gas which is used to create a pneumoperitoneum. What is pneumo? That is gas. Where do we insert a gas? In the peritoneum. So the most common gas that we insert usually in a laparoscopic surgery, and that was a previous year question, is the carbon dioxide gas. Okay, so the gas which is used to create a pneumoperitoneum is the carbon dioxide gas. And for insufflation or to insert this carbon dioxide gas within the peritoneal cavity, we use this Veress needle itself. Okay, so therefore it is a very important image that you need to remember. Veress needle, it is used in laparoscopic surgeries to create a pneumoperitoneum, and the pneumoperitoneum is created with the help of a carbon dioxide gas. No issues till here. Next, if I talk about is this one. These two instruments are known as cauteries. Yes, nowadays I hope all of you are quite aware, only we give the first incision, the skin incision, with the help of a blade, surgical blade. Otherwise all the other incisions are taken or are given with the help of these cauteries itself. Why? Because cauteries will not only give an incision, but they will also burn the area. And as they burn the area somewhat, definitely they will not cause excessive bleeding. If you are giving direct incision with a blade, there will be more bleeding. But if you are using a blade, if you are using a cautery to create an incision or to make an incision, there will be less amount of bleeding. Therefore, cauteries are commonly preferred. There are two types of cauteries you need to remember. FMG exam में भी दोनों पे question आ चुका है, important. Okay, so the first one is the monopolar cautery. The first one is the monopolar cautery, and the second one is known as the bipolar cautery. The second one is known as the bipolar cautery over here. So monopolar, why? Because you can see there is only a single end. Okay, the tip of this monopolar cautery is like a pen, or it is like a Bowie tip. Okay, so there is only a single one, therefore it is called as monopolar. But here you can see in this cautery, the end which is there are two ends, right? So there are two electrodes over here. Therefore it is called as a bipolar cautery. Okay, here the ends are like prongs. Here the end is like a pen. Okay, that's the basic difference. Important is, monopolar cautery always requires a cautery pad. Why it requires a cautery pad always? Important is, please remember, because if we connect this monopolar cautery to the cautery machine, so the electricity will come via this monopolar cautery. Electricity or the electric current comes via this monopolar cautery. It goes to this tip, and then it goes into the tissues and it cuts the tissues. Current or the heat cutting the tissue is what is cauterization. Okay, so it will cut the tissue, but then this current will pass via the patient's body. Okay, then this current will pass via the patient's body once it has cut the tissue, and then it will exit out now. Otherwise, okay, the cautery will not work. Q, because in physics you might have studied, I'm not going into details, but the electric circuit should be complete for the current to flow. So here also the circuit should be completed, so the current will come back from the patient's body into the cautery machine, and that is usually comes back with the help of a cautery pad. So you need to stick a cautery pad to the patient's body. Usually it is usually the cautery pad is placed over the thigh of the patient. Okay, so that's the important thing. Cautery pad is required for a monopolar cautery. Is it required for a bipolar cautery? No. The reason is, here important is, please remember, here the current comes via one electrode, it cuts the tissue and it goes back via another electrode. Okay, so here the current does not pass via the patient's body. That's the reason why we do not require any cautery pad in cases of bipolar cautery. So that's the basic difference, first one. Next important, as the current is passing via the patient's body in cases of monopolar cautery, therefore there is a risk of arrhythmia, because this current can interfere with your current of your heart also, na? The rhythm of your heart. And therefore monopolar cautery is contraindicated in patients who are having pacemakers implanted. तो जिन पेशेंट्स में पेस मेकर्स है लगे हुए उन पेशेंट्स में कौन सी कॉटरी यूज नहीं करते हो? मोनोपोलर कॉटरी इज नॉट यूज्ड इन पेशेंट्स हु आर हैविंग पेस मेकर्स, whereas bipolar cautery can be used in patients who are having pacemakers. Okay, important is here you can see in a monopolar cautery there are two buttons. The yellow button which is there, it is used for cutting. Okay, the yellow button is used for cutting, whereas the blue button is used for coagulation. The blue button is used for coagulation. Whereas if I talk about the bipolar cautery, you can see there is no button over here, because the only function that a bipolar cautery can perform is coagulation. इसमें cutting होगी क्या? नहीं होती. So bipolar cautery is only responsible for coagulation. That's important. Okay, so these were the basic differences you need to remember about the cauteries. Next, if I talk about the surgical blades, as I've told you, cautery are not used to make skin incision. Why cauteries are not used to make skin incisions? Because if we use cauteries to make skin incisions, cautery क्या use करती है? Electric current. They are using heat. Therefore, they will be burn over the skins. There will be burning scars over the skins if you use the cautery. That's the reason why to make skin incisions, we still prefer the surgical blades. Important among the surgical blades are the two most important ones. That is 11 and number 11 and the number 12 blade. The number 11 blade, you can see it is a pointed blade. Okay, the number 11 blade is a pointed or a triangular blade at the tip. This blade is what is known as the stab blade. Why it is known as the stab blade? So the number 11 blade is known as the stab blade because it is used to make stab incisions. Okay, the one that we do perpendicular. Okay, that is what is a stab incision. So it is used to make stab incisions. And where do we make stab incisions? Usually to drain a abscess. What is an abscess? Pus collection. To drain a pus collection, definitely the incision that we make on the skin is a stab incision. So definitely for incision and drainage of an abscess for I and D, and that has been a previous year question again. For incision and drainage of an abscess, which is the number of blade that is used? It is the number 11 blade or the stab blade which is used. Next is the number 12 blade. So you can see number 12 blade is a curved blade, right? So this number 12 blade is used for cutting sutures. Okay, to cut the sutures, the blade that we use is the number 12 blade. Whereas all the other blades, whether it is number 10, 15, 18, 20, 21, 22, 23, 24, all of these blades are used to make skin incisions, various types of skin incisions. Okay? And if they ask you, that was a previous year question in neetpg, which is the sharpest portion of the blade? The single one liner that you need to remember, the sharpest portion of the blade is not the tip. That was a mistake that a lot of people did. So the sharpest portion of the blade is the belly. Okay, it is the tummy. The sharpest portion of the blade is the tummy or the belly. Okay, it is the belly of the blade which is the sharpest portion. And always hold the blade perpendicular to the skin so that the margins जो है ना, margins are not inverted, they are everted. हमें बाहर आई हुई होनी चाहिए margins. Okay, the margins are everted. And this is what? So you do not use the blade directly, right? So usually you place the blade over here on this handle. And what is this handle called as? This handle is known as the Bard-Parkle handle or the BP handle. This handle, which is used to mount a surgical blade on top, is known as the Bard-Parkle handle. To lengthen the surgical blade. Easy हो ना, pen की तरह पकड़ सको तुम blade को. Next important is this one. What is this, anybody? So this one is a needle holder, and with the help of a needle holder, we are holding the suture needle. This suture needle, as you can see, please remember, this suture needle that we can see, it is hold in between. Okay, so this is what is the swaged end. What is the swaged end? The end at which the suture is attached or the thread is attached is the swaged end, whereas the pointed end, the other one which is sharp, it is the pointed end. Okay, so where do we hold the needle? With the help of a needle holder, and that was a previous year question. So please remember, we hold the needle with the help of a needle holder at junction of how much part from the pointed end? At junction of 2/3 from the pointed end. Okay, 2/3 from the pointed end. And how much from the swaged end? 1/3 from the swaged end. Okay, so at junction of 2/3 from the pointed end and 1/3 from the swaged end, the needle should be held. Okay, 1/3 from the swaged end. The needle should be held. No issues with this, anybody? Just a minute. No issues till here. So at the junction of 2/3 from the switched end and 2/3 from the pointed end and 1/3 from the switched end, you need to hold the needle with the help of a needle holder. Okay. Then once we have taken the sutures, we'll talk about the sutures. Okay. Then finally you will tie a knot. Right. Finally you will tie a knot, and that knots, you need to remember these 3 types of knots at least. Okay. So one knot that you can see in the first image here, how many throws are there? First we are taking 2 throws and then it is followed by 1 throw. Okay. Then it is followed by a single throw. So if you take 2 throws and then again 1 throw, so it is the most secure knot. It cannot slip easily. ठीक है? तो अगर तुम 2 गांठ पहले मार रहे हो और उसके बाद और एक गांठ मार रहे हो, तो definitely it is the most secure knot. It will not slip off easily. And this is what is called as a surgeon's knot. This is what is known as the surgeon's knot. It is the most secure knot which does not slip easily. Next one that you can see over here. Next one that you can see, guys. Okay. You can follow the blue thread. Okay. So you can see the blue thread is going either above the loop or it is going below the loop. Okay. So here you can see the blue thread, both the ends of the blue thread, they are going above the loop. So if both the ends go above the loop, this is what is called as a square knot or a reef knot. Okay, if both the ends go above the loop, it is known as the square knot or the reef knot. It is known as the square knot or the reef knot. That you need to remember. Okay, and it is a secure kind of a knot. It is a secure kind of a knot. That means it will not slip off easily. But the most secure still remains the surgeon's knot. Next is this one. How to recognize this knot in the image? So you can follow the blue thread again. One part of the thread is going below the loop. Another part of the thread is going above the loop. Okay, so that's important. If one part of the thread goes below the loop, another part goes above the loop, this is the granny's knot. And we know the granny's knot, usually grannies use it while making a sweater, and therefore these knots will come off easily because these are insecure knot. They will slip off easily. These are insecure knots. Okay, so that's the important knots that you need to remember, which has been asked in the exam. Then if I talk about the classification of sutures, okay, if I talk about sutures now, so there are 2 varieties of sutures. Either they are absorbable sutures, and if they are absorbable, will you need to remove them? No, they will get absorbed by themselves. अपने आप वो absorb हो जाएंगे, तुम्हें निकालने की जरूरत नहीं है. These are known as absorbable sutures. And the second is known as non-absorbable sutures. So non-absorbable मतलब the sutures that you need to remove. Okay, if you need to remove the sutures, अगर तुम्हें निकालने हैं sutures, that is what is a non-absorbable suture. If I talk about the next classification, the sutures can be either natural sutures, which are derived from plants or animals, or it can be synthetic sutures, which are made out of something, okay, which are made in the laboratory. Okay, these are synthetic sutures. Important is if I talk about the first group, that is absorbable and natural sutures. So absorbable and natural sutures are usually the catgut and the chromic catgut. Absorbable natural sutures are the catgut and the chromic catgut. Whereas the non-absorbable natural suture is silk. Non-absorbable natural suture is silk. If I talk about the next one, if I talk about absorbable sutures but which are synthetic in nature, so the absorbable synthetic sutures will be vicryl, and the second one is monocryl, and the third one is PDS. PDS is also known as polydioxanone. Okay, so at least remember this classification. Absorbable synthetic sutures are vicryl, monocryl, and PDS, that is polydioxanone. Whereas if I talk about non-absorbable synthetic sutures, non-absorbable synthetic sutures are proline and nylon. Non-absorbable synthetic sutures will be proline and nylon. So this is the bare minimum classification of sutures that you need to remember. At least remember this table for your exam. Okay? Next one, if I talk about these sutures in detail which have been asked in your examination. The only images that have been asked in your examination, I am focusing on those type of sutures, and they are also very commonly used during the surgeries as well. The first suture that you can see over here, this suture which appears yellow in color is what is your catgut suture. It is your catgut suture. Important is, catgut is a natural or a synthetic suture? Definitely it is a natural suture because it is derived from an animal, first thing. Second, is it an absorbable or a non-absorbable suture? We have seen it is an absorbable suture. That means it will be absorbed by itself. We don't need to remove the suture. Okay? So if I talk about what is the absorption time that has been asked, within how much days catgut suture is absorbed? So catgut suture is absorbed usually within a span of 60 days. Catgut suture is absorbed within a span of 60 days. Chromic catgut can be absorbed within 90 days. Okay, but catgut is absorbed within a span of 60 days. Important is, it is derived from which animal? So please remember, it is not derived from a cat. Though it seems it is derived from a cat, no, it is not. Okay, so please remember, catgut suture is derived from the sheep's gut. It is derived from sheep's gut. Okay, so it's derived from, just a minute, it's derived from the sheep's gut. Sheep gut से निकाला जाता है इसको. And which layer of the sheep gut? As we know, just like the human intestine or the human gut, sheep's gut is also the strongest layer of the sheep gut is also submucosa. That is the one liner from anatomy. Okay, which is the strongest layer of your GIT? Answer is submucosa. So here it is derived from the sheep gut submucosa. It is derived from the sheep gut submucosa. That's important. Okay, that has been a previous year question. Now again, one important question which has been asked, that catgut is stored in which preservative? So if you open up the catgut suture, that is stored in some preservative. And what is that preservative? So it is stored in isopropyl alcohol. So catgut suture is stored in isopropyl alcohol. Yes, there is some liquid inside the catgut suture pack, and that liquid is nothing else but isopropyl alcohol. Okay, so catgut suture is stored in isopropyl alcohol. That is again an important previous year question. Okay, the preservative used for storage of catgut suture. Answer is isopropyl alcohol. Okay. Next is this violet color suture, and this violet or purple color suture is known as Vicryl. It is known as Vicryl, which is the most common suture used nowadays. Okay, Vicryl. Another name for Vicryl is, it is also known as polygalactin. So Vicryl is also known as polygalactin. Is it a natural suture or synthetic suture? Definitely it is a synthetic suture. Is it absorbable or non-absorbable? So it is an absorbable suture. It is an absorbable suture. Okay, important is that. Now Vicryl usually is absorbed within what? How many days now? So if it is an absorbable suture, there should be a span or duration of absorption. So usually Vicryl is absorbed within a span of 60 to 90 days. Vicryl is absorbed within a span of 60 to 90 days. Important is that. And where is Vicryl used? So Vicryl is not used over the skin. It is used below the skin. Okay. So it is used for bowel or bladder repair. Commonly remember, it is used for bowel or bladder repair. When you need to repair your intestine or when you need to repair your urinary bladder, for all the internal structures, you can use the Vicryl suture. Very commonly used. Please remember that. Okay. Next is this sky blue color suture. And this suture is what is called as proline suture. Proline is also known as polypropylene. So don't get confused. Proline and polypropylene is one and the same thing. Now, is it a synthetic or a natural suture? Definitely it is a synthetic suture. Okay, proline or polypropylene is a synthetic suture. Absorbable or non-absorbable? So it is a non-absorbable suture. And where is proline suture used? So please remember, proline suture is generally used for vascular repair. When you need to repair the vessels, right? अगर तुम्हें vessels को repair करना है, so at that time vascular repair we use this proline sutures. Next, the rectus sheath repair. Okay, for rectus sheath repair also, that was a previous NEET PG question. For rectus sheath repair, which is the suture preferred, it is the proline suture which is preferred. Next, if I talk about this suture over here, the black color suture that we have, and this black color suture is again a very commonly used suture, and that is nothing else but your silk suture. If I talk about your silk suture, important is, silk is natural or synthetic? Definitely we know silk is natural. Why it is natural? Because it is derived from silkworm. Okay, silk we know it is derived from silk. Thread is derived from silkworm, na? Just like that, silk suture is also derived from silkworm. Therefore, it is a natural suture. And it is absorbable or non-absorbable. So please remember, silk is a non-absorbable suture. You need to remove the suture. Okay, you need to remove the suture. Silk suture is preferred where? So silk suture is generally preferred for skin suturing. Silk suture is generally preferred for skin suturing. Okay, so that's the important thing. So therefore, it is very common suture which is used. Next is this one. It is known as a nylon suture. Nylon is synthetic or natural? Definitely it is a synthetic suture. Absorbable or non-absorbable? So nylon, please remember, it is a non-absorbable suture. Important is, nylon is also known as ethylon, and nylon suture is used where? So nylon again is used for skin suturing. Just like silk sutures, we can also use nylon for skin suturing. Important, very fine nylon or very thin nylon is also used for ophthalmological surgeries. Yes, please remember, that was a previous year question again. For ophthalmological surgeries, which is the preferred suture? Answer is nylon. Okay, nylon is the preferred sutures used for ophthalmological surgeries, and it is also used for tendon repairs. It is also used for tendon repair. Because it is a strong suture, it is also used for tendon repairs. Please remember that. Okay, now if I talk about the needles which are attached, you can see the needle is attached to the suture itself. So the needle is which are attached. There are two types of needles. If I cut the needle in between, okay, and if I see the needle, either it will have a circular point or it will have a triangular point. If it has a circular point, it is called as a round body needle. If it has a circular point, it is called as a round body needle. And if it has a triangular point, it is called as a cutting or a reverse cutting needle. It is called as a cutting or the reverse cutting needle. So what is the basic difference where we will prefer a round body needle and where we will prefer a reverse cutting needle? Important is, please remember that round body needle could not pass via the tough structures. So if it cannot pass via tough structures, can you use it for skin suturing vagara or for tough structures? No. So please remember, round body needle is generally used for delicate structures like the intestines vagara. Whereas cutting or reverse cutting needle, as it has a pointed end or a sharp end, definitely it can be used for tough structures. Okay, so cutting or reverse cutting needle is generally preferred for tough structures. No issues with this, anybody? So that's important. Moving further, guys. Moving further. Now talking about the wounds. Do you want a break? So we can start after break. Okay. So if you want a break, please let me know in the chat box so we can take a break for 10 to 15 minutes and then we can start. 10 minutes break. And then we can start with the wounds and then we'll continue with trauma further. Please let me know. I hope I am audible to all of you. I'm fine with no break. You let me know. Just if all of you are fine, we can continue further. We can continue further for sure. Then talking about wounds, guys. If I talk about, okay, so okay, great, chalo. If I talk about wounds now, after wounds, let's take a break. Okay. If I talk about wounds, guys, important is over here there are different types of wounds you need to remember. This will also be covered in forensic. I am just giving you a brief idea because we deal as surgeons, we usually deal with these type of wounds regular basis pe. So therefore you need to remember about the wounds as well. Okay. So important is this one that you can see, the first one. This wound is a very superficial wound, and this type of injury is what is called as an abrasion. This is what is called as an abrasion. What is an abrasion? Abrasion is only injury to the epidermis, only the injury to outermost layer of skin, that is what is known as your epidermis. So abrasion is injury only to the outermost layer of skin, that is epidermis. Please remember. And abrasions are usually seen during an accident. Okay, usually during a road traffic accident, we can see these multiple linear wounds on the skin, and that is what is abrasion. Next, you can see over here, if we use a heavy weapon, just something like a sword or something like an axe, okay, तो अगर कुल्हाड़ी जैसा कुछ use करते हो, then this type of wound is formed, and this wound that you can see over here, okay, this wound that you can see over here is what is called as a laceration. This wound is what is known as a laceration. Important about laceration is, please remember, laceration will have irregular margins. Laceration has irregular margins. If I compare it with a incised wound, what is an incised wound? If I take a surgical blade and if I make a cut, okay, that is what is called as an incised wound. So if I compare a laceration with an incised wound will have regular margins, but laceration has irregular margins. Important is the nerves and the vessels or the hair follicles, if they talk about, okay, the nerves, vessels and the hair follicles, they are crushed in cases of a laceration. They are crushed in cases of a laceration, but in an incised wound, if I give a sharp cut, in a case of incised wound, these nerves, these vessels and these hair follicles will be cut. So that's the basic difference. If they are crushed, it is laceration. If they are cut, that is an incised wound. Next is this. You can see there are multiple superficial linear cuts. These multiple superficial linear cuts that usually is seen on the accessible parts of body, usually over the wrist or the forearm. These are called as the suicidal cuts. These are known as the suicidal cuts, also known as tentative cuts or the hesitational cuts. So these are known as suicidal wounds or suicidal cuts or tentative cuts, hesitational cuts as well. Okay? Multiple superficial linear cuts. Next is this one. What is this type of a wound called as? This type of a wound is what is known as degloving. This type of a wound is known as a degloving injury, or it is known as a avulsion injury. This is a degloving or an avulsion injury. See, over here, if a flap is formed, okay, if due to some injury a flap of skin is separated, from the underlying structure. So these are my underlying structures, and a flap of skin is separated from the underlying structure. This type of injury where a flap of skin is separated is known as degloving or avulsion injury. Important previous year question is, usually degloving or avulsion injury mein the plane of separation is between which two layers? So the plane of separation is between the subcutaneous tissue. Okay, the plane of separation in a degloving or an avulsion injury is between a subcutaneous tissue and the deep fascia. So the plane of separation is between a subcutaneous tissue and the deep fascia. Okay, in a case of degloving or an avulsion injury. Okay, important is next one is this. This is what? This you can see. For example, if you get a blunt trauma somewhere, okay, and after that you get these kind of discoloration over the skin. This kind of red, brown or bluish or blackish at times, this discoloration that you get, this is what is called as a contusion. This is what is known as a contusion. And contusion is also known as a bruise. Important is, contusion is also called as a bruise. Important is, why there is a contusion or bruise after a trauma? Usually it is due to collection of blood. Yes, it is due to collection of blood. So bruise or contusion is nothing else but collection of blood. So you will say, so why we don't call it a hematoma? So hematoma is the collection of blood which feels like a tumor, which is huge collection of blood which feels like a tumor. That is what is a hematoma. Here can you feel it like a tumor? No. Okay. So this is what is a contusion or a bruise. That is only minimal collection of blood due to rupture of small vessels like the venules. Okay. Next is this one. You can see the skin or the underlying structures, they have been completely damaged. पूरी तरह से खत्म हो चुके हैं skin और बाकी के structures. This is what is called as a crush injury. This is what is known as your crush injury. And crush injuries are usually seen during what? Crush injuries are usually seen during road traffic accidents. These are crush injuries, and we know in crush injuries all the structures are severely damaged. Okay, they are crushed completely. Okay, so you need a flap to cover the crush injury properly. You need a skin flap. Next important is this, and that is what is scars. Okay, so if there was wound in a patient, please remember, definitely after a wound there will be wound healing. Okay, and as the wound healing will occur, what will happen at the site of the wound? Okay, at the site of the wound, what will start depositing? The fibroblast will start depositing, or the collagen will start depositing. Okay, so if there is wound healing, definitely when there is wound healing, the fibroblast or the collagen starts depositing at the site, and that is what is known as wound healing or wound repair. Please remember that. Okay, so usually if there is deposition of collagen or fibroblast at the wound site, that causes healing. Important is, can anybody tell me faster which is the first collagen to appear during wound healing? Which is the first? All of these are previous year questions. Which is the first collagen to appear during wound healing? Which is the first collagen to appear during wound healing? Faster, answer this question. And second, also answer that which is the most abundant collagen in a scar? Which is the most abundant collagen in a scar? So what is a scar? As I've told you, we are going to discuss about a scar. Scar is nothing but outcome of an wound. Okay, the outcome of a wound is what is known as a scar. In simple terms, outcome of a wound is known as scar. After wound healing, what appears is what is a scar. So please tell me these two important one-liners. First collagen to appear during wound healing. Very good. Answer is type 3 collagen. First collagen to appear during wound healing. Answer is type 3 collagen. Previous year question. And the most abundant collagen in a scar? The most abundant collagen in a scar. Answer. Most abundant collagen in a scar. Very good. It is type 1 collagen. The most abundant collagen in a scar is a type 1 collagen. Important. You need to remember. Chalo. Next, if I talk about the scar, usually the scars can be of two types. One is called as a hypertrophic scar and second is a keloid scar. Now, if you see that the scar, if it is limited within the wounds, if the scar is limited within the margins of the wound, it is known as a hypertrophic scar. But if it grows beyond the margins, it is what is called as a keloid scar. If the scar grows beyond the margins, it is what is called as a keloid scar. Important is, hypertrophic scar is more commonly seen in which population? So hypertrophic scar is more common in children. But whereas keloid scar is more common in younger population, that is 10 to 30 years of age. Keloid scar is more common in younger population between 10 to 30 years of age, and that too females mein. Females mein keloid is more common. Important is, will keloid scar occur in every patient? No. Keloid scar has a familial predisposition. What do I mean by this? जिनके फैमिली में हिस्ट्री है केलॉइड बनने की, उन्हीं पेशेंट्स में केलॉइड बनने की रिस्क ज्यादा होती है. ओके, सो ओनली पेशेंट्स हु हैव अ फैमिली हिस्ट्री विल बी हैविंग अ हायर रिस्क ऑफ केलॉइड स्कार फॉर्मेशन. Okay, whereas no familial association is seen in cases of hypertrophic scar. Hypertrophic scar can be seen in any and every patient. Okay, so that's the important thing. Next, keloid scar is more common in which race? So you need to remember, keloid scar is more common in the black race, or we can call it as the Afro-Caribbean race. Okay, so keloid scar formation is at a higher risk in the black or the Afro-Caribbean race, whereas no such genetic predisposition or no such racial predisposition is seen in a case of hypertrophic scar. What is the treatment for a hypertrophic scar? For a hypertrophic scar, nothing has to be done, or we can just massage the hypertrophic scar with the help of moisturizing cream. That's it. It will go by its own. But if I talk about a keloid scar definitely needs a treatment. And what is the treatment most commonly used for keloid scar? The management of the treatment for a keloid scar, you need to remember. Here we will give an intrakeloidal injection. Within this keloid, we need to give an injection. We will give an intrakeloidal injection of a steroid. And what is that steroid known as? Triamcinolone. A previous year question which has been commonly asked. Okay, so intrakeloidal injection of triamcinolone has to be given. That is the most common treatment used for keloid scar. But if they ask you what is the best treatment for a keloid scar, then the answer cannot be intrakeloidal injection. Okay, if they ask you what is the best treatment for a keloid scar, then the answer cannot be intrakeloidal injection of triamcinolone. Then your answer should be surgical excision. So you will say, sir, even after surgical excision, can there be chances of recurrence? Yes, there can be chances of recurrence even after surgical excision. That's the reason why usually after surgical excision, the patient has to undergo a interstitial radiotherapy. Okay, we will place a radioactive substance like cobalt in the tissue. Okay, so interstitial radiotherapy. That's the best answer to be given for best treatment in a case of keloid scar. So surgical excision followed by interstitial radiotherapy is the best treatment option for keloid scar. But the most commonly used is definitely the intrakeloidal injection of triamcinolone. No issues with this, anybody? Next, if I talk about these, what are these? So these are various types of ulcers which are commonly asked in your examination. They are topmost favorite, and usually they will ask you about the ulcers in the leg region itself. Okay, so they are very commonly asked. In the first image you can see there are multiple ulcers. Okay, there is not a single ulcer, there are multiple ulcers, and they're superficial or deep. So we can see they are shallow or they are very superficial. Okay, upar hai bas. They are multiple, they are shallow or superficial ulcers. So multiple or superficial ulcers usually seen in the leg region. And what is the most common site? So the most common site for these type of ulcer is definitely the gaiter's area of leg. Okay, the area above the medial malleolus. Okay, so it is the gaiter's area of leg which is the most common site, the area which lies above the medial malleolus. It is the most common site, again a PYQ. Okay, and these ulcers where there are multiple and shallow ulcers, these are an example of a venous ulcer. Okay, these are an example of venous ulcer. So you will say, sir, only superficial ulcers will tell us about that? No, you also need to see the margins. If it has sloped margins, if it has slope or sloping margins, so if the ulcer has such kind of sloping margins, that is also suggestive of a venous ulcer. So venous ulcer are multiple shallow ulcers with sloping margins usually seen on the gaiter's area of leg. That is a venous ulcer. Second ulcer that you can see in the image is what is the deep ulcer. Okay, there is a single deep ulcer, and which type of margins are seen? Such margins. That is what is called as a punched out margins. So deep ulcer with punched out margins, if it is there in the image or if they mention in the question. So deep ulcer with punched out margins. Okay, so definitely this is a case of an arterial ulcer. Okay, this is what is a case of an arterial ulcer. So the margins are very important, guys, to make a diagnosis. Sloping margins, venous ulcer. Punched out margins in a deep ulcer, usually an arterial ulcer. And in arterial ulcers, please remember the patient commonly has pain. Why? Because the arterial ulcers are due to artery blockage. And if there is blockage in artery or there is an obstruction in the artery, there will be decreased blood supply to the nerves also in that area. That causes pain in the patient. Okay, so it is associated with pain. Next, we can see over here, please remember, these are called as the trophic ulcer. The one which are usually seen in the sole of the foot, they are called as a trophic ulcer. Okay, so one of the subtypes of a trophic ulcer is usually seen in the heel area also, and that is what is called as a pressure sore. One of the subtype of a trophic ulcer is seen in the heel area, and that is what is known as a pressure sore. So pressure sore is due to excessive pressure which is exerted on the pressure points. Okay, so trophic ulcers are usually seen in patients of diabetes mellitus or leprosy. Trophic ulcers are usually seen in patients of diabetes mellitus or leprosy. And important is, trophic ulcers are painful or painless? They are painless. Why? because diabetes mellitus patients are suffering from neuropathy and leprosy patients are having neuritis. So in both the conditions, the ulcers, the trophic ulcers are painless usually. Okay, so there will be painless ulcers, but which kind of margins will be there? So these are painless ulcers which are having, please remember, which are having again punched out margins. Yes, here also the ulcer will have a punched out margin. So painless ulcer with punched out margins. What did I tell you? Arterial ulcers are painful, okay, but trophic ulcers are painless. Both of them are having punched out margins, so that will help you to differentiate. Painless is arterial ulcer, painless is a trophic ulcer and painful is an arterial ulcer. Okay, important is that to be remembered. And second important thing that you need to remember over here, these are non-healing ulcers. They will not heal. You might have seen a patient of diabetes getting an ulcer. That ulcer does not heal on time, so it is a non-healing ulcer. Okay, and see, all these ulcers, treatment is always dressing. Proper dressing should be done. Proper wound hygiene should be maintained. Next, the last one that you need to remember, I'll talk about pressure sores separately as well. This last ulcer that you have in the image, okay, this is what is called as a Marjolin's ulcer, a very common ulcer which is commonly asked in your exam. Okay, this is what is called as a Marjolin's ulcer. If I talk about the Marjolin's ulcer, guys, important is Marjolin's ulcer is a painful or painless ulcer? It is a painful ulcer. First important thing, it is a painful ulcer. Next, where it will be common? It will be common at the site where there was a burn scar. तो अगर पेशेंट में पहले इस जगह पे बर्न हो चुका हो, okay, and if there is a burn scar over there, so definitely at the site of burn scar, Marjolin's ulcer is more common. So Marjolin's ulcer should have a past history of burns. It usually has past history of burns usually. And what is the risk factor in a Marjolin's ulcer? The risk factor in a Marjolin's ulcer is there will be high risk of squamous cell carcinoma over here. Yes, and that has been a question. Which type of ulcer has highest risk of squamous cell carcinoma? So only ulcer which has the highest risk of squamous cell carcinoma is Marjolin's ulcer. Yes, Marjolin's ulcer can further progress into squamous cell carcinoma. That is the reason why here the treatment is not only dressing. Here we need to go for a surgical excision. Here we need to go for a surgical excision of the ulcer. Wide local excision should be done. Okay? That should be done. Important. Please remember this. Syphilitic ulcer, please remember, syphilitic ulcer also has punched out margins usually. Okay? Next is this. What is this? So you can see there is infection of the pulp space of finger. So this is what is called as the pulp space. This is the nail and this is what is called as a nail bed. Okay, so these two infections are different. So if there is infection of finger pulp space, if there is infection of finger pulp space, this is what is called as a phelon. So if there is infection of the pulp space of finger, this is what is called as a phelon. Is it a bacterial or a fungal infection? So it is a bacterial infection. Please remember, it is a bacterial infection usually. That is what is known as a phelon. Please remember. Okay. So phelon is usually a bacterial infection which occurs in the pulp space of finger. But if they say there is a viral infection which occurs in the pulp space of finger, usually due to herpes simplex virus, then that is what is called as a Whitlow, herpetic Whitlow. So please remember, both are infections in the pulp space of the finger. But if it is bacterial in nature, it is called as a phelon. But if it is herpetic or if it is viral in nature, it is known as a Whitlow. So that's the basic difference. Next is this infection over here. You can see this is not the infection of a finger pulp. This is the infection of nail bed. So if they give you this image, infection of nail bed, that is the most common infection of hand. Please remember, this infection is the most common infection of hand. This is the most common infection of hand. So this infection of nail bed is the most common infection of hand, and that is what is called as paronychia. That is what is called as paronychia. You can see there is inflammation, redness, swelling and all of that. Along with that, you can see pus collection is also there. So management of paronychia is not only by giving antibiotics or by draining the pus. Antibiotics and drainage should be done only. But along with that, in majority conditions, we also need to go for a partial nail excision over here. You also need to go for a partial nail excision, and that is important to be remembered. Okay, this has been asked as well. Okay, partial nail excision has to be done in a case of paronychia in most of the condition. Next, if I talk about this type of a wound, what is this type of a wound? Usually on the shin or the leg area of the patient, and it is commonly associated with a condition that is called as IBD. What is IBD? I've told you IBD is inflammatory bowel disease, and this condition, IBD or inflammatory bowel disease, can be of two types. It can be either Crohn's disease or it can be ulcerative colitis. This type of a wound or an ulcer is commonly associated with ulcerative colitis. It's commonly associated with ulcerative colitis. And second condition where it can be seen is rheumatoid arthritis. So in these two conditions, this infection which is seen in the leg or the shin area, this infection is what is called as pyoderma gangrenosum. A previous year question again. This is called as pyoderma gangrenosum. That too has been asked twice in the examination, guys. Pyoderma gangrenosum. And pyoderma gangrenosum is again an ulcer. So you will say, sir, again, how to differentiate this ulcer? So please remember, this ulcer which is there, it has undermined edges. What do I mean by undermined? Inward edges. So this ulcer, as you can see, the edges or the margins of this ulcer are inwards. They are undermined. So if there is undermined edges of an ulcer, okay, so undermined edges of an ulcer in the leg or the shin area, it is likely suggestive of chancroid. So you will say, sir, undermined edges are also seen in other conditions. Yes, they are. They are also seen in case of a tubercular ulcer. But where is tubercular ulcer more common? Usually in the neck region. Tubercular ulcer is usually more common in the lymph nodes, area around lymph node. So tubercular ulcer also has an undermined edge, but it is common in the neck region. Second, it is seen in pyoderma gangrenosum, which is seen in the shin or the leg area, and it is associated with these two conditions. And third important, where we can see this undermined edges, is usually the chancroid. I hope all of you have studied derma. So in that you have studied that painful genital ulcer occurs due to Haemophilus ducreyi. That is known as chancroid. Over there also we can see a genital ulcer with undermined edges. Okay? So I'm covering all the topics, right? So that is what is called as integration, and that is how you need to study. Okay? Next one, you can see again a previous year question multiple times asked. Once they have given the image, another time they have mentioned the diagnosis clearly. And this condition, you can see multiple red patches all over the body of the patient, and they are changing their side. From one side, they are going to another side. So this is what is called as migratory necrolytic erythema. This is what is called as necrolytic migratory erythema, or migratory necrolytic erythema. It is called as migratory necrolytic erythema. Erythema is nothing but red patches or red rashes over the body. And why migratory? Because it keeps on changing sides from one side to another. Okay. And they have asked, thus migratory necrolytic erythema is associated with which condition or which malignancy? So please remember, this migratory necrolytic erythema is commonly associated with a pancreatic cancer and pancreatic malignancy. And that is what is called as glucagonoma. That is what is known as glucagonoma. Twice asked question in your exam. Okay, so this was also a recent NEET PG question and also came in the previous examination of FMG. Glucagonoma is commonly associated with this necrolytic migratory erythema. Next is this one. Here you can see there is a widespread infection in the leg of this patient, and you can see some balloons also, right? Blebs are formed, and these blebs contain nothing but gas. Okay, these contain gas. So this is a case of gas gangrene. This is a case of gas gangrene. I hope all of you are quite aware now. Gas gangrene is due to an organism. And what is the most common cause of gas gangrene? Okay, I'm waiting for your answer. Now this is a very easy question. All of you should be able to answer. Gas gangrene. What is the most common cause of gas gangrene? Now gas gangrene, why it is called as gas gangrene? Because this organism or this bacteria which is there, it produces a lot of gas. And here this infection can also spread to the whole body of the patient. The patient can land up into sepsis. There can be damage to all the muscles as well. Myonecrosis hota hai patient mein. And the patient can also die in cases of gas gangrene. That's important. Okay. So usually diagnosis can be done with the help of a biopsy and a culture. Biopsy and culture are required to make a diagnosis in a case of gas gangrene. Okay. What is the most common cause? Very good. Which species of Clostridium? Very good. It is Clostridium perfringens, previously called as Clostridium welki. So Clostridium perfringens is the most common cause of gas gangrene that you need to remember. Next is this condition. Both these conditions are necrotizing fasciitis. Both these conditions are necrotizing fasciitis. What do I mean by necrotizing fasciitis? So fasciitis in literal terms, I hope all of you are quite aware. Itis is nothing but inflammation. Inflammation of what? Inflammation of the fascia. So if there is inflammation of the fascia, definitely it is called as fasciitis. But when the fascia undergoes necrosis, that is what is called as necrotizing fasciitis. So it is such a severe infection where the fascia is undergoing necrosis. That is called as necrotizing fasciitis. There are two variants of necrotizing fasciitis. If the necrotizing fasciitis is seen in the scrotum, this is what is called as the Fournier's gangrene. If necrotizing fasciitis is seen in the scrotum, that is what is called as Fournier's gangrene, a previous year question of FMGE. Okay, that is the previous year question of FMGE. But if they say, and if they give you this image, which was given in the recent NEET PG examination 2023, if there is necrotizing fasciitis of the abdominal wall. So necrotizing fasciitis of the abdomen, please remember, this is what is called as the Melanese gangrene. Okay, necrotizing fasciitis of the abdominal wall is what is called as the Melanese gangrene. Okay, so these are the important two terminologies you need to remember. Necrotizing fasciitis of scrotum, Fournier's gangrene. Necrotizing fasciitis of abdominal wall, Melanese gangrene. Okay. Next, if I talk about sepsis, guys, we are talking about wounds now, so I'll just finish it off. Sepsis, if I talk about, sepsis is nothing but combination of two things. What is sepsis? So if you can see a known foci of infection, for example, if a patient is having some infection over here, the patient is having an ulcer over here, or the patient is having some boil over here, that is a furuncle, okay? So there should be a known foci of infection. There should be known foci of infection. But along with known foci of infection, to diagnose sepsis, there should be another thing as well. I hope all of you are quite aware, whenever a patient suffers from infection, the body tries to protect. And what is the protective response of body known as? The protective response of body is called as inflammation. But inflammation, yes, inflammation is a protective response of body. And when it is in the limits, it is fine, or it is rather beneficial for the body. But when the inflammation goes out of control, when the inflammation will go out of control, that will be damaging the body. Okay, and that out of control inflammation is what is called as SIRS. What is known as SIRS? Systemic Inflammatory Response Syndrome. If there is a known foci of infection, तुम्हें दिख रहा है कहीं infection, along with that there is SIRS, that is Systemic Inflammatory Response Syndrome. That means the inflammation has spread to multiple organs in the body. Okay, so all of these factors together is what is called as sepsis in a patient. Okay, yes, in Systemic Inflammatory Response Syndrome, the patient can either have hypothermia or hyperthermia. That means the temperature of the body can be either less than 36 degrees centigrade or more than 38 degrees centigrade. The patient's respiratory rate will be high. Tachypnea hoga patient mein, the respiratory rate will be more than 22 breaths per minute. The systolic blood pressure of the patient will be low, less than 90 millimeters of mercury. So all of these factors, at least two of these factors makes a diagnosis of SIRS. And if SIRS के साथ साथ अगर हमें infection दिख रहा है, that is what is sepsis. What is septic shock then? So septic shock is nothing but sepsis plus hypotension. So a lot of people will feel कि ये question नहीं पूछे जाते. Let me tell you, all of these questions have been asked. These are simplest definitions, and that you need to know, right? That you need to know. Yes, as doctors, you need to treat sepsis as well, na? So you need to know what is sepsis first of all. Septic shock is what? Septic shock is nothing but sepsis along with hypotension or decreased blood pressure. Okay, sepsis along with hypotension or decreased blood pressure is what is called as septic shock. Very good. And that hypotension or that low BP, if it is not corrected by fluids, then we can make a diagnosis of septic shock. That means the hypotension or the low blood pressure which is not responding to fluids, that is what is the case of septic shock. Next, assessment of septic shock or sepsis in a patient is usually done by help of a score, and that score is what has been asked in the recent FMGE examination as well as recent neetpg examination, and that is what is known as the SOFA score. Okay, so SOFA, what is the full form of SOFA? That has been asked again. So SOFA is nothing but sepsis related. SOFA is nothing but sepsis related or sequential. Okay, sepsis related or sequential organ failure assessment score. It is sepsis related or sequential organ failure assessment score. Okay, that is what is known as the SOFA score, and that will help you assess that how much severe the sepsis is in the patient or how many organs have been damaged due to sepsis in this patient. Okay, so sepsis related or sequential organ failure assessment score. But sepsis, a SOFA score, the traditional or the conventional SOFA score, उसमें बहुत सारे parameters होते हैं. There are many factors in the conventional SOFA score. Therefore, in cases of emergency, we follow nowadays the Q SOFA score. What does the Q, small q stands for? Q stands for quick. So it is quick sequential organ failure assessment score. That is known as the Q SOFA score. And the three parameters of the Q SOFA score has been asked in the recent neetpg as well as in recent FMGE examination. The Q SOFA score, you need to remember, it has three parameters remembered by the mnemonic bar. And the three parameters of the SOFA score are remembered by bar, where B usually goes for systolic blood pressure. B goes for systolic blood pressure when the systolic blood pressure of the patient is low, less than 100 millimeters of mercury. At least remember the parameters. Don't remember the criteria. At least remember systolic blood pressure. And A goes for altered mental status. Okay, A goes for altered mental status. And how do you assess mental status of a patient? Yes, you assess it with the help of a score called as GCS, Glasgow Coma Score. So sometimes they can mention altered mental status, sometimes they will mention GCS. So both of them are fine. And lastly, R. R stands for respiratory rate. R stands for respiratory rate. Okay, so if the respiratory rate of the patient is more than 20 breaths per minute, that is the third parameter of a Q-SOFA score. Okay, so important is Q-SOFA score has three parameters remembered by the mnemonic bar. B goes for systolic BP less than 100. A goes for altered mental status assessed with the help of a score known as GCS or Glasgow Coma score, and R goes for respiratory rate, where there will be a high respiratory rate more than 20 breaths per minute, that is tachypnea. Next, if I talk about some surgical swellings, important ones. This surgical swelling that you can see usually over the lateral or the outer canthus of eye, कोने में दिख रहा है यहाँ पे, okay, on the outer corner of eye. This is what is called as a dermoid cyst. This is what is known as a dermoid cyst. The same image had come earlier in your examination as well. Okay, so this is the case of a dermoid cyst. Please remember. Why a dermoid cyst is formed? Nothing but the epithelial elements, if they get trapped along the lines of embryonal fusion. Simple terms में समझो, only if the epithelial elements they get trapped somewhere in the body, that forms a dermoid cyst. So dermoid means nothing else but entrapment or collection of some epithelial elements. That is what is a dermoid cyst. Important is, what is the treatment of a dermoid cyst, guys? So important is, treatment usually of a dermoid cyst is nothing but surgical excision. That was another previous year question. Once they only asked you to make a diagnosis, other time they ask you what is the treatment of the above given condition. Answer is surgical excision. Okay, and the most common site which is shown in the image is the same one. It is the lateral or the outer canthus of eye only, most of the times. Okay, next is this swelling over here. What you can see, there is some swelling, small swellings over the scrotum of this patient. Rather, it is not single but multiple swellings over the scrotum of this patient. So this swelling can also appear on the scalp of the patient. It can not only be present over the scrotum, but sometimes it can also be present over the scalp. Why? What is common between these two sides? Scalp and scrotum में ज़्यादा क्या common होता है दोनों में से? So in both these sides we have hair follicles. In both the sides, whether it is your scalp or whether it is your scrotum, we have hair follicles. ठीक है? And what opens along with the hair follicles? I hope all of you are quite aware. Along with the hair follicle, a gland opens on the skin. Along with the hair follicle, a gland always opens, and that gland is what is called as your sebaceous gland. That gland is what is called as your sebaceous gland. So if the hair follicle duct or the sebaceous duct gets blocked, then we can get this type of a swelling, and this swelling arises from the sebaceous gland itself, and therefore this type of a cyst or a swelling which is formed is known as a sebaceous cyst. Okay, this is what is a case of a sebaceous cyst. Important is, sebaceous cyst is more common in the scalp or the scrotum because it is nothing but swelling arising from the sebaceous gland, and we know sebaceous gland always opens along with hair follicles. So when the hair follicular duct gets blocked, that causes formation of a sebaceous cyst. Okay, treatment over here is again a surgical excision. Treatment over here is again a surgical excision of a sebaceous cyst. Please remember that. Okay. Very good. Next important is this swelling, which has come a lot of times in the NEET PG examination, and it can anytime come in your FMG examination. What you can see, the patient is having a cheek swelling over here. But important another feature is, this cheek swelling is also elevating the lobule of the ear. Okay. So if the ear lobule is lifted up due to a swelling, if the ear lobule, अगर ये ear lobule जो है वो अगर ऊपर उठ रहा है due to the swelling, cheek swelling, this is what is the characteristic or the hallmark feature of a parotid swelling. This is what is the characteristic feature or hallmark feature of a parotid swelling. So how to differentiate a parotid swelling? Please remember, what is the hallmark of a parotid swelling is important. The hallmark of a parotid swelling is usually the ear lobule is lifted up. Ear lobule is lifted up in a case of parotid swelling. Why there will be a swelling arising from the parotid gland? It can be just an infection of the parotid gland, that is parotitis, and parotitis is commonly seen in children during an episode of mumps. Okay? So in a case of mumps it can happen, or it can also arise due to a parotid tumor, and the most common parotid tumor we know it is pleomorphic adenoma. Okay, so in both these conditions there can be this parotid swelling, and please remember, this is the way to differentiate parotid swelling from all other cheek swellings. So parotid always causes lifting up of the ear lobule. Next is this swelling over here. This swelling which is seen in the floor of mouth. Yes, the swelling which is seen in the floor of mouth. This is what is called as a ranula. And what is ranula? Ranula is nothing. It is a cyst. What is a cyst in simple terms? Cyst का मतलब होता है sac. Okay, cyst means sac, and that sac contains some kind of fluid inside it. Okay, so here you can see a sac or a cyst which is there, which is present in the floor of mouth. A cyst present in the floor of mouth. And what does this cyst contain? This cyst contains a lot of mucus inside it. Okay, this cyst contains a lot of mucus inside it. So a mucus containing cyst, okay, a mucus containing cyst in the floor of mouth is what is known as ranula. And the ranula usually involves which gland? So please remember, the ranula generally involves the sublingual salivary gland. Ranula commonly involves the sublingual salivary gland. Okay, and if I try to flash a torch from here, if I try to flash a torch, what will happen? The whole swelling will glow up. Okay, the whole swelling will glow up, okay, due to the light of the torch. And that is what is called as which test? That test is known as the trans illumination test. That test is what is called as the trans illumination test. So the trans illumination test is positive. The trans illumination test is positive in cases of ranula. Trans illumination test is also positive in other swellings. And what are those other swellings? So please remember this trans illumination test. That means when the swelling will glow with light after flashing a torch. This trans illumination test is positive in cases of ranula. It is positive in cases of a neural tube defect known as meningocele, when there is only meninges and CSF inside the cavity, meningocele. Third important, it is also positive in a case of hydrocele. Okay, hydrocele, which is a swelling arising in the scrotum. And fourth, it is also positive in a cases of a posterolateral neck swelling known as cystic hygroma. So cystic hygroma, hydrocele, ranula and meningocele are the four conditions where you need to remember these swellings are brilliantly trans-illuminant. What is the treatment? So treatment is, please remember, usually it is the cyst excision. The cyst or the sac which is there now, you need to remove that cyst. So cyst excision along with sublingual gland excision. Yes, you also need to remember the sublingual gland. Otherwise, again there will be ranula formation. So sublingual gland excision should also be done. No issues with this, anybody? So that was all about your wounds and the swellings as well. We have covered. So next will be trauma. So let's take a break. Okay. Let's take a break and then we'll start with trauma because I want all of you fresh for trauma. Okay? Chalo. Thank you so much. Shall we start? Am I audible? Please let me know if the audio visuals are clear. Please let me know if the audio visuals are clear, guys. Jaldi se. Hopefully the audio visuals are clear. No. We can begin then. Can we? Can I start? Please let me know. Give me a thumbs up in the chat box so I can just begin. Am I audible? Yeah. Okay, sure. Now starting with trauma now. Okay, a very important and interesting topic that you need to remember, and that is what is trauma. So if I talk about trauma, guys, important is the first thing that you need to remember. Why is trauma so much important? Because we know a lot of people nowadays are facing road traffic accidents every day, right? And they sustain a lot of trauma, and then they come to the emergency. They are brought to the emergency, and usually the frontliners who deal with them are mostly the surgeons, right? So usually they are the emergency medicine people or the surgeons who have to deal with them, and definitely the orthopedicians as well. Now, important is you need to remember trauma. Why? Because a lot of deaths occur after trauma. Now, if they ask you what is the most common cause of death after trauma, so if they ask you what is the most common cause of death after trauma, now there are usually three types of deaths which occur. Please remember, after trauma, if there is immediate death on spot, okay, that is what is called as a immediate death. If the patient dies on spot itself, that is called as a immediate death. And the most common cause of immediate death, as well as overall also, the most common cause of death after trauma is usually a severe head injury. The most common cause of on-spot death or a immediate death after trauma is usually a severe head injury. That's important. Other cause can be transaction or injury to the main blood vessels of your body. Okay? Injury to the main blood vessels of your body as well. Okay? So that can be immediate causes of death. What are early causes of death? Early causes of death after trauma. What is the early cause? So usually early causes, that means the patient dies within 1 hour of trauma. So if the patient dies within 1 hour of trauma, usually the causes of death can be multiple. Okay, so few causes you need to remember. So one of the cause can be airway obstruction. Yes, the patient's airway was completely blocked. Okay, so one of the causes can be airway obstruction. Other cause can be pneumothorax in the patient. Okay, other cause can be pneumothorax in the patient as well. Okay, apart from that, the patient can also have cardiac tamponade. Yes, the patient can have a cardiac tamponade that can lead to death. Or the patient had a circulatory arrest. That means the patient went into shock, severe shock. So the patient had a acute circulatory arrest. There was a severe shock in the patient. Or sorry, or the patient had a severe tracheobronchial injury. Okay, the patient had a severe tracheobronchial injury as well. Or the patient had a massive hemothorax. What is hemothorax? Collection of blood in the thoracic cavity. Where thoracic cavity mein? Exactly around the lungs. That means in the pleural cavity. When there is excess collection of blood in the pleural cavity, that is what is hemothorax. When there is excess collection of blood in the pericardial cavity, that is what is cardiac tamponade. Okay? So these are the important causes of death after trauma within the first hour of trauma. Okay? So that's you need to remember. So usually, if they ask you what is the golden hour after trauma, so please remember your answer should be the first hour after trauma is considered as golden hour after trauma, because if we give medical help to the patient within this 1 hour of trauma, if we give medical help to the patient within this 1 hour of trauma, most of these deaths can be avoided. Okay, most of these deaths can be avoided. So that's the important thing. That's the reason why the first hour after trauma is called as the golden hour after trauma. And platinum minutes are, so platinum minutes are usually the first 10 minutes after trauma are known as the platinum minutes usually. ठीक है, तो पहले 10 मिनट को platinum minute बोला जाता है और पहले घंटे को trauma के बाद is called as a golden hour. Next, if I talk about triage now. So what do I mean by triage? Basically, if a patient, for example, okay, there was a bus accident or a train accident in a specific area, and that area is usually in the periphery. Okay, it only has a very small hospital over there. It has very small hospital. There is only a single government hospital over there. Now what will happen? There will be a lot of people who require medical help, that too at the same time. All of these people will flood the hospital at the same time, and we will not be able to manage all the patient at once, definitely, because the workload will be limited. Okay, the workforce will be limited. That's the reason why we need to segregate the patient, we need to categorize the patient. ठीक है, once in Hindi. So please remember, एक जगह पे बस एक्सीडेंट या ट्रेन एक्सीडेंट हुआ है, उसके बाद क्या हुआ, 30-40 लोग एक साथ बहुत ज्यादा इंजर हो गए. नाउ सबको एक साथ मदद की जरूरत है. अब सबको तुम एक साथ मेडिकल हेल्प दे सकते हो क्या? नहीं, क्योंकि उस इलाके में बस एक अस्पताल है और वहां पे लिमिटेड वर्कफोर्स है. ठीक है, तो ऐसे टाइम में क्या करना पड़ेगा, तुम्हें पेशेंट्स को सेग्रीगेट करना पड़ेगा, कैटेगराइज करना पड़ेगा, या अलग अलग कैटेगरी में बांटना पड़ेगा. ठीक है, सो दैट इज व्हाट इज ट्रायज. So please remember, what is triage in simple terms? Triage means nothing else but it is segregation of patient. Triage means nothing but segregation, or we can say separation, we can say categorization also. So triage is nothing but segregation of patients, when usually during a case of mass casualty. What I described right now, like a bus accident or a train accident, is a case of mass casualty, when many people require help at the same time. Or in a case of disaster, for example, floods, earthquakes, that you might have studied in PSM. So it's one and the same thing over here as well. Okay, so in a case of disaster, when a lot of people require medical help at the same time. So that is segregation of patients in a case of mass casualty or a disaster based on two parameters. And what are these parameters? So one is likelihood of survival, and second is severity of injury. Likelihood of survival means what? Which patient can be saved. Okay, and second is severity of injury. हिंदी में these patients are divided. ये कैसे डिवाइड करे जाते हैं? दो फैक्टर्स पे बेस्ड. फर्स्ट इज डेफिनेटली which patient can be saved. That means कौन सा पेशेंट बचाया जा सकता है, उसको बोलते हैं likelihood of survival. And second, कौन सा पेशेंट ज्यादा severely injured है, that is called as severity of injury. Both of these parameters definitely are taken into consideration when we need to segregate the patient. But important among them, one factor if they ask you, then answer should be likelihood of survival. Why? Because likelihood of survival is the better factor जिस पे we will categorize or we will segregate the patient, followed by severity of injury. Both are factors, both parameters are definitely taken into consideration, but the major factor which is taken into consideration is likelihood of survival. That means कौन सा patient बच सकता है. Please remember that. Okay, don't worry Abhinandan, please remember whatever I am saying in Hindi is I have already spoken in English as well. Please remember, whatever I am speaking in English, that I am repeating in Hindi for those people who are finding it difficult to follow up with me in English. Okay, so we need to take care of both of them, right? So I am using both the languages. Don't have that fear that I am saying something different in Hindi. No, please remember, I am saying this and repeating the same thing in Hindi also. Okay, but we need to consider everyone over here, right? So that's the important thing. So that is what is triage. So once they have only asked you the definition of triage. So triage is nothing but segregation or separation of patients into various color-coded categories based on likelihood of survival followed by severity of injury in various color-coded categories. And what are these four color-coded categories in which we will categorize the patient? The first one, the highest priority is given to the red category. The highest priority is given to the red category. So please remember, the red category is given the highest priority, and definitely here we have patients who require some urgent intervention. Okay, who require some urgent intervention. Which kind of patients usually? The patients who are gasping, for example, or the patients who are having huge blood loss. So the patients who require basic resuscitation. Okay, the patients who require immediate basic resuscitation, they are the patients who come in the red category. Or the patients who require a limb or a life-saving surgery. The patients who require a limb or a life-saving surgery. The patients who require a limb or a life-saving surgery within a span of 6 hours. So within a span of 6 hours, if the patient is requiring a limb or a life-saving surgery, that is what is the red category. अगर 6 घंटे के अंदर patient को कोई surgery की जरूरत है, that is what is red category patients. No issues with this, anybody? Next is what is the yellow or the blue category patient. So if I talk about the yellow or blue, some places have the yellow category, some places have the blue category. So it's one category only. So yellow or blue category, these patients are given high priority. These patients are given high priority. And which are these patients? These are the patients who now don't require resuscitation. These possibly may require resuscitation. Okay, अभी जरूरत नहीं है उनको resuscitation की, but आगे जाके पड़ सकती है. So the patients who possibly might require resuscitation, or the patients who require a limb or life-saving surgery. The patients who require a limb or a life-saving surgery in a span of 6 to 24 hours. Okay, in a span of 6 to 24 hours. Not immediately within 6 hours, but yes, within span of 24 hours, they might require a limb or a life-saving surgery. Okay. Next, the third category is what is the green category. And what are these green category patients? So these green category patients are low priority patients. Green category patients are low category patients. Who are these patients? Those patients who are having some minor injuries only. Okay. The patients who are having only minor injuries, they are categorized in the green category. So these are chalta filta patient. Okay, the patients who are walking easily, these are known as ambulatory patients. Okay, so the patients who can walk only are having minor injuries are known as ambulatory patients, and they are categorized in the green color category. Okay, so ambulatory patients or patients with minor injuries, they can say, or they can say walking wounded patients. Okay, they are wounded definitely, but they are having very small wounds, therefore they are easily walking as well. And the last category, which is given the least priority, okay, they are treated at last. So the ones which are giving the least priority are the black color coded category. Okay, they are known as the black color black category patients. They are given the least priority. And please remember why I said that severity of injury is the second most important factor, because if severity of injury would have been the most important factor, then black color coded category should have been the most preferred category or the most prioritized category. ऐसा है क्या? नहीं. So that's the important thing now. Now you understand me? So please remember, black color coded category is the least prioritized category. They are given least priority because these are the most severely injured patients who cannot be saved. So which are the patients in black color category? Usually these are the dead patients, or these are the moribund patients, okay, who are about to die, or they are unsalvageable patient, and that was the term which was used, unsalvageable. That means the patients who could not be saved. Even after your best efforts, you cannot save the patient. These patients will be called as unsalvageable patient. Okay, so dead, moribund, or unsalvageable patients are categorized in the black category. No issues with this, anybody? So this is what is called as triage, a very important question of your examination. Next, if I talk about, once definitely a patient is categorized at the site of injury or at the site of accident itself, or if the patient has not been categorized, once the patient is brought to the hospital, you need to categorize the patient, or you need to perform the triage of a patient. Okay, then you know which patients should be given the most priority and which should be given the least priority. Okay. Now once you start the resuscitation of the patient, what do I mean by resuscitation? I've told you all the things that you do to save a life of a patient. Okay, so the protocol or the guidelines that you follow to save the life of a patient is what is called as resuscitation in short. Okay, now that resuscitation in a case of trauma is usually done with the guidelines, and these guidelines are usually known as ATLS guidelines or a ATLS protocol. What is ATLS? You need to know the full form. ATLS is nothing but advanced trauma life support. ATLS is nothing but advanced trauma life support. Please remember that. Okay, so advanced trauma life support is definitely the guidelines that you need to follow while saving the patient who has come to you after a trauma. Okay, so that is what is advanced trauma life support. Important is what is the sequence which is followed for resuscitation in a case of ATLS protocol. So if you are performing resuscitation in a patient, if you are trying to save a life of a patient after trauma, okay, you are following some guidelines. Those guidelines are called as ATLS protocol. Now what is the sequence to be followed? Will you give highest priority to the airway, or will you give highest priority to the circulation of this patient? So is it A, B, C, D, or is it C, A, B? What is your answer? Fat. I need answers now. What is the sequence for resuscitation? That was a previous year question again. What is the sequence for resuscitation according to ATLS protocol? What is the sequence of resuscitation, guys? Sorry. Let me know once the sequence of resuscitation which is followed. Anybody? Chalo. I'll tell it to you. So this has been asked. It is A, B, C, D, E. Yes, airway has to be given the highest priority, followed by breathing, followed by circulation, followed by disability, followed by exposure. Okay, so please remember, what does this A, B, C, D, E stand for? So please remember, A stands for airway management. You need to take care of the airway of this patient, airway management. B stands for breathing management. Okay, you need to look out for any problems in breathing of this patient. C stands for circulation management. C stands for circulation. Important previous year question. What does D stand for in a ATLS protocol or in a sequence of resuscitation? That has been a question in FMGE examination. So we know now D stands for what? D stands for disability management. Okay, so D stands for disability management. It does not stand for any dehydration or anything else. Okay, so D stands for disability management, was a PYQ. And lastly, E stands for what? E stands for exposure with environmental control. So E stands for exposure with environmental control. Okay, I'll talk about these, don't worry about that. Okay, so E stands for exposure with environmental control. Now you will say ki sir, CAB protocol is followed where now? So please remember, CAB is the protocol where circulation is given the utmost priority. This sequence is generally followed if a patient has underwent a cardiac arrest. That means you are standing on an airport and there a patient suddenly collapsed. Okay, so the patient was suffering from cardiac arrest. There was no pulse in the patient, no breathing efforts were seen in the patient. Okay, so such a patient who is under cardiac arrest, the protocol that we follow is not the ATLS one. Then the protocol is known as a BLS protocol, that is known as basic life support, or it is called as ACLS, that is advanced cardiac life support. Okay, so BLS or the ACLS protocol is followed. Please remember, if a patient has underwent a cardiac arrest, and then the sequence which is followed, then the utmost priority should be given to circulation management, and we immediately start chest compressions on that patient. So that is the topic of medicine and anesthesia. You will discuss it over there. No issues with this. Let's continue with trauma now, ATLS. Okay. So if I talk about surveys in a patient of trauma, okay, so usually as we initiate the ATLS protocol, okay, as we initiate or as we start the ATLS protocol in a patient, we need to do two types of surveys. And what are these two types of surveys? One is called as a primary survey. And what is done in a primary survey? Resuscitation is done in a primary survey, and which sequence is followed, that we have already discussed. It is A, B, C, D, E. Okay, so primary survey is nothing but the survey which is done for resuscitation. That is the sequence followed is A, B, C, D, E. The next one that we do is called as a secondary survey. The next one that we do is the secondary survey. In secondary survey, we do important two things. One, we try to collect the history of a patient. And that history is what is called as the ample history. We try to collect the history of a patient known as ample history. A stands for what? So please remember over here, the A stands for allergies. Okay, if the patient is having any kind of allergy, if the patient could not speak because if the patient is in trauma, if the patient is in coma or he is unconscious, then you should ask the attendants of the patient, okay, or whoever has brought the patient to the emergency. Okay, so you need to see whether the patient has any kind of allergies. Second, you need to see whether the patient is having any medical condition. That means if the patient is suffering from any diabetes mellitus, hypertension or anything else, or if the patient is taking some medicines, if the patient is currently taking some medications. Then P stands for what? P need to stand for any past history of the patient. That means whether the patient has underwent any surgery in the past, koi surgery hui hai nahi hui, past history should be taken. Or P also stands for pregnancy. If it is a female in the reproductive age group, you also need to take the history of pregnancy in the patient. L stands for what? Usually L stands for last meal, because in most of the cases of trauma, we need to intubate the patient. Okay, so that's the reason why we ask about the last meal of the patient as well. Please remember that. Okay, so last meal of the patient should be asked, because if we need to take the patient for intubation or for surgery, we need to give anesthesia, and if we give anesthesia, the risk of aspiration will be very high. Okay, so that's the reason we need to ask about last meal. And E for events which have caused trauma. The events which has caused trauma, you need to ask about that as well. And second thing that you do in a secondary survey, okay, apart from taking the ample history, the second thing that you do is usually search for all injuries. Okay, search for all injuries, because in the primary survey, you are busy saving the life of the patient. Okay, you are busy resuscitating the patient. Once you have saved the life of a patient, now search for all other injuries that the patient has sustained. कोई भी और injury patient में हो तो उसको देखो एक बार. Look everywhere to search for these injuries. Okay, so now if I talk about one by one, A stands for airway management. So usually airway management is not done alone. Airway management के साथ साथ we also go for cervical spine protection. Along with airway management, we also go for cervical spine protection. When do we give cervical spine protection? When we suspect that the patient has sustained a cervical spine injury. That means जब हमें लगता है कि patient की cervical spine में कोई चोट लगी है. In that condition, we need to give utmost priority to the cervical spine protection. Please remember, yes, cervical spine protection precedes over airway management. Yes, very important. Okay, cervical spine protection को ज़्यादा महत्व दिया जाता है even before airway management. Reason is, if there is a cervical spine injury, for example, if there is a cervical vertebra का fracture in a patient after trauma, what will happen if this cervical vertebra ka fracture is there, okay, and if you try to extend the neck of the patient, if you try to extend the neck of the patient, what will happen? Now this fractured cervical fragment, this fractured fragment of the cervical vertebra go and hit the medulla oblongata. It goes and hits the medulla oblongata, and we know medulla oblongata is a very important organ of your body which contains the vital centers of your body. Your respiratory center and the cardiovagal center both are located in the medulla oblongata. If the medulla oblongata is injured, the patient will die on spot. Okay, so that's the important thing. इसीलिए that's the reason why cervical spine protection is given the utmost priority even before airway management. And in cervical spine protection, what should be done? We should try to immobilize the cervical spine. We should not move the cervical spine. Immobilization of the cervical spine is done. Usually how that should be done? Usually you should transport the patient on a hard surface and you should strap the patient usually. Okay, so that the patient should not move. Okay, or you can just stabilize the cervical spine of the patient. Okay, so that should be done. Immobilize the cervical spine. For that, generally we apply a hard cervical collar, and that hard cervical collar that we apply is also known as the Philadelphia collar. Around the neck of the patient we apply a hard cervical collar known as the Philadelphia collar. No issues with this, anybody? That's important. Then if I talk about airway management, guys, when are you going to manage the airway of a patient? When you feel that the airway is blocked or the airway is obstructed. How do you get to know that the airway of the patient is obstructed? So there are some danger signs which can tell you that the patient's airway is blocked. And what are these danger signs which are going to tell you the patient's airway is blocked? First important is the patient is unable to speak. So if the patient is unable to speak, that means there can be some obstruction in his airway. First thing. Second important sign, if the patient GCS is very low, that means a GCS of less than equal to 8, the Glasgow Coma score of less than equal to 8, which is also suggestive of severe head injury. In that condition also, you need to manage the airway of the patient. Third important, if the patient is in coma, comatose patient, okay, so comatose patient is also at a risk of having some airway obstruction as well, okay, or there can be aspiration as well. Important next one, if there is any facial trauma. So if there is any facial or neck trauma, there will be higher chances of airway obstruction in this patient as well. Okay, so any maxillofacial injuries in the patient, okay, neck injuries in the patient. Okay, so all of these are signs, danger signs that you need to manage the airway. And for airway management, what is the definitive airway of choice? If a patient comes to you with some airway obstruction, first of all, what should be done? If a patient is having some problem with airway, if there is some airway obstruction, guys, if there is some airway obstruction, you will try to clear the airway, right? You will try to clear the airway. That means if there is some foreign body in the airway, you will try to remove that foreign body particularly. Okay, so important is that. But if there is no foreign body, there are a lot of secretions in the airway. What do I mean by secretions? A lot of blood is present, a lot of fluid is present in the airway of this patient, due to which he is not able to breathe or not able to speak. So definitely you will do suction of all these secretions. All of these secretions should be removed. That is, suctioning should be done. And even after that, the patient's airway is not opened up properly, then you will go and perform these manures. And these manures have been given in the recent NEET-PG examination, and they have also appeared in the FMGE examination earlier. So this was the recent NEET-PG exam question. Okay, so which is the manure followed in a case of ATLS protocol. This manure to open up the airway of this patient. So you can see when this manure is performed, the airway is straight now. Okay, the airway will be straight in this patient. This manure is known as, what are we doing? We are tilting the head of the patient and we are lifting the chin of the patient. This is what is called as the head tilt and a chin lift manure. This manure is known as the head tilt and a chin lift manure. So that should be done. Okay, so head tilt and a chin lift manure should be done in a patient to open up the airway properly. The next one that you have is called as the jaw thrust manure. Here you will give a sudden jerk or a sudden thrust to the jaw of the patient, so that if the airway is blocked also, it should open up. Okay, so this is known as the jaw thrust manure. Okay, it is known as the jaw thrust manure. So these are the two manures that we can perform to open up the airway of the patient properly. No issues with this, anybody? That was about your airway obstruction. Okay, then definitely if the patient's airway is blocked or the patient is not able to breathe properly, okay, we will also assess the breathing of the patient. We will see what is the rate of breathing, that is respiratory rate. We will see if the chest is rising equally on both the sides or not, or if the patient is having a deep breathing or not, or only the patient is having that is a shallow breath, okay, and we will try to assess there is enough oxygen saturation of the patient or not with the help of a pulse oximeter. Okay, so breathing management should also be done. Breathing assessment should also be done. If the patient is not able to breathe properly, then definitely we need to insert a airway from outside. And what is that definitive airway of choice? What we generally do if a patient is not able to breathe, definitely we try to insert some endotracheal tube. Okay, so we try to insert an endotracheal tube inside the throat of this patient or inside the airway of this patient. And where this tube goes? This tube goes till the trachea. It crosses the vocal cords and it will go till the trachea. So therefore it is known as the endotracheal tube. Okay, that's important. So definitely we will go for an intubation. Endotracheal intubation, to be specific, we'll go for an endotracheal intubation. Now I hope all of you will cover it in anesthesia also. The laryngoscope which is used for endotracheal intubation, it is a curved blade laryngoscope in a case of adult called as Macintosh laryngoscope, and a straight blade laryngoscope in case of pediatrics known as the Miller's laryngoscope that you might have studied. Okay? If I talk about endotracheal intubation, that means insertion of an endotracheal tube into his airway. Okay, that is the definitive airway of choice in a case of airway obstruction or in a case of breathing problems in a patient. If it is not possible, why endotracheal intubation will not be possible? Because to insert an endotracheal tube, the vocal cord should be visible, right? But if you are not able to see the vocal cords only, why? Because there's a lot of blood in the throat of this patient, therefore vocal cords are not at all visible. Or if there is a lot of swelling of the airway, yes, there's a lot of swelling of the larynx, and that is the reason why the vocal cords are not visible. Or if the patient is having a maxillofacial injury, therefore there's a lot of bleed and again the vocal cords are not visible. Or if the patient is having a cervical spine injury, and I've told you, if a patient is having cervical spine injury, can you extend the head of the patient or extend the neck of the patient? No, because there will be risk of injury to the medulla oblongata. That is the reason why if a patient is having a cervical spine injury, you cannot extend the neck, and if neck could not be extended, definitely endotracheal intubation is very much difficult. Or if the patient is having a very short neck, okay, in all these conditions, definitely endotracheal intubation is not possible. Or if you tried but you failed, okay, if endotracheal intubation fails, then definitely what are the two airways of choice that we have? So usually we have some emergency airway of choice which will not take time, which will be a very rapid procedure, and second, it will be time taking but it will be the best procedure, that is the definitive airway of choice. So if endotracheal intubation fails, definitely please remember, either we will go for an emergency procedure, and that is what is called as needle cricothyroidotomy. What do I mean by this now? Needle cricothyroidotomy. You might have studied in ENT. There is a cricothyroid membrane over here on the neck. Where is this? Between the thyroid cartilage and between the cricoid cartilage. We have a membrane known as cricothyroid membrane. On this cricothyroid membrane, if we are inserting a needle, a wide bore needle, okay, what will happen? Some amount of air can at least pass via that needle. That process is what is called as needle cricothyroidotomy. Important is, needle cricothyroidotomy cannot be done in smaller children. Okay, with children usually it is contraindicated in children less than 12 years of age. Why? Because you can see this cricothyroid membrane lies very close to the subglottis of the children. Okay, subglottis is the lowermost part of larynx. It lies close to the subglottis. And if you insert a needle over here, there will be edema at this site, and that edema will cause subglottic narrowing, that is called a subglottic stenosis, and the airway can close again. So therefore it is contraindicated in children less than 12 years of age due to the risk of subglottic stenosis. That's the important thing. Okay, but if they ask you, important is, what is the definitive airway of choice? So you will say, sir, why needle cricothyroidotomy is not the definitive airway of choice? So as I've told you, it is only a needle which is inserted over here, and it is like very small amounts of air can go. At least it can keep the patient alive for a span of only 2 to 4 hours. Okay, otherwise there will be subglottic stenosis there also. In a span of 2 to 4 hours, that airway is going to close. So for definitive management, definitely, or the definitive airway, we will go for another method, and that another method is what is called as tracheostomy. That means this time we are not going to make an incision or insert a needle over here. We are going to make an incision over the trachea. I hope all of you are quite aware. Trachea is made up of multiple cartilaginous rings, and in between the rings we have some membrane. Okay, so we are going to give an incision over the membrane over here. And then we are going to insert a tube, and that tube is what is called as a tracheostomy tube. Okay, so the definitive airway of choice will be tracheostomy if the endotracheal intubation fails or if it is not possible. Tracheostomy, once we do, what is the best site for tracheostomy? Between which rings? So that's important again, important question. So the best site for tracheostomy, I hope all of you are quite aware, it is mid tracheostomy, which is done between the second and the third tracheal rings. The best site for tracheostomy is between the second and the third tracheal rings usually. That's the best site for your tracheostomy. No issues with this. And tracheostomy se bhi there was a question in recent neetpg examination and even in FMG as well. Therefore, these are important topics to be remembered. As I've told you, now there will be a lot of topics which are clinical based. Okay. So now if I talk about tracheostomy, as I've told you, here we can insert two types of tubes. Either it can be a cuffed tracheostomy tube or it can be an uncuffed tracheostomy tube. Okay. Cuff is nothing but this balloon which is there. Okay. This cuff or the balloon which is there. Now please tell me guys, this cuff, what is the role of this cuff? That has been asked. You can see nowadays the endotracheal tubes also have a cuff. The endotracheal tubes also have a cuff, and that has been a very important question and a repetitive question of exam. What is the role of a cuff or balloon? Okay, so please remember, is it used for fixation of the tube? Is it used for fixation of the tube? This is the cuff. We inflate the cuff. Okay, in a endotracheal also and in a tracheostomy tube also we have this cuff. Okay, so please tell me, what is the role of this cuff tubes? What is the role of the cuff tubes? Whether it is a tracheostomy tube or endotracheal tube, what is the role of a cuff tube? Very good, very good. It is used to prevent aspiration. It is used to prevent aspiration because once you have inserted endotracheal tube in a patient, okay, once you have inserted endotracheal tube in a patient, okay, and the patient is kept on ventilator, now the patient should not start breathing by himself. Therefore, the patient is given anesthesia and the patient is given muscle relaxants. Now, as these muscle relaxants are given, all the muscles of his body are paralyzed, including the respiratory muscles. Okay, so that's the important thing. Now, what will happen? The laryngeal muscles are also paralyzed. That is the reason why definitely the patient will not have any cough reflex or gag reflex. So, if there is no cough reflex, there is no prevention. Anything can enter into the trachea and finally it can go into the lungs. Okay, anything can enter into the trachea and it can finally reach to the lungs of this patient. So there will be high risk of aspiration. Okay, so anything can go into the lungs. This is known as aspiration. The patient can develop pneumonia further or lung abscess as well. That's the reason why usually in patients who are mechanically ventilated, that means the patients who are on ventilator, they are given anesthesia also now. That means muscle relaxants. That means usually these patients should be having a cuff tube, otherwise there will be high risk of aspiration in this patient. Okay, so that's the important thing. That was the question again. One was asked, keep cuff tubes are preferred for what purpose? So they are preferred for preventing aspiration. And second, they are used in which patient? That was a recent question. So they are used usually in ICU patients, okay, or they are used in comatose patients because the risk of aspiration will be high in this patient. So they are generally preferred in ICU or comatose patients. Important is that. No issues with this. Now, if I talk about endotracheal intubation, as I've told you, only important things. Endotracheal intubation. This endotracheal tube can be either inserted via the oral cavity, then it will be called as orotracheal intubation. That is commonly done. So more commonly we prefer orotracheal intubation also. But sometimes we can also insert this endotracheal tube via the nose or the nasal cavity as well. Then it is called as nasotracheal intubation, which is very less commonly done. And nasotracheal intubation is absolutely contraindicated. Nasotracheal intubation is absolutely contraindicated if a patient is having a base of skull fracture. If a patient is having a base of skull fracture, the tube can go directly into the cranial cavity. And that's the reason why it is contraindicated in a patient of base of skull fracture. Okay? So that's important about the airway and breathing management of the patient. Next, if I talk about the circulation management of the patient. If I talk about circulation management, important is the question has been, सबसे पहले सर्कुलेशन मैनेजमेंट में क्या करना चाहिए? सो फर्स्ट ऑफ ऑल यू नीड टू प्रोसीड विथ हेमरेज कंट्रोल. That means if you see the bleeding side, you try to control the bleeding of this patient. And what is the best method to prevent bleeding? The best method to prevent bleeding is by applying direct pressure. The best method to prevent bleeding is by applying direct pressure. So if you do not have anything, what do? You try to apply pressure with the help of your hand. Okay, that should be done. If you have a cloth, try to apply the cloth around the bleeding site. Or if you have a pelvic binder, that is usually used in cases of pelvic fracture. We know pelvic fracture causes 1.5 to 2 liters of blood loss, and that can land up the patient into hypovolemic shock. Okay, excess of blood loss now. Therefore, in a case of pelvic fracture, always try to apply pelvic binder. If that is not available, tie a cloth around the pelvis of the patient. Okay, so that should be done. So direct pressure is the best method to control hemorrhage or bleeding in a patient. Now, circulation management is done by what? Once you have controlled the bleeding, definitely you need to start fluids in the patient to prevent any kind of hypovolemic shock in the patient. And that is usually done by, you need to give a lot of fluids, but cautious. Nowadays, we don't give excess of fluids, and that has been written in Bailey as well. Please remember, you usually take IV lines in the patient, okay? You try to get intravenous access in the patient, okay? And the question was, minimum how many gauge cannula should be inserted in a case of trauma or during resuscitation? That was a question. Minimum how many gauge IV lines or minimum how many gauge cannula should be inserted in a case of trauma or during resuscitation in a patient? So minimum, if they ask you, please remember, minimum 2 18 gauge IV lines are to be inserted. Minimum 2 18 gauge IV lines or IV cannulas are to be inserted. And 18 gauge were which color? 18 gauge were green in color. Yes, recommended are, please remember the difference, what I'm trying to say. Recommended are orange or gray only because they are responsible for rapid transfusions. That is what we need during a trauma. But important is, if those are not available, if orange and gray are not available, minimum which can be used? Minimum is 2 18 gauge IV lines. Okay, minimum 2 18 gauge IV lines, because from both the sides we will start fluids to the patient. Okay, and how much amount of fluid should be given to the patient? Okay, how much amount of fluid should be given to the patient? So usually Bailey clearly says 1 liter of crystalloid should be given. Initially it was 2 liters, but now ATLS clearly says it is 1 liter of crystalloid should be given to the patient. And which are crystalloids? The crystalloid fluids are nothing else but Ringer lactate or normal saline. So Ringer lactate or normal saline should be given to the patient, 1 liter of crystalloids. Along with that, we will also try to control the bleeding of the patient. Don't give excess of fluids, and no colloids are given immediately. Colloids are given later on if required. Okay? Apart from this, definitely we will try to control bleeding if it is not controlled yet with the direct pressure. And that is done by giving injection of tranexamic acid. That is usually done by giving an injection of tranexamic acid. Tranexamic acid is also known as Tranexa commonly. It is a drug which helps in controlling or stopping the bleed. Okay, here 1 gram is given in a span of first 10 minutes. Okay, 1 gram is given in the span of first 10 minutes. Pehle 10 minute mein 1 gram chadha do, and then next 1 gram is given over the next 8 hours. The next 1 gram is given over a span of next 8 hours. Okay, so that is what is done. Please remember, blood transfusion can be given if you suspect that the patient is in class 3 or class 4 hypovolemic shock. Okay, so in severe varieties of shock, we can also prefer blood transfusion. But initially, we will only manage the patient with crystalloids or fluids. Okay, so if blood transfusion is available, then that can be done, but only in severe varieties of shock. No issues till anybody. So that was all about your circulation management. Next was disability management. Disability management mein nothing else has to be done. Disability mein usually you try to manage the disability related to his nervous system of the patient. Okay, so in disability management you only try to assess his GCS of the patient. That is brief neurological examination of the patient should be done apart from GCS. Okay, so GCS ke alawa you also need to go for a brief neurological examination of the patient. Okay, and you also check the pupils of the patient. That is what is meant by disability management in the patient. You try to manage the disability related to a central nervous system. And last is exposure and environmental control. What do? We try to undress the patient. We try to completely remove the clothes of a patient. For example, a burns patient is coming to an emergency. We try to undress the patient. Pure kapde nikalo patient ke and try to see the extent of burn. How much body surface area of the patient has been burnt. That you try to check. And second, as you are exposing the patient can land up into hypothermia. So try to control the environment. That means try to control the temperature of your emergency room or your operation theater. Okay. Don't let the patient go into hypothermia. That is what is E. So done with trauma. Matlab at least the ATLS protocol. Now talking about various other types as well. If I talk about shock over here, as I've told you, a patient after trauma can have excessive blood loss or a massive blood loss, and the patient's blood pressure will fall. That is called as hypotension, and his heart rate will spike because the heart will try to compensate by beating faster, and that is what is called a shock. So what is shock? Shock in simple terms is nothing but hypoxia at cellular level. What do I mean by this definition? If there is decreased oxygen supply to the cells, that is what is shock. Okay, in simple terms, what do I mean by shock? If there is decreased oxygen supply to the cells, that is what is shock. And why there is decreased oxygen supply? Due to decreased blood supply to the cells. Due to decreased blood supply to the cells, at times there will be hypoxia in the patient. And why there is decreased blood supply? Due to decreased blood volume in the body most of the times. But not all kinds of shock will have decreased blood volume, right? Only decreased amount of blood is seen in hypovolemic shock. Other shocks mein the blood volume is not decreased. So that's the important thing you need to remember. Okay. So hypoxia at cellular level or decreased blood supply to the cells is what is shock. So yahan pe kya ho jata hai? I've told you the blood pressure of the patient falls usually. And what will happen to the heart rate? as the body tries to compensate, the heart tries to compensate to increase the blood pressure, okay, it will try to increase the heart rate. I hope all of you are quite aware. Cardiac output will determine the blood pressure of the patient, and cardiac output is nothing else but heart rate into stroke volume. Okay, so if the stroke volume of the patient is low, that means the amount of blood in the body is low. Try to increase the heart rate so that the cardiac output increases and so that the blood pressure increases. So try to increase the heart rate. That is called as reflex tachycardia in the patient. Okay, so decreased blood pressure and increased heart rate is what is suggestive of shock in a patient. Most common type of shock. There can be various varieties of shock. Just one C. Rest you cover it in medicine. I'm talking about hypovolemic shock. Important is C. Please remember, if the heart is not beating at all, okay, the heart is failed. Okay, so if heart is not beating, will there be blood flow to the organs? No. So the organs will not get enough of oxygen, and that is also a shock. So if the heart is not able to pump properly, and due to that the patient lands up in shock, that is called as a cardiogenic shock. Shock due to heart is known as cardiogenic shock. Or if the heart is beating too much faster, that is in a case of arrhythmia. Then also blood supply to the organs will not be enough. Q, because if the heart is beating faster, it is not opening up properly, it is not receiving blood, and if the incoming blood is low, outgoing blood is also low, and if outgoing blood is low, definitely the blood to the organs will also be low, and that's the reason why this is also a case of cardiogenic shock. Next, if a patient is having severe infection in the body and the patient lands up in sepsis, I told you sepsis can further progress to septic shock. Okay, due to the inflammatory mediators, there will be vasodilation throughout the body, and all the blood will go to the extremities. All the blood goes to the extremities. Pura ka pura blood ka hota hai? Haathon पैरों में. So will your vital organs of your body receive enough blood? No. So the kidneys, liver, heart, they will not receive enough amount of blood, and again the body goes into shock. Okay, that is called as a septic shock. Next, if a patient is having excessive histamine release in the body, why excessive histamine release occurs? Due to allergy. If a patient was allergic to something, if the patient eats that substance, or if the patient is exposed to that particular substance, there is excessive histamine release. That histamine causes vasodilation. Again, there is vasodilation in the peripheries. All the blood goes to the peripheries or to the extremities. Again, there is decreased blood supply to the vital organs of body. That is what is shock. That shock, which is due to excessive histamine release, is known as anaphylactic shock. Okay, and the one that I've talked about is definitely the hypovolemic shock that we are going to discuss. So the most common type of shock is due to excessive blood loss from the body. So if there is decreased blood in the body, definitely the organs are receiving decreased blood, and if the organs are receiving decreased blood, the organs are having decreased oxygen also. That is what is shock. Okay, so the most common type of shock, it is due to decreased blood volume in the body, and that is hypovolemic shock. And why does hypovolemic shock occurs? Due to excessive blood loss, and excessive blood loss is called as hemorrhage. Therefore, hypovolemic shock is also known as hemorrhagic shock. Don't get confused. Hypovolemic and hemorrhagic shock are one and the same thing. Please remember this. Okay. Another question which came in the FMGE examination: if a patient is having an isolated head injury, that means the patient is only having a head injury, there is no other injury in the body. Isolated head injury can never give rise to hypovolemic shock. Why such? See, please remember, now if there is any head injury and there is bleeding within the cranial cavity, this cranial cavity is a closed compartment. Can it expand in size? No, it cannot, because it is protected by the skull bone, which is a very hard bone, right? Therefore, it cannot expand in size. So if there is any blood, if it collects in the cranial cavity, it will be limited. Why? Because the cranial cavity cannot expand. So there will be limited blood loss in a case of head injury. Okay, because the cranial cavity could not expand, there is limited blood loss in a case of head injury. So please remember, if a patient is only suffering from isolated head injury, only head injury is there, it can never give rise to hypovolemic shock. That is an important statement, because in FMG examination, the question was, among all of the following conditions, which condition will have least chances of hypovolemic shock? And the answer was subdural hemorrhage. Now we know subdural hemorrhage is a case of head injury. In that, there will not be so much amount of bleeding that the patient lands up into hypovolemic shock. There will be only bleeding around 300 or maximum 350 ml. And hypovolemic shock starts when the bleeding is more than 400 to 500 ml. Okay? So that's the basic idea. So if a patient of head injury is having hypovolemic shock, you need to search for other bleeding sites. Why? Maybe the patient of head injury is having hypovolemic shock. You know, head injury does not cause hypovolemic shock. So please check for please check for any abdominal trauma, because maybe the patient is having internal bleeding in the abdominal cavity, or the patient is having internal bleeding in the thoracic cavity, or the patient is having any bleeding in the neck, okay, or in the pelvis. So these are the sites where the blood can collect and you are not able to recognize it from outside, okay. So if a patient of head injury is going into shock, please try to look for any other bleeding sites as well, okay. Next is, if a patient goes into hypovolemic shock, what is the earliest indicator or earliest sign of a shock? As I've told you, if the blood pressure of the patient starts falling, what will the heart try to do? The heart try to start beating faster to compensate, okay. So therefore, the earliest sign or the earliest indicator of hypovolemic shock is tachycardia. The earliest sign or the earliest indicator of shock is tachycardia, and that is important to be remembered, okay. That has been a question. Next important, all of these three statements are question previous years. What is the best indicator to determine the amount of fluid required in shock? Please answer this one now. Okay, I'll explain it to you in Hindi, those who didn't understand. So, कितना fluid तुम्हें चाहिए patient को? Okay, कितना patient को fluid चढ़ाना है तुम्हें? How much amount of fluid is required in the patient? That you need to determine with which indicator? Can anybody tell me that? How you are going to decide कि कितना fluid चढ़ाना है patient में? How you are going to decide how much fluid should be given to the patient? What is the best indicator to determine or to decide? So please remember, I feel there's a lag, so I'll answer. Please remember, that is called as PCWP. And what is PCWP? Pulmonary capillary wedge pressure. Okay, so pulmonary capillary wedge pressure can tell you that how much amount of fluid should be given to the patient. If that is not an option, the second best answer should be CVP, that is central venous pressure. Okay, so second best answer should be central venous pressure. So the amount of fluid required in a case of shock will be determined with the help of two things. Either the best answer is pulmonary capillary wedge pressure, not an option, go for central venous pressure or CVP as your answer. If they ask you what is the best clinical indicator, if they ask you what is the best clinical indicator of fluid resuscitation, or to assess if adequate fluid is administered in the patient of shock or not, इसका मतलब समझ लो हिंदी में कि which is the indicator that will tell you कि adequate fluid is given to the patient or not. What do I mean by adequate? Enough amount of fluid, okay. So please remember, which is the clinical indicator that will tell you कि enough amount of fluid has been given to the patient, okay. So which among the following indicators, which among the indicators can tell you that enough amount of fluid is given to the patient in resuscitation? Okay, so that has been asked a lot of times. This is a sarkari question of your exam, and that you need to remember is the urine output. Why urine output now? So please remember, if a patient is giving enough amount of fluid, there will be enough amount of blood supply to the kidneys, and if there is enough amount of blood going to the kidneys, definitely the urine produced will be enough in amount. So urine output can tell you if the amount of fluid that you have given to the patient is enough, adequate or not. Okay, so that is what is urine output. So in an adult, the urine output should be more than 0.5 ml per kg per hour in an adult, okay. And we know children have more urine output. Therefore, in a children, it should be more than 1 ml per kg per hour. In a child, it should be more than 1 ml per kg per hour. That is what is called as an adequate urine output. Okay, that is the time we can stop the fluid resuscitation. Next is important two statements. As I've told you till now, that shock is nothing but the systolic blood pressure of the patient decreases. That is what is shock. But there is an exception to this. Okay, so all types of shock, man, the systolic blood pressure is decreased. Okay, so systolic blood pressure is decreased in all types of shock except one, and that is what is called as warm septic shock. So these are punch liners. Okay, so that can help you make a diagnosis within a minute. Okay, so warm septic shock is one variety where, please remember, the patient will have increased blood pressure. Yes, okay, only one condition of shock where there is increased blood pressure, and that is what is warm septic shock. Okay, so for the ones who want to understand, it is due to hyperdynamic circulation. In the early phases of sepsis, there is a hyperdynamic circulation. That means the fluid or the blood goes rapidly from the heart to the body, Therefore, the blood pressure is increased. Okay, but as it does not stay at the tissues for a longer duration of time, the tissues are not able to get oxygen. Therefore, hypoxia at cellular level, that is what is shock. Samajh gaye? So that's important. Systolic blood pressure is decreased in all varieties of shock except one, and the answer to this question will be warm septic shock. Next important one liner or statement that I would like to make, and that is what is All shocks leads to hypotension and tachycardia. I've told you what is hypotension, decreased blood pressure, and what is tachycardia, increased heart rate. So all types of shock leads to hypotension and tachycardia, but hypotension and bradycardia is seen in which shock? Hypotension and bradycardia is seen in a special variety of shock, and that is called as neurogenic shock. Okay, so hypotension and bradycardia is seen in a special variety of shock called as neurogenic shock. That's important. Okay, so neurogenic shock में क्या होता है? There is damage to the spinal cord. Which part of the spinal cord? Mainly thoracolumbar region. So if there is damage to the spinal cord in the thoracolumbar region, I hope all of you are quite aware that from thoracolumbar region, which spinal nerves will come out? Parasympathetic or sympathetic? Sympathetic spinal nerves. Okay, so sympathetic spinal nerves will come out, and these sympathetic spinal nerves are responsible for vasoconstriction or vasodilation. They are responsible for vasoconstriction. Okay, so they are responsible for vasoconstriction. They will increase heart rate or decrease heart rate. We know sympathetic system, that means fight, flight and fright. जब tiger देखते हो सामने, so it will cause vasoconstriction to the in the periphery, and it will cause increased heart rate as well. Important is, now if there is damage, okay, if there is damage to the spinal cord, this thoracolumbar sympathetic fibers are also damaged. If the thoracolumbar sympathetic fibers are damaged, what will happen? Vasoconstriction will not happen. So if vasoconstriction is not happening in the peripheries, what will happen? Vasodilatation. There is vasodilatation. Kahan pe? In the periphery. If there is vasodilation in periphery, I've told you in other types of shock also, all the blood will be going to peripheries. All the blood goes to the periphery. Will your vital organs like heart, kidney and liver get enough blood supply? No. And that is what is a shock. Next, if the sympathetic fibers are damaged, definitely the heart rate will not increase. What will happen to the heart rate? The heart rate decreases, and that is what is bradycardia. So that's important. Okay, so please remember, hypotension and bradycardia are usual features in a case of neurogenic shock that you need to remember. These are two important one-liners. Next, if I talk about head trauma now, first starting with head trauma. So if I talk about head trauma, guys, I hope all of you are quite aware. Our head, the outermost layer of the head is called as scalp. The outermost layer of the head is called as scalp. Then we have a bone, and that bone is what is called as skull bone, also known as your cranial bone. Okay, the bone that we have inside is known as skull bone. And then we have the brain. Okay, so if I talk about head trauma, there can be injury to the scalp, there can be injury to the skull bone, or there can be injury to the brain as well. Now, scalp is an abbreviation. The layers of the scalp has been asked from anatomy. You need to remember that. S stands for skin, C stands for dense connective tissue, A stands for aponeurosis. Which aponeurosis? Galea aponeurotica. L stands for loose areolar tissue, and P stands for periosteum. What is periosteum? Outer covering of a skull bone. That is periosteum. Okay. So if they ask you which is the most dangerous area of scalp, the question was which is the most dangerous area of scalp. If they ask you which is the most dangerous area or most dangerous layer of scalp, then your answer should be loose areolar tissue. And why such? So please remember, the loose areolar tissue is considered as the dangerous area of scalp because it contains important veins. And what are these veins? These are known as your emissary veins. So please remember, the loose areolar tissue, as it contains the emissary veins, it is considered as the dangerous layer of scalp. And what will happen if the emissary veins are damaged? So please remember, if the loose areolar tissue is damaged, there will be damage to the emissary veins. That will cause subdural hemorrhage. That will study. But important is more than that. These emissary veins are connected to the main vein of your anterior cranial fossa. ये जो आगे वाला हिस्सा है ना of the brain, this drains into the main vein known as cavernous sinus. Okay, so this anterior cranial fossa drains into the main vein known as cavernous sinus, and these emissary veins are connected to the cavernous sinus. And the infection from here can spread to the cavernous sinus, and that can cause cavernous sinus thrombosis in the patient. Therefore, loose areolar tissue is considered as the dangerous area of scalp. No issues with this, anybody? That's important. Okay. Chalo. Then if there is a scalp laceration, there will be profuse bleeding. Okay. And therefore, what is the treatment? The treatment is, in emergency management is apply direct pressure with usually a bandage. But definitive management is suturing. And the suturing in the scalp is done in two layers. One layer that we suture first is the aponeurosis. And second layer that we suture above is the skin. No issues with this, anybody? That's important. Now, if I talk about some types of skull fractures over here. If I talk about skull fracture, the first skull fracture which is over here, you can see the fracture line is a straight line that you can see over here. Okay, so this type of a skull fracture is known as a linear fracture or a fissure fracture. Such type of a skull fracture is known as a linear or a fissure fracture that you need to remember. Next one, here you can see there was a penetrating trauma. In linear or fissure fracture, which type of trauma was there? For example, there was a lathi injury or a stick injury to the skull of this patient. So usually a blunt trauma was there. So if there is a blunt trauma to the head or blunt trauma to the skull, definitely will be a linear or a fissure fracture. But if there is a penetrating trauma to the head of this patient, penetrating, that means you are using an axe, okay? For example, you are using a axe, okay? Kulhadi use kar rahe ho, and then you are hitting a patient's head. It will cause such kind of a fracture. What is a fracture like this known as? It is known as a depressed skull fracture. And this depressed skull fracture also has another name. This depressed skull fracture is also known as fracture a la signature. It is also known as fracture a la signature. Okay, or signature fracture. No issues with this, anybody? Next important. Usually there was a blunt or a penetrating trauma to the skull of the patient, but there is not any fracture you can see. Okay, there is only a depression or a dent that you can see. This is what is called as a indented fracture. It is not a fracture actually. It is an indented fracture or a ping pong fracture it is called as. Or it is also known as a ping pong fracture. Okay, or it is also known as the Pond's fracture. It is also known as the Pond's fracture. So this type of fracture will be seen when the skull is very hard or when the skull is elastic and soft. Yes, very good. When the skull is elastic and soft. So it is usually seen in the elastic skull of infants. It is usually seen in elastic skull of infants usually. Okay, so that you need to remember. Next important, you need to see, these are the two important signs. And what are these signs suggest you of? So these two important signs are suggest you of cranial fossa fracture. If I talk about the cranial fossa fractures, guys. Okay, important is there are three cranial fossas that we have: the anterior cranial fossa, the middle cranial fossa, and the posterior cranial fossa. I am writing important points. Okay, so if they ask you which is the most common part fractured in anterior cranial fossa, the most common part fractured in anterior cranial fossa over here, it is this plate over here. And what is this plate of the ethmoid bone known as? Cribriform plate. Very good. Okay, so it is the cribriform plate. Okay, it is the cribriform plate which is the most common part fractured in anterior cranial fossa. Which is the most common part fractured in middle cranial fossa? Is the same. The most common part fractured is the petrous part of your temporal bone because it is very weak. Okay, it is the petrous part of temporal bone which is commonly fractured in a middle cranial fossa. Okay, so petrous part of temporal bone. And in posterior cranial fossa fracture, it is the occipital bone. Okay, it is the occipital bone which is generally fractured. No issues with this, anybody? So that's the important part you need to remember. Okay, now important is in an anterior cranial fossa fracture, guys. In a case of anterior cranial fossa fracture, the patient will have what? So the patient will have fracture of the cribriform plate, and this cribriform plate, please remember, it is a separating plate between the cranial cavity and between the nasal cavity. If this plate is fractured, now what will leak out? The CSF from the cranial cavity will leak out via the nose, and this is what is called as CSF rhinorrhea. So in anterior cranial fossa fracture, the patient can have CSF rhinorrhea. The CSF starts leaking out via the cranial cavity, and that is what is called as CSF rhinorrhea. It is usually seen in cases of anterior cranial fossa fracture. Along with that, the patient can also have another important sign. And what is that? The patient has an ectopic bruise. I told you, what is a bruise or a contusion? It is nothing but collection of blood usually. Ectopic, why? Because there was injury over here. And where is the blood collecting? Over here. See. Okay, so that's why it is called as an ectopic bruise. So this ectopic bruise which is seen, or contusion which is seen around both the eyes, this is also called as bilateral periorbital ecchymosis. This is known as bilateral periorbital ecchymosis. Okay, and this bilateral periorbital ecchymosis which is seen in this patient is what is called as the classical what sign? Raccoon's eye or the panda's eye. Okay, so it is known as the raccoon's eye or panda's eye, or the raccoon sign or the panda's sign. Please remember that. Okay, so that you need to remember. Raccoon's eye or panda's eye is a feature of anterior cranial fossa fracture. It is nothing else but bilateral periorbital ecchymosis. And you will say, why sir is telling about this periorbital ecchymosis? Because in one examination they asked you this sign. They didn't ask you the name, but rather they described the sign, and a lot of people were confused. They asked you what is Battle's sign, and a lot of people marked it as bruising over mastoid. No, it is not. Sorry, a lot of people marked it as edema over mastoid. No, it is not edema over mastoid. Edema over mastoid is seen in ENT. It is known as the Gressinger sign, seen in cases of sigmoid sinus thrombosis. This is nothing but discoloration over mastoid or bruising over mastoid which is seen. And when it is seen? In cases of middle cranial fossa fracture. So in cases of middle cranial fossa fracture, MCF fracture, there is bruising over the mastoid area. Okay, and this bruising over mastoid is what is called as the battle sign. There is bruising over the mastoid, and that is what is known as the battle sign. No issues with this, anybody? So that's important to be remembered. Next, in middle cranial fossa fracture also, we will be able to see, okay, the CSF which is leaking out. But the CSF will not leak out via nose now mostly. It will leak out via the ear. And that is what is called as CSF autoria. That is known as CSF autoria. Okay? That should be remembered. Important. Okay? So that is important to be remembered. No issues with this. Once we are done with the cranial fossa fracture or the base of skull fractures, I am going to talk about a very important and a sarkari question of your exam, and that is what is intracranial hemorrhages. If I talk about intracranial hemorrhages, guys, now what is the hemorrhage? As I've told you already, it is bleeding. Where is the bleeding? Within the cranial cavity, and therefore within the cranial cavity, and therefore it is known as intracranial hemorrhages. Now, important is any type of head injury. What is the investigation of choice for head injury? The investigation of choice for head injury is definitely a NCCT head, that you need to remember. Okay, so investigation of choice of a head trauma or a head injury is a NCCT head. NCCT matlab non-contrast CT scan of head. Okay, it is a NCCT head. Now, once we have performed an NCCT head in a patient of head trauma, there can be two things. Either we can see something which appears white, and anything which appears white on a CT is called as what? Anything which appears white on a CT is called as hyperdensity. If you are able to see something white or hyperdensity, that is what is suggestive of a bleeding or a hemorrhage. That is what is suggestive of a bleeding or hemorrhage. But if something appears black on a CT, that is called as hypodensity. That is known as hypodensity. And hypodensity or blackish appearance is what is suggestive of an infarct. What do I mean by infarct? Decreased blood supply causing necrosis. That is what is an infarct. Okay? So these are the two things. In cases of trauma, we are concerned about this hemorrhage usually. Okay? Now let's talk about the 4 types of intracranial hemorrhages. A very sarkari question. Okay, the first type of intracranial hemorrhage, we have done NCCT of this patient, and then we get this type of a hyperdensity. White now, so hyperdensity. We get this type of hyperdensity. Which kind? Idli shape. Idli, or we can call it biconvex. Dono taraf se convex. Okay, biconvex shape. Okay, so if we are able to get a biconvex opacity, or it looks like a lens also na, so it is also known as a lenticular opacity or a hyperdensity, whatever you call it. Okay, so biconvex or a lenticular opacity or hyperdensity is suggestive of idli, so EDH. That is, so it is suggestive of EDH. What is EDH? Extradural hemorrhage. That means there is bleeding but outside the dura mater. I hope all of you are quite aware there are 3 meninges around the brain. Sabse andar wala innermost is pia mater, then arachnoid mater, and then the dura mater. This bleeding is outside the dura mater. That is extradural hemorrhage. So extradural hemorrhage mein the NCCT shows a biconvex or lenticular opacity. Which is the most common vessel which bleeds over here? The most common vessel which bleeds over here is the MMA. That is mixed, that is the middle meningeal artery. Okay, so it is the middle meningeal artery. And where does the middle meningeal artery lie? Usually beneath this landmark. What is this landmark? You might have studied in anatomy called as, this is what is known as the pterion. Okay, so the middle meningeal artery usually lies beneath this pterion. Okay, therefore most of the times you can see EDH in the temporoparietal area itself. Okay, then there is a very characteristic feature, not only seen in EDH, it can be seen in other cases of head trauma also, but very commonly associated with EDH. That means after a patient had a significant trauma, so please remember, in EDH the patient has a significant trauma. That means like a bike accident or usually a road traffic accident. After trauma, the patient was unconscious for some time. Then after some time he gained his consciousness, and then again he went into unconsciousness, and mostly he dies. Okay, so this is a characteristic picture seen in cases of EDH, that is called as lucid interval, and that has been asked in your exam. Lucid interval is a feature of, so you know now lucid interval is a feature of EDH or extradural hemorrhage. That is nothing else but a period of consciousness in between 2 periods of unconsciousness. A period of consciousness in between 2 periods of unconsciousness. That is what is called as lucid interval. Treatment is what? Now here there is a lot of bleeding usually. As compared to other cases, here there is a lot of bleeding. Therefore, we need to go for a surgical management most of the times. And that is what is called as burr hole surgery. If it is very small bleed, we can only go for a burr hole surgery. We can make a hole over where? Over the surgical landmark known as pterion. Okay, or at the site. Agar tumhare paas CT nahi hai, if you don't have CT available, then definitely you can make a borehole at the site itself, that is the pterion itself. If it is a very huge bleed, then definitely a borehole cannot suffice. If it is a very huge or massive bleed, then definitely you need to go for craniotomy in the patient. Okay, opening up the skull bone and then removing the blood clot. Next is this one. What is this? You can see over here. Here there is a hyperdensity which is seen, or whitish appearance which is seen. In which shape? Banana shaped usually. Okay, or it is called as the half moon shape. And wherever there is half moon, we call it crescent. Okay, so here also the opacity is what is called as concave or convex. Why? On one side it is concave, the other side it is convex. Okay, so it is known as concave or convex opacity, also known as concave or convex opacity, also known as, please remember, crescentric opacity. I've told you half moon shapes are called as crescents. So crescentric opacity. Okay, so that is what is seen. And if this kind of opacity is what is seen on the CT scan, then we suspect which kind of a hemorrhage? We suspect SDH, that is subdural hemorrhage. That means here there is a bleeding, but where? Beneath the dura mater. Dura mater ke niche bleeding hai. That is what is the case of subdural hemorrhage. No issues with this. Usually subdural hemorrhage occurs after a trivial trauma. What do I mean by trivial? Minimal trauma, like a patient fell in a bathroom. Okay, that is a characteristic history. What is the characteristic history in a case of SDH? The patient is usually an elderly patient. It can be a child, but usually elderly patient who fell in a bathroom and who does not come to you urgently or in the emergency. The patient might present to you after 8 days of trauma. Okay, and then the patient can complain of headache. Okay, so that is what is the usual case of SDH that comes to you in the examination. Okay, so that is what is seen in cases of SDH. Please remember, SDH can be of 3 types. If the patient presents to you within 3 days, it is acute SDH. If the patient presents to you within 3 to 21 days, that is subacute SDH. And if the patient presents to you after 21 days, that is chronic SDH. Okay, so usually if I talk about SDH, please remember what should be the treatment in this patient. Okay, what should be the treatment? Over here, the treatment that you need to remember, okay, is usually either a borehole surgery again, if the patient is symptomatic only. If the patient is not symptomatic, don't go for a surgery. Just go for observation in the patient. Okay, so borehole surgery, or you can go for a craniotomy here as well, if it is very huge. But important is, if the patient is not having severe symptoms, only the patient is having headache, and headache after trauma is usually due to increased intracranial pressure. If there is increased intracranial pressure, because this hemorrhage or bleed, the clot which is formed, it is trying to increase the intracranial pressure. So if there is only intracranial pressure which is causing headache in the patient, then only manage the patient by giving IV mannitol. Okay, that is called as osmotherapy. It will help in decreasing the intracranial pressure. But important contraindication you might have studied in pharmacology is IV mannitol should be not given. It is contraindicated in cases of active cerebral hemorrhage. Why? Because it causes sudden decrease in intracranial pressure. As it causes sudden decrease in intracranial pressure, there will be herniation of the brain. Okay, so therefore, if there is active bleeding which is going on, active cerebral hemorrhage, please remember mannitol is contraindicated. It can be given in subacute or chronic cases usually. No issues with this, anybody? That's important. Chalo. And which is the most common vessel which bleeds over here? In cases of subdural hemorrhage, I hope all of you are quite aware, the most common vessels which bleed. I write the full name usually. I prefer writing the full name. It is the cortical bridging emissary veins. Some exams they have only written emissary veins. Some exams they have only written bridging veins. So it's always better to remember the full name. That is cortical bridging emissary veins. No issues with this, anybody? So those are the vessels which commonly bleed in cases of subdural hemorrhage. Another question which has been asked. Only venous intracranial hemorrhage. That means only intracranial hemorrhage where the bleeding is from the veins. Now you know the answer, it is SDH, because in all other types of intracranial hemorrhage, the bleeding usually occurs from arteries. Next is this one. What is this? You can see the opacity usually within the sylvian fissure and within the ventricles. So if the opacity, okay, whitish appearance is seen, okay, if the opacity is within the ventricles or in the sylvian fissure, the opacity is within the ventricles or in the sylvian fissure, then it is suggestive of which type of hemorrhage? Then definitely it is suggestive of a SAH. What do I mean by SAH? It is nothing else but subarachnoid hemorrhage. And I hope all of you are quite aware. Subarachnoid hemorrhage. Okay, so subarachnoid space. Okay, that means the space below the arachnoid. Between arachnoid matter, between pia matter. This space is what is called a subarachnoid space. This space may we normally have a fluid in the brain. And what is that fluid called as? CSF, cerebrospinal fluid. now you will see that the bleeding is occurring in the subarachnoid space. Okay, so therefore the CSF now does not look black, it appears white, because it is not only the CSF, it is a blood mixed CSF which is seen over here. Okay, so that's important over here, you need to remember that. Okay, so here it is usually bleeding in the subarachnoid space in a case of subarachnoid hemorrhage. Which is the most common cause of subarachnoid hemorrhage? The most common cause of subarachnoid hemorrhage is usually trauma. The most common cause of subarachnoid hemorrhage is usually trauma. Followed by that, definitely it can be spontaneous rupture. Okay, followed by that, it can be, the another cause can be spontaneous rupture of aneurysm. What is aneurysm in short? Aneurysm is nothing but dilatation of a vessel. For example, this is a vessel, this dilatation is what is called as aneurysm. And when that aneurysm is very small like a berry, it is called as a aneurysm. So spontaneous rupture of aneurysm is the second most common cause of subarachnoid hemorrhage. And where are these aneurysms more common? Very good question. It is more common in the circle of Willis. But in circle of Willis also, if they ask you one artery, then your answer should be anterior communicating artery. Then your answer should be anterior communicating artery. Okay. Then if I talk about what should be the treatment in this patient. So please remember, usually in this patient, the treatment is generally, okay, the treatment is usually not surgical, it is conservative, and that is what is IV nimodipine. क्या टॉपिक चल रहा है? So the topic is intracranial hemorrhage buddy, and that is managed by a surgeon. You might have seen that a lot of times it is taught by a physician, but usually if I talk about emergencies, it is managed by surgery people. Please remember that. ठीक है? So head traumas are managed by surgeons, and that's the reason why I am covering it over here. So important is, please remember this, कि IV nimodipine is the drug of choice for subarachnoid hemorrhage. You will say, sir, is there any important keyword that with the help of which we can pick up a subarachnoid hemorrhage wala case? Yes, we can. And that case or that complaint of the patient is, the patient will say, Dr. Saab, I'm having worst headache of my life. Okay, that is what is the complaint. The patient says the patient is having the worst headache of her life, or the second thing that they can mention, the patient is having such a severe headache, it is known as a thunderclap headache. So either worst headache of my life or thunderclap headache. Please remember that. Okay? And important is, please remember, worst headache of life or thunderclap headache. Along with that, the patient will also have nuchal rigidity. And what do I mean by nuchal rigidity? That is neck stiffness. And a lot of people in the recent FMGE examination has marked it wrong. If they only mention about headache and nuchal rigidity, you need to mark it as subarachnoid hemorrhage. If they mention the third part of the triad, that is what is fever, then that is suggestive of an infection, and then you need to mark it as meningitis. But in a case of subarachnoid hemorrhage, please remember, okay, so please remember, in cases of subarachnoid hemorrhage, usually the patient will not have any kind of fever. If fever is present, the diagnosis becomes meningitis. So that is very clear. Okay. Next, the last type of intracranial hemorrhage. So please remember, here you need to remember this one is what is called as intracerebral hemorrhage. Okay. So this is what is called as intracerebral hemorrhage. You can see the whitish opacity or the hyperdensity is seen within the brain tissue or within the brain parenchyma. This is what is the case of intracerebral hemorrhage. That means the bleeding is within the cerebrum or within the brain parenchyma. Therefore, it can also be called as intraparenchymal hemorrhage. And please remember this, you might have studied in medicine. If there is bleeding within the brain tissue, it is also called as hemorrhagic stroke. So intracerebral hemorrhage is nothing else but hemorrhagic stroke itself. Okay. And now you can tell me which is the most common vessel which bleeds over here. The most common vessel that bleeds, please remember, the most common vessel that bleeds in cases of intracerebral hemorrhage is usually the lenticulostriate artery. Lenticle kiska dusra naam hai? The lenticle is another name for basal ganglia. So the artery which supplies the basal ganglia is known as the lenticulostriate artery, also known as the Charcot's artery. So if the Charcot's artery undergoes a rupture, okay, that causes intracerebral hemorrhage or hemorrhagic stroke in the patient. And what will be the most common site of bleed? And that is the Sarkari question of your exam. The most common site of bleed, we know it is the which part of basal ganglia, and that has been asked. It is the putamen. The most common site of bleed is usually the putamen. Please remember this. Okay? So it is not the lentiform nucleus which commonly bleeds. It is the putamen where the bleed is very common. No issues with this. What is done for treatment? Here we generally go for a drug again, not surgery. Usually we go for drug because most of the cases can be managed with the help of a drug. And that drug which we need to remember is the drug of choice is usually IV nicardipine. So don't get confused. Nimodipine was for SAH and Nicar, CR na. So intracerebral, that's how you need to remember. Intracerebral, it is nicardipine. Okay, it is nicardipine in cases of intracerebral hemorrhage or hemorrhagic stroke. It is the drug of choice, a calcium channel blocker. No issues with this, anybody? Okay, so hopefully there is no issue in understanding these things. Chalo. Moving further now, talking about in a case of head trauma, definitely every patient who comes with head trauma, we need to assess the severity of injury in this patient. And how we are assessing the severity of injury in the patient of head trauma? With the help of a score or a scale that is called as GCS, Glasgow Coma Score, or a Glasgow Coma Scale. So with the help of a GCS, we are trying to assess whether the patient is having mild, moderate, or a severe head injury in every case of head trauma. Okay, so if we are trying to assess head trauma in the patient with the help of a Glasgow Coma Score, we have three important parameters to check for. Okay, they are remembered by the mnemonic EVM. That is eye opening response, second is verbal response, and third is motor response. Okay, and the mnemonic is E4 V5 M6. Okay, so maximum eye opening score is 4, maximum verbal score is 5, and maximum motor score is 6. Okay, so that's important. Please remember this. Now, important is, first of all, if I talk about the eye opening response of a patient, okay, if the patient is opening the eye spontaneously, apne aap aanखें khol raha hai, he is given a score of E4. If the patient is not opening eyes on his own, but when you call him, Baba aanखें kholo, okay, when you ask him to open the eyes, he opens the eyes. So on voice command, it is E3. When the patient opens the eyes on pain, okay, patient aanखें नहीं खोल रहा, तुमने चूटी काट दी दो उसे, ठीक है? So when the patient is not opening the eyes, definitely you will apply pressure or you will try to give painful stimulus. If the patient opens eyes on painful stimulus, it is E2. And if the patient does not open the eyes, it is a score of E1. Next is, if I talk about the verbal response, you will check whether the patient is able to speak or not. Okay, if the patient is oriented to time, place, and person. What do I mean by this? The patient, if you ask the name, the patient tells his name. Okay, if you ask where are you, the patient tells I'm in hospital. Okay, that means the patient is oriented to time, place, and person. If he's answering everything properly, that means a score of V5 is to be given. Next, if the patient appears to be confused, okay, that means if you ask the patient where are you, okay, so who are you, the patient does not know his name. Okay, if you ask the patient where are you, the patient says I am in the crematorium. And what is going to be done? The patient says you are burning me. Okay, so that kind of a confused patient, he should be given a score of V4. Next, if the patient starts abusing you with words, okay, inappropriate words, if the patient starts abusing you, गालियां देना शुरू कर दे patient, that is a score of V3. Yes, a lot of head trauma patient starts abusing. Next, if the patient is not even able to speak words, he is only making incomprehensible sounds like ah, ooh, okay, all of these incomprehensible sounds are given a score of V2. And if the patient is not making any sound, that is a score of V1. Next is, if I talk about the motor response of the patient, maximum motor response, I've told you it is M6. So if the patient is obeying commands, if you ask the patient, Baba haath uthao, okay, Baba raise hand, he's raising his hand. If a patient obeys commands, it is given a score of M6. Next, if the patient is not able to obey the command, but if you ask, Baba dard kya ho raha hai, where is your pain? Baba tries to locate the pain. Okay, Baba says over here. Okay, that means if the patient is able to localize pain, he is given a score of M5. If the patient withdraws on pain, that means he is not even able to localize pain. But if you try टूटी काटते हो तो Baba हाथ हटा लेते हैं. That means if the patient withdraws on pain, then definitely it is given a score of M4. Okay, so if the patient withdraws on pain, it is a score of M4. Okay, so normal flexion, or you can say withdraws on pain, that is a score of M4. Next, if they ask you if there is abnormal flexion, there is not normal flexion, there is abnormal flexion in the patient. Okay, if there is abnormal flexion, it is given a score of M3, and that abnormal flexion is what is called as decorticate position. So decorticate position is a score of M3. If there is an abnormal extension in the patient, that is given a score of M2, and that abnormal extension is what is called as decerebrate position. So decerebrate is given a score of M2. And if the patient is showing no motor response, that is given a score of M1. Now, if I combine all of these scores, E4, V5, M6, what is the maximum GCS in a patient? The maximum GCS of a patient can be 15. Okay, the maximum GCS score of a patient can be 15. Whereas if I talk about the minimum GCS score of a patient, what is the minimum GCS score of a patient? Everywhere it was 1, 1, 1. So if I combine all of them, the minimum GCS score of a patient can be 3. Minimum GCS score of a patient can be 3. And a lot of times they give you a lot of parameters, and depending on that you need to assess the GCS score of a patient, and then they ask you usually which grade of head injury it is. So if the patient GCS is between 13 to 15, if the patient's GCS is between 13 to 15, it is suggestive of mild head injury. 13 to 15, mild head injury. 13 to 15, mild head injury. Okay, if the score is between 9 to 12, it is suggestive of moderate head injury. 9 to 12, moderate head injury. 9 to 12, moderate head injury. And if the score is between 3 to 8, okay, if the score is between 3 to 8, it is suggestive of severe head injury. Why 3 to 8, it is severe head injury, please remember. Why I don't write it as less than and more than? Because that causes a lot of confusion. Okay, that causes a lot of confusion. So that's important. Okay, and if a patient is having the minimum GCS score, okay, that is what is suggestive of a brain dead patient. Thank you so much, all of you. So that is what is suggestive of a brain dead patient. Okay, that's important. Chalo. Once you have done with the GCS score, understood properly, great. No one should make a mistake in the GCS score now. Okay, so these are the important points to be remembered. Moving further now, talking about next type of head injury, and that is what the most severe type of head injury. Rather, it is, I'm talking about a brain injury, when there is injury to the brain. Now there can be various types of injury to the brain, please remember. Okay, one of the brain injury can be contusion, okay, or another brain injury can be concussion. Concussion is the mildest form of brain injury. One important one-liner that you need to remember: concussion is nothing else but it is the mildest form of head injury. But here I'm not going to discuss about the mildest form of head injury, because here we do not go for any surgical management, only observation is done, and the NCCT also appears normal in this patient. Okay, so I'm talking about this question which has appeared in your examination multiple number of times, NEET PG as well as FMG exam. And what was that question? A 22-year-old male following a road traffic accident was referred to you 2 days later. On examination, his GCS Glasgow Coma score was E2, B3, M2. Combine all of them. What is the final GCS of the patient? It is 7. So we know if the score, GCS score is 7, less than 8, definitely it is suggestive of a severe head injury in the patient. So this patient has sustained a severe head injury, and he had no fractures or any visible bleeding, or any lacerations were not present. Blood pressure of this patient is around 180 by 90 millimeters of mercury. That means the blood pressure of this patient is very high. Heart rate is 52 beats per minute. That means the heart rate is less than 60. That means it is suggestive of bradycardia in the patient. GCS of the patient is not improving. Your keyword, GCS of the patient is not improving. And the NCCT head was performed, which has been given below. And the NCCT head, if we see, can you see any whitish or blackish appearance in the CT? No, it seems to be grayish, na? And gray is normal brain parenchyma. Therefore, this is what is a normal NCCT of the patient. Okay, the NCCT head of the patient appears to be absolutely normal. But even if the NCCT head of the patient is normal, the GCS of the patient is very low, and the GCS of the patient is not improving. So what it is suggestive of? The likely diagnosis in this patient, please remember, the likely diagnosis in this patient is the most severe form of head injury or brain injury, and that is what is called as diffuse axonal injury. I hope all of you are quite aware of the Formula 1 racer, the topmost. He was known as Michael Schumacher. He sustained diffuse axonal injury. Okay, so please remember diffuse axonal injury, or DAI. Okay, it is the most severe form of head injury. It is the most severe form of head injury that you need to remember. In diffuse axonal injury, what is the cause now? Okay, what is the cause? Please remember, there is a stretching force or a shearing force between the gray matter and the white matter junction. Okay, there are two matters in the brain now, gray matter and white matter. At that junction, there is a stretching force or a shearing force, due to which what happens? See, this is the gray matter white matter junction, and here we are having some neurons. This part of neuron is cell body, this part of neuron is axons. So now what has happened? At the gray matter white matter junction, due to a shearing force, there was injury to all these neurons. Mainly to which part of the neurons? Axons of the neurons. Okay, and that is what is called as diffuse axonal injury. Okay, so that's important. Please remember, diffuse axonal injury is nothing but due to a shearing force at the gray matter or white matter junction, there is injury to the axons. Okay, where at the gray matter and the white matter junction. No issues with this, anybody? Important is, what are the keywords to pick up in this question? The keywords to pick up in this question are, the patient has sustained a road traffic accident, and important is the GCS of the patient. The GCS of the patient is very low. It is not improving. Okay, the GCS of the patient is very low, it is not improving, or it is falling down, or the GCS is decreasing, it is falling. These are the keywords to be picked up. Okay, and the NCCT head, even after such a severe head injury, the NCCT head appears to be normal. Why? Because these neurons could not be picked up properly on a CT head. Therefore, in most of the patients, the CT head is normal. Some patients can show us change, but then therefore, if CT head appears to be normal, what is the investigation of choice for diffuse axonal injury? And that has been a question again. So the investigation of choice is the MRI. Okay, the investigation of choice is the MRI, but usually it is a T2 weighted MRI. Why T2 weighted MRI? Because water appears white on a T2 weighted MRI. Yaad rakhna, any type of water, fluid or blood appears white on a T2 weighted MRI. And on the T2 weighted MRI, you can see this blood over here. Okay, and these type of small hemorrhages at the gray matter white matter junction are known as punctate hemorrhages. These are known as punctate hemorrhages. No issues with this. These are known as punctate hemorrhages. Chalo. Next, if I talk about, that was about your diffuse axonal injury. Treatment is usually the patient does not have a proper outcome. Okay, so therefore we do not go for any surgical management in this patient. Only palliative care is given to the patient to improve his survival. Next is this one. Now talking about the facial fractures. And there can be upper facial fractures or there can be lower facial fracture. Upper facial fracture, the upper part of the face is formed by which bone? Maxilla. So therefore these upper facial fractures are nothing else but the maxillary fractures. And I hope all of you are quite aware, maxillary fractures are also known as La Fortes fractures. Okay, maxillary fractures are also known as La Fortes fractures. There are three types of maxillary or La Fortes fractures. Type 1, you can see in type 1 La Forte, from where is the fracture line passing? In type 1 La Forte, the fracture line is passing via the palate. So if fracture line passes via the palate, okay, this is called as type 1 La Forte, and this is what is called as a transverse or a horizontal fracture. This is called as a transverse or horizontal fracture. You can see the fracture line is horizontal. Next one, you can see in type 2 La Forte, the fracture line is passing via the root of the nose. And which kind of fracture it is seen? Here the fracture line passes via the root of nose, and the fracture is known as a pyramidal fracture. It looks like a triangular pyramid, right? So it is known as a pyramidal fracture. And type 2 La and type 3 La Forte, if they ask you, type 3 La Forte, here you can see the fracture line is passing via the orbit and also via the bridge of the nose, okay, or the root of the nose. So here the fracture line passes via the root of nose, and this type of fracture, if there is a fracture in via the orbit, the cranial cavity and the face both will not have any connection. This is what is called as craniofacial disjunction. This is what is called as craniofacial disjunction. Okay, now can anybody tell me? Okay, I'll move further. Please tell me. Okay, please remember, no, it is not for NEET PG, but please remember, important is FMG has become almost to the level or beyond NEET PG as well. If you feel that FMG is easy, it's not. Okay, so that's the important thing. Please remember that. Okay, so important is jaldi se. Now please let me know in which types of La Forte will you have CSF rhinorrhea. What was CSF rhinorrhea? When the CSF leaks out of the nose. Okay, and why CSF leaks out of the nose? Because the cribriform plate is fractured. Where is the cribriform plate? The cribriform plate is in the ethmoid bone. And where is the ethmoid bone? In between the orbits, at the root of the nose. Now please tell me in which type of La Forte you will have CSF rhinorrhea in the patient, because that has been a previous year question. I'll talk about till then. I'll talk about the lower facial fractures. Please remember, okay? So if I talk about the lower facial fractures usually, okay? So in the lower facial fracture, which is the fracture over here? The mandible, okay? So if I talk about the lower facial fractures, that is nothing else but your mandibular fractures. That is nothing else but your mandibular fracture. What is the most common site of a mandible to be fractured? The most common site of a mandible to be fractured is this one. That is the neck of the mandible, which forms the temporomandibular joint, right? So it is usually the most common site of fracture is definitely the condyle. It is the condyle followed by the angle of mandible. The most common site of fracture will be the condyle followed by the angle of mandible. No issues with this. But this fracture which is seen over here, it is over here at the mentum or at the genial tubercle. Okay, it is at the mentum or the genial tubercle. This is considered as a dangerous mandibular fracture. This is considered as a dangerous fracture of the mandible. And why it is considered as the dangerous fracture of mandible? It is also known as a butterfly fracture. Why it is considered dangerous? Because I hope all of you are quite aware at this part of the mandible, at the genial tubercle of the mandible, we have a muscle known as safety muscle of tongue, known as genioglossus muscle, which is attached. It keeps the tongue, okay, it keeps the tongue pulled downwards. If there is a fracture at the mandible over here, what will happen? The genioglossus muscle is released. As the genioglossus muscle is released, it will fall back and it will close the airway of the patient, and the patient can die of respiratory arrest. Okay, so therefore it is considered as dangerous fracture because there is release of the safety muscle of tongue known as genioglossus muscle. Okay, treatment for this type of a fracture is usually ORIF, that is open reduction or internal fixation, or we can go for interdental wiring. Next is this important fracture. What is seen over here? You can see there is some fracture in the orbit of the patient. Okay, so you can see there is fracture in the orbit of this patient over here. Okay, and this is what is called as the blowout orbital fracture. This is known as, ये orbit normal लग रहा है. This orbit is having a fracture. In which part of the orbit there is a fracture? I hope all of you are quite aware of the walls of orbit. There is the floor of the orbit. There is the superior wall or roof of the orbit. There is lateral wall and there is the medial wall of orbit. So here the inferior wall or the floor of the orbit has been fractured. And this is what is called as the blowout orbital fracture. If I talk about the blowout orbital fracture, please remember it is usually due to which kind of a trauma? ये सरकारी question है तुम्हारे exam का. Recently it was appeared and it has appeared many times in exam. It is usually due to a blunt trauma to the orbit. Okay, blunt trauma to the orbit. And usually they will mention a tennis ball injury. They will mainly mention a tennis ball injury to the patient. Okay, that's important. Which is the most common wall of orbit to be fractured? The most common wall of orbit to be fractured, as seen in the image, it is the floor. The most common wall of orbit to be fractured is the floor, followed by the medial wall. Followed by the medial wall. No issues with this, anybody? That's important. Important is here on a CT, okay, investigation of choice is the NC-CT scan as given in the image, and which is the sign seen. You can see as the floor of the orbit is fractured, the soft tissues of the orbit, they are going into the maxillary sinus. The soft tissues of the orbit, they are protruding into the maxillary sinus, and this looks like a tear, na? Teardrop. Okay, आंसू की बूंद जैसा लग रहा है. Therefore, this is what is known as the teardrop sign. That is characteristically known as the teardrop sign. And management of blowout orbital fracture is done by conservative management. Surgical management is rarely required. Okay? If they ask you which is the muscle entrapped over here, so usually the most common muscle which can be entrapped because it is floor now, it is usually the inferior rectus muscle. Okay, it is the inferior rectus muscle. Chalo, off also cover. Moving further. आगे बढ़ते हैं. And important is I have asked you ki in which types of La Forte you will get CSF rhinorrhea. So please remember CSF rhinorrhea. All of you have answered as type 3. In type 3, yes, very good. There is definitely damage to the cribriform plate. In type 2 also we are having damage to the cribriform plate, right? So please remember that's the reason why CSF rhinorrhea is seen in type 2 as well as type 3 La Forte. It is usually seen in type 2 as well as type 3 La Forte. Okay, that's important. Next, talking about thoracic trauma in a patient. Okay, if I talk about thoracic trauma in a patient or chest trauma in a patient. If I talk about thoracic trauma or chest trauma, important is usually what is the first line investigation in a case of thoracic trauma in the patient? If a patient comes to you with thoracic trauma, definitely the first line investigation is a chest x-ray. The first line investigation is a chest x-ray. What is the emergency investigation that we perform? The emergency investigation that we perform to see any bleeding, okay, in the thorax. Blood is fluid, and for fluid, the better investigation is always an ultrasound. So here also we perform a very rapid ultrasound, and that rapid ultrasound which is done in cases of emergency is called as a E-fast or an extended fast. I am going to talk about it in abdominal trauma. Don't worry about that. Okay, so emergency investigation is an extended fast. It is nothing but a rapid ultrasound, okay, which is done of the abdomen and the thoracic cavity. If I talk about the most common causes of death or mortality, okay, death is nothing but mortality. The most common causes of death in a case of thoracic trauma or chest trauma. Please remember, in a blunt thoracic trauma, in a case of blunt thoracic trauma, the most common cause of death is a tracheobronchial injury. If there is injury to the trachea or the bronchus or rupture of the trachea and the bronchus. The most common cause of death in a blunt thoracic trauma is tracheobronchial injury. But in a case of penetrating thoracic trauma, it is usually a massive hemothorax. What is hemothorax? As I have told you, hemo ka matlab hota hai blood. Thorax, that means in the pleural cavity. There's a lot of blood collection in the pleural cavity. That is what is called as massive hemothorax. Okay, so that is what is the cause of most common cause of death in a penetrating thoracic trauma. Penetrating matlab there is some, okay, sword or there is some knife usually in the thorax. That is what is a penetrating thoracic trauma. Important is what is this condition over here. In this chest x-ray, what you can see over here, in this chest x-ray, there is fracture of this rib, there is fracture of this rib. Here also these two ribs have been fractured. Again, there is fracture of this ribs. Oh, again, these are fractured over here as well. Okay, so this is a case of flail chest. This is what is a case of flail chest. So what is a flail chest? The definition of flail chest you need to remember, guys. Flail chest is nothing but fracture of two consecutive ribs. What do I mean by consecutive? One after the another. That means third or fourth, fourth or fifth, fifth or sixth. Always the rib should be consecutive. Okay, so it is nothing but fracture of two consecutive ribs or more. Fracture of two consecutive ribs or more at more than equal to two sides. Okay, so fracture of two or more consecutive ribs at more than equal to two sides. So you can see two ribs have been fractured. Yes. Are they consecutive? Yes. How many sides they have been fractured at? They are fractured at two sides. So is it a case of flail chest? Yes, it is a case of flail chest. Okay, so that means very good. More than equal to two ribs fractured consecutively and more than equal to two sides. That is the case of flail chest. Now, usually the patient will have a lot of pain. We don't go for any type of rib fractures. We don't go for a surgical management. Okay, so usually we will go for a conservative management in the patient. And what should be the treatment? Okay, so in a case of flail chest, definitely what is the complaint? The patient is either having respiratory distress, okay, because the lung is not able to expand properly, or the patient will have a paradoxical breathing. You can see that the flail part or the fractured part now, it is moving opposite to as compared to the rest of the chest. If rest of the chest is rising, this part is falling. If this part is rising, rest of the chest is falling. This is what is called as classically the paradoxical breathing. That is what is known as the paradoxical breathing. So paradoxical chest movements or paradoxical breathing is a feature of flail chest. That is a keyword in the equation. Treatment is give enough analgesia. And what is analgesics? Painkillers. Give enough amount of painkillers to the patient because there will be a lot of pain in this patient. And if required, definitely give oxygen support as well. If required, give oxygen support to the patient, either with the help of a mask, or if the patient is not able to definitely even breathe with the help of a mask also, then intubate the patient. Okay, so that should be done properly. IPPV should be given, that is intermittent positive pressure ventilation. Okay. Next is this condition. What is this condition over here? This is the recent image which came in the December examination. Okay, this image that you can see usually. Important. Okay, not in 2023, it was usually the 2022 December. Okay, this image you can see, it is not fat necrosis. A lot of people marked it as fat necrosis. It is an autopsy picture or a postmortem picture on which you can see the body of the patient is open and you can see the heart is appearing completely black. Why? Because there is a lot of collection around the heart. And what is that collection? That collection is nothing but the blood. Okay, so if I talk about, see, I explain about this condition, I'll explain. So I hope all of you are quite aware. This is the heart, for example, and this is what is your pericardium. The outer covering of heart is what is called as pericardium. Now around the heart, if there was some injury to the pericardium, okay, there was some penetrating injury to the pericardium, due to which there is a lot of blood which is collected in the pericardium. An excess of blood, if it collects in the pericardium, okay, what will happen? That will start exerting a lot of pressure. Due to this excess of blood which is collected, there will be a lot of pressure on the heart. Will the heart be able to relax properly? Heart ढंग से relax कर पाएगा क्या? नहीं कर पाता. So if the heart is not able to relax properly, what will happen? The incoming blood, will it be able to come into the heart? No. If the blood is not able to come into the heart, okay, so what will happen? The incoming blood is less. So outgoing blood will also be low. So outgoing blood is also low. Okay, so if outgoing blood is low, what is outgoing blood? Cardiac output. So if outgoing blood is low, as I've told you, cardiac output decides what? Blood pressure of the patient. So if cardiac output is low, the blood pressure of the patient is also low. That is what is hypotension. That is the first part of your classical triad. Second part of triad. Now as this blood is not able to come into the heart, what will happen? This blood will keep on collecting in the veins above. This blood will keep on collecting in the vein. And which is the main vein which drains into the heart from above? Superior vena cava. So all of this blood keeps on collecting in superior vena cava, and superior vena cava se where? In the IJV, internal jugular vein. So there will be raised JVP. As there is a lot of blood in the IJV, the jugular venous pressure or the pressure in the IJV will be elevated. So you can see that the neck veins are congested or they are dilated. Okay, so that is what is seen. Second part of the triad. And third part, if you try to auscultate this patient from outside, if you try to auscultate, will you be able to auscultate? No. Reason is, please remember, as there is a lot of blood around the heart, you will not be able to hear the heart sounds properly and clearly. That is what is called as muffled heart sounds. The S1 and S2 will not be heard clearly. That is what is known as muffled heart sound. And this is what is the case of cardiac tamponade. This is what is the case of cardiac tamponade. No issues with this, anybody? Cardiac tamponade can also occur after a massive pericardial effusion that you will study in medicine. But it can also occur after trauma as well, thoracic trauma. Okay, so we need to discuss it over here as well. It is a case of cardiac tamponade. Okay, and important is in cases of cardiac tamponade, which type of trauma is commonly responsible? Bailey Creary writes it is penetrating trauma more than blunt trauma, which is responsible. Blunt trauma also causes, but more common is the penetrating trauma. Next important is, what is the classical triad seen over here? The classical clinical features which are seen, they are remembered as a Beck's triad. And what is the three features of Beck's triad in this patient? So the three features of Beck's triad, as we have discussed, as incoming blood is low, outgoing blood is also low. That is hypotension. Second, the patient has raised JVP, non-pulsatile raised jugular venous pressure is seen because the SVC is not able to drain the blood into the heart. And third important feature, the patient has muffled S1 and S2 because of the blood. We are not able to hear the sounds clearly. That is what is muffled heart sounds, muffled S1 and S2. These are the three features of Beck's triad. Now, what is the investigation of choice over here? Investigation of choice, if they ask you, answer is a echocardiography. Okay, answer is a echocardiography because that can tell you about the blood collected around the heart. Okay, but if they ask you what is the emergency investigation of choice, emergency may, which will be the investigation that you will do, then I will answer it as fast or e-fast. Okay, I will answer it as fast or e-fast. What did I tell you? Fast is also an ultrasound, but a very rapid ultrasound done in cases of emergency. Okay, so fast only I will keep the ultrasound probe over here and I will see if there is any collection around heart to rule out cardiac tamponade in the patient. Investigation of choice is echocardiography. Then if I talk about management of cardiac tamponade. So management of cardiac tamponade in emergency to give immediate relief to the patient. What should be done? So in emergency, see, I am doing a echocardiography in this patient. Along with that, I am taking a needle and I am inserting that needle in the subxiphoid space. What is the subxiphoid space? The space below the xiphy sternum. Okay, so in the subxiphoid space, I am inserting a needle. And this needle should be facing which shoulder? The left shoulder. At how many degrees angle to the skin? At 45 degrees angle to the skin. Okay. And I'm inserting this needle in the pericardium. Once I insert this needle in the pericardium, okay, I will try to aspirate all this blood. I will try to aspirate all the blood. And once I've aspirated the blood, even 5 to 10 ml if I aspirate, then definitely a patient will have immediate improvement in the blood pressure. Because the heart will at least be able to relax, incoming blood will increase, outgoing blood will increase. Okay? So emergency management, which is done with the help of a needle, this is what is called as needle pericardiocentesis. This is what is called as needle pericardiocentesis. Okay? That is what is remember. Definitive management, if I talk about, what is the definitive management? I need to open up the thorax of this patient. And if I need to open up the thorax, opening up of thorax is called as emergency thoracotomy. Opening up of thorax is what is called as emergency thoracotomy should be done. Or immediate thoracotomy should be done. Okay? That's important. Next, talking about another condition. And what is this condition, guys? See over here. This is the normal lung. Okay, hopefully you are able to identify. And this is what is the affected lung over here. Okay, this side is the affected lung. So right side of the patient is affected. Okay, how to identify a right and a left side? I hope all of you are taught by radiologists. Over here, if you see the heart shadow, that means it is the left lung. Okay, so it's important. Okay, so if you can see the left side of the heart, left side of the lung is normal, the right side is affected. And what is seen on the left side? You can see there is more blackening on the left side, right? The left side, sorry, the right side. The right-sided lung appears more black. The right-sided lung appears more black. Why it appears more black? What appears black on X-ray? X-ray पे क्या black दिखता है? X-ray पे air black दिखती है. Okay? X-ray पे air black दिखती है. So here you can see on the right side of the lung there is excess amount of air. So thus air is not within the lung. So where is this air? For example, this is your lung and this is the outer covering. What is the outer covering of a lung called as? Very good. Outer covering of a lung called as pleural cavity. The outer covering of the lung is called as pleural cavity. Now what has happened? There was some injury to the pleural cavity due to which a lot of air has come inside. A lot of air has collected inside the pleural cavity. Now if there is a lot of air inside the pleural cavity, it will again cause, just like cardiac tamponade, here also there will be a lot of pressure on the lungs. Okay, here there will be a lot of pressure on the lungs. Will the lungs be able to expand properly? No. If the lungs fail to expand, the patient will suffer from respiratory distress. And this condition, when there is a lot of air in the pleural cavity, air is called as Pneumo. And where is the air? In the thorax. Therefore, this condition is what is called as pneumothorax. Okay. So here we are going to discuss about pneumothorax. Now, important is pneumothorax can be spontaneous also. But spontaneous pneumothorax is usually not so severe. It does not cause decreased blood pressure in the patient, and it is usually seen in a case of emphysema when the bleb usually ruptures. But tension pneumothorax is the important one, which is seen in a case of trauma, in a case of thoracic trauma. What is seen in tension pneumothorax? Now see, on one of the sides there is a lot of air. What will happen? This side will compress the superior vena cava and it will also compress the heart. If the heart is compressed, definitely, if the heart is compressed, what will happen? Will the heart be able to receive a lot of blood? No. If the heart is compressed, it is not able to relax. It is not able to receive a lot of blood. If the heart is not able to receive a lot of blood, incoming blood is low. Outgoing blood is low. So outgoing blood is what is? Cardiac output. So if cardiac output is low, blood pressure of the patient falls. And that is what is called as hypotension. So tension pneumothorax, you need to remember why we call it as tension, because the blood pressure, okay, of the patient will fall. Okay, the blood pressure of the patient falls. That is the reason we call it as tension pneumothorax. There is so much of air that the heart is even compressed due to that. Okay, and it is following a trauma usually. How to pick up the X-ray? Please remember, as I have told you, there's a lot of air surrounding the lung. Therefore, the lung of the patient will be collapsed. So you can see this is what is the collapsed lung. On the affected side, you can see there is a collapsed lung. And this excess air, this black colored air which is seen now, it is surrounding the lung. And this is what is called as hyperlucency. Okay, hyperlucency, that is nothing but increased blackening. So you can see on the affected side, there is hyperlucency. Opacity on X-ray is white. Lucency on X-ray is black. So there is hyperlucency or increased blackening on the affected side. Next, you can see there is deepening of this angle. What is this angle called as? Costophrenic angle. The angle between the diaphragm and the rib, costophrenic angle, has deepened. This is known as the deep sulcus sign. There is a characteristic deep sulcus sign usually, which is seen in this patient. Apart from that, the diaphragm is which shape normally? Dome shape. But here, due to excess of air and excess of compression from above, the diaphragm has flattened down. So there is what is flattening of diaphragm, which is also seen. There is flattening of diaphragm, which is commonly seen in the patient. Next, you can see over here in this patient, you can see any bronchovascular markings. So in a normal lung, you can see there are these whitish lines. These whitish lines are nothing but the bronchus and the vessel markings. Okay, in a normal lung, you can see that. But in a case of tension pneumothorax, are you able to see that? No. No whitish markings are seen. That means the bronchovascular markings are absent. So the bronchovascular markings are absent in a case of tension pneumothorax. Apart from that, this is the classical feature. You can see this is the trachea, where you can see the trachea is shifted towards the opposite side. The same trachea should be central, right? But here you can see the trachea is shifted to the opposite side. There is a contralateral tracheal shift. Opposite sided tracheal shift is what is seen. Okay, so contralateral tracheal shift is seen. How to pick up a case of tension pneumothorax? Okay, this was about the X-ray. I have told you the X-ray. Now, how to pick up a case? I have made the classical ABC of pneumothorax. And what are these ABC? These ABC will help you make a clinical diagnosis of tension pneumothorax. And you will say, sir, why clinical diagnosis is required? Clinical diagnosis is required because most of the patients of tension pneumothorax will be having a low blood pressure. And therefore, we need to immediately manage the patient. Just say we were doing management in cases of cardiac tamponade, where see we will do some emergency management in cases of tension pneumothorax also. Okay? A stands for what? So please remember, A stands for on the affected side, as the lung is collapsed, will there be air entry? No. Will there be breath sounds? No. So if you auscultate the affected side, there will be absent air entry. There will be absent air entry and there will be absent breath sounds as well. Absent air entry and absent breath sounds are heard on the affected side. Next, B stands for what? Breathlessness. That is a complaint of the patient, respiratory distress or breathlessness, because the lung is not able to expand. And C stands for what? Congested neck veins. I have told you what happens. The excess of air or the pleura which has been enlarged, it compresses the superior vena cava, due to which, as the superior vena cava is compressed, blood cannot go into the heart. Blood stays in superior vena cava and then it stays in IJV. And that causes congested neck veins in the patient. The neck veins are full. That is the ABC of tension pneumothorax. That will help you make a clinical diagnosis. Okay? These are the keywords of your question also. If you suspect tension pneumothorax in a patient, then definitely what should be done? Investigations, please remember, investigation. First line is always First line is always a chest x-ray that has to be done. But if they ask you what is a better investigation, definitely it can be a CT scan which can be done if the patient's blood pressure is not falling. Okay, CT is a time taking procedure. So if you have it available, you don't need to send the patient for any other center to take a CT scan. No, you need to manage the patient in emergency. So most of the times it is a clinical diagnosis. Even without X-ray or CT, we are able to make a diagnosis. Okay? And I've told you what is another emergency investigation for thorax. It is usually a fast. So if I perform a fast, I'll be able to see these signs. Okay, on a fast, I'm able to see these signs. Don't need to remember everything. Please remember, in a normal lung, we will be able to see a seashore sign. Why? Normal lung is expanding. It is usually relaxing, constricting, relaxing, constricting. So there is a lung movement which is seen. Therefore, a normal lung shows a seashore sign. But in a case of pneumothorax, is the lung able to expand? No. So there is no lung movement which is seen. If there is no lung movement, in a case of pneumothorax, we can see a barcode or a stratosphere sign. We can see a barcode or a stratosphere sign. So that has to be remembered. Normal lung, seashore sign. Pneumothorax, barcode or stratosphere sign. Then if I come to the management of the patient, if I could talk about the management in a case of tension pneumothorax, emergency management should be done by what? So please remember, emergency management ki agar main baat karu, important is here we will take a needle, a wide bore needle, wide diameter wala needle, and we are going to insert in the intercostal space of the patient. Why? Because if we insert in the intercostal space of a patient, what will happen? All that air will come out via this needle. And the lung will be able to expand now. The pressure decreases, lung is able to expand. And jab lung phulne lagegi, definitely the patient will have improvement in breathing also. And the blood pressure will also improve of the patient. Okay? So definitely emergency management. Okay, we were inserting needle in pericardium. That was called as needle pericardiocentesis. Now we are inserting the needle in thorax. So this should be called as needle thoracocentesis. This is known as needle thoracocentesis. Now important is, insertion of needle according to ATLS protocol, it has changed. Okay, according to ATLS protocol, previously it was second intercostal space, mid clavicular line. Now it has changed. Okay, now in cases of adults, according to the ATLS protocol that we follow, it is usually the fifth intercostal space. It is the fifth intercostal space on the mid axillary line or just anterior to the mid axillary line, to be specific. Okay, so that is what is the site in adults. But in a case of a child, it is still the same. ATLS protocol still says the same. In a case of child, it is usually the second intercostal space. Okay, on which line? Second intercostal space on the mid clavicular line. In children, it is still the same. Second intercostal space on the mid clavicular line. I know Harrison's has not changed it, but as we are following ATLS protocol for trauma management, it is this one that you need to follow. Next one, if I talk about definitive management. Definitive management, please remember over here is what? You need to insert a chest tube. Okay, so if you insert a chest tube, see, this is what is the pneumothorax. You are inserting a chest tube in the patient. Okay, and that chest tube which is inserted now, it is connected to an underwater seal. Okay, why underwater seal is required? What is underwater seal? That means the tube goes and it is going into the fluid. Because if you don't fill up the fluid in the bag, what will happen? Air will come out, it will go in. It will come out, it will go in. Now the air is coming out. Okay, and it will escape by forming bubbles. But will the air be able to enter the tube? No, it is not able to enter the tube. And therefore this underwater seal is required. Okay, so definitive management is ICD insertion. What is ICD? Intercostal drainage tube, or ICT also you can call it. Okay, so intercostal drainage tube insertion has to be done. Okay, so intercostal drainage tube has to be inserted. Okay, so intercostal drainage tube with underwater seal is inserted with an underwater seal. What is the site? So please remember, it is the fifth intercostal space where we inserted. But which line usually? So we don't call it the line. Okay, it is usually in the triangle of safety. Triangle of safety, once just see it. The anterior border is formed by lateral border of pectoralis major. The posterior border is formed by lateral border of latissimus dorsi. The base is formed by the fifth intercostal space, and the apex is formed by the base of axilla. Okay, so that's important. So usually fifth intercostal space in the triangle of safety, we generally insert this ICD or intercostal drainage tube with underwater seal. No issues with this, anybody? So this is important to be remembered for the management of tension pneumothorax. Chalo. Done with thoracic trauma. Now talking about abdominal trauma. So let's try to complete abdominal trauma. Maybe we'll start with breast tomorrow. Okay, or burns we will complete, and then we'll start with rest tomorrow only. Okay, so jaldi se. If I talk about abdominal trauma now, here we have a 17-year-old girl. Here we have a 17-year-old girl who presents to the emergency department with a stab wound. Stab is a penetrating or a blunt trauma. Definitely it is a case of a penetrating trauma to the abdomen. There is a stab wound in the abdomen, that is penetrating trauma to the abdomen the patient has in the anterior axillary line at the right costal margin. Blood pressure of patient is 80 by 50 millimeters of mercury. That means the patient's blood pressure is dropping down. That means the patient is having hypotension. Next, important is the pulse rate of the patient is 120 beats per minute. Okay, so definitely the heart rate or the pulse rate of the patient is high. Okay, that means tachycardia. And we know if there is low blood pressure and tachycardia in a patient, that is what is suggestive of shock in a patient, right? Respiratory rate is also high, 28 breaths per minute. Normal is 12 to 20. Okay, 2 large bore IV lines are inserted. Definitely we know for circulation management, we insert minimum 2 18 gauge IV lines. Those were inserted. Nasogastric tube was inserted. Foley's catheter was inserted. Blood pressure after giving fluids to the patient increases to 90 by 60 millimeters of mercury. What is the appropriate management in this patient? Now, important is, how do I determine shock in a patient, or how do I determine if the patient is hemodynamically stable or the patient is hemodynamically unstable? That term we are going to use a lot now. So important is, please remember, we will try to check the shock index of the patient. What is the formula of shock index? Shock index is heart rate upon systolic blood pressure. What is normal heart rate in a patient? Normal heart rate of a patient is 72 beats per minute. What is the normal systolic blood pressure? 120 mm of Hg. So usually in a normal patient, the shock index will be more than 1 or less than 1. So in a normal patient or in a stable patient, hemodynamically stable patient, the shock index should be less than 1. Okay, the shock index will be less than 1 in a normal or a stable patient. But if the patient is in shock, okay, if the patient is in shock, that means a hemodynamically unstable patient. Okay, hemodynamically unstable patient, that means a patient who is in shock. इसी patient का ले लो, okay, इसी patient का vitals देखो. What is the heart rate of this patient? 120 beats per minute. Okay, and what is the blood pressure of this patient? 80 millimeters of mercury, systolic blood pressure. Okay, now is the shock index more than 1 or less than 1? Definitely the shock index is more than 1. So if the shock index is more than 1, that is suggestive of a hemodynamically unstable patient or a patient who is in shock. Okay, that's important. Now if I talk about abdominal trauma, I'll come back to this question, don't worry. So if I talk about abdominal trauma, what is the most common organ injured? These are some important one-liners that you should be aware of. The most common organ injured in a case of blunt abdominal trauma is definitely the spleen. The most common organ injured in cases of blunt abdominal trauma is the spleen, followed by the second most common organ injured is the liver. If they ask you which is the most common organ injured in penetrating abdominal trauma, then the most common organ injured in penetrating abdominal trauma is usually the liver. If liver is not an option, then you need to mark it as stomach. Okay, penetrating मतलब किसी ने चाकू घुसाया. Somebody stabbed you with a weapon. Okay, so liver followed by stomach, followed by small intestine. Okay, if they ask you which is the most common organ injured in a seatbelt trauma. Now, when I was driving a car, okay, I was wearing a seatbelt and then applied a sudden brake, or there was a collision of my car with the next car. That means मेरी car धड़क गई किसी और के साथ. And what will happen? There will be a sudden hyperflexion. If there is a sudden hyperflexion, the thorax of mine will be saved, but the abdominal organs will go ahead. As the abdominal organs go ahead, I hope all of you are quite aware, we have the intestine, and the intestine is attached with the help of a mesentery. Okay, so now if the intestine goes ahead suddenly, okay, there is sudden hyperflexion of the intestine. What will happen? There will be stretching over the mesentery, and that will cause rupture of the mesentery. Okay, there will be rupture of the mesentery. The most common organ injured in cases of seatbelt trauma is the mesentery. And what happens to the mesentery? There is a mesenteric rupture which occurs. Okay. Next is in cases of blast injuries. If I talk about the abdominal organs, overall it is the eardrum, followed by trachea, followed by lungs. But definitely in the abdomen, it is the small intestine or the intestines in short, you can remember. Okay, it is the intestines. More commonly, it is the short intestine, small intestine. Now, if I talk about the flowchart of abdominal trauma, very important for all of you to know. If I talk about management in a case of abdominal trauma, guys. If I talk about management in a case of abdominal trauma, I need to see whether the patient is suffering from a blunt abdominal trauma or the patient is having a penetrating abdominal trauma or the patient is having a penetrating abdominal trauma. Okay. If the patient is having a blunt abdominal trauma, again I need to see if the patient is hemodynamically unstable, that means the patient is in shock, or the patient is hemodynamically stable, that means its blood pressure and heart rate is normal. Same thing with penetrating also. I will see if my patient is hemodynamically stable or my patient is hemodynamically unstable. Okay? So that is how you need to remember the flowchart. Important is, first I'll start with blunt trauma. Okay, blunt trauma, usually in this condition I'll start with all the types of trauma. First important line that I will need all of you to remember. Okay, any case of abdominal trauma who comes to you, whether it is a blunt trauma or it is a penetrating abdominal trauma, whether the patient is hemodynamically stable or the patient is hemodynamically unstable, if you are having a rapid ultrasound in the emergency itself or in the operation theater itself, that rapid ultrasound has to be done. In this rapid ultrasound, we only check for 4 sites. First is we keep the ultrasound probe in the subxiphoid space. We check for the pericardium to rule out any cardiac tamponade. Second, we keep the probe in the right hypochondrium to check for any perihepatic bleed. Third, we keep the probe in the left hypochondrium to check for any perisplenic bleed. And fourth, we keep the probe in the suprapubic region to see any blood collection in the pelvis. Okay, so this is what is called as a fast. Okay, or a E-fast. Extended fast mein the 2 other sides that we add is the right and the left thoracic cavity. Okay, so the first line investigation, important is, the first line investigation in any case of abdominal trauma is a fast or a E-fast. Okay, it is usually a fast or a E-fast that we perform. Okay, so fast, E-fast, important. Kuch bhi jo bhi tum kar sako, that should be done definitely. Okay, so fast or E-fast, whatever is available, that should be done. No issues with this, anybody? That's important in every case. Important is, now if my patient is having a blunt abdominal trauma and he is hemodynamically stable, okay, I have performed a fast. 2 conditions can be there. Fast will tell me about what? Ultrasound will always tell you about any fluid collection. So it will tell you ki in the abdomen if there is any fluid collection. And what is that fluid collection in a case of trauma? Nothing else but blood. Okay. So if the fast comes out to be negative, nothing has to be done, just go for observation of the patient. But if the fast shows any fluid collection, if it comes out to be positive, then I need to go for the best or the gold standard investigation. And what is the gold standard investigation in cases of abdominal trauma? It is CECT abdomen. Okay, it is CECT abdomen, that is the contrast enhanced CT scan of abdomen. Okay, that should be done in the patient. Okay, and depending on the findings in the CECT abdomen, you will manage the patient. Okay, if conservative management is required, go for conservative management. If surgical management is required, go for surgical management. Next, if I talk about unstable patient with a blunt abdominal trauma, I'm having a hemodynamically unstable patient with a blunt abdominal trauma. Now there can be 2 conditions. Either the E-fast can come out to be positive. If the E-fast comes out to be positive, if it shows blood collection and your patient's BP is suddenly dropping, that means there is an active hemorrhage or active bleeding which is going on. Then definitely go for a surgery. And what is that surgery that we perform? We need to check now which site is bleeding. Therefore, we completely open up the abdomen with a midline incision. And we check for the bleeding site. Checking is known as exploration, and we are performing opening of the abdomen, that is called as laparotomy. So the surgery that we perform is what is called as exploratory laparotomy has to be done. Exploratory laparotomy. Next is, if the E-fast comes out to be negative, then what should be done in this condition? If the E-fast comes out to be negative, okay, we will give fluids to the patient definitely. Okay, if the patient's condition starts worsening, take up the patient for surgery. But if the patient is unstable definitely, but his BP has not fallen too low, then take up the patient for a repeat E-fast. Okay, take up the patient for a repeat E-fast or a fast, whatever it is. And in how much time? Usually within a span of 30 to 45 minutes. Okay, after 30 to 45 minutes, take the patient for a repeat E-fast. If the repeat E-fast shows positive, take up the patient for surgery. And that surgery is nothing else but again the exploratory laparotomy itself. Okay, it is again the exploratory laparotomy. Next, if the repeat E-fast comes out to be negative, then there's a problem. Now 2 fast have come out to be negative. Then go for serial PCV. Then go for serial PCV and hemoglobin monitoring. PCV is what? Packed cell volume, also known as hematocrit. Check for PCV and hemoglobin monitoring. What do I mean by serial? After every half an hour to 1 hour, you take the blood sample of the patient and you send it to the lab. And you check for his PCV, packed cell volume, hematocrit or hemoglobin. Okay. If the serial PCV monitoring or hemoglobin monitoring is showing you a decreasing trend, that means the values of hemoglobin or PCV are decreasing, That means there is a bleeding which is going on in the patient, take up the patient for surgery. That is the exploratory laparotomy. But if the serial PCV and hemoglobin monitoring appears to be normal, then definitely go for what? Then definitely go for observation in the patient. Only go for observation in the patient. Okay, that has to be done. No issues with this, anybody? So hopefully there is no problem as such. You are able to hear me out. Next, moving further. Just a minute, I'll reconnect it. There's some problem with mirroring. Next is important one. Now I'm going to talk about the penetrating trauma wala patient. If I talk about penetrating trauma, again, whether the patient is hemodynamically stable or unstable, the first line investigation is always a fast. Okay, important is if the fast here also, okay, here we need to see if the fast is positive. If the fast comes out to be positive, definitely I am going to take up this patient for a CECT abdomen. You will say, sir, you are taking a stable patient for CECT abdomen. Why? Because it is the gold standard investigation. It can tell you more about the bleeding site. It can tell you about all the injuries in the patient. But why are you not taking a patient who is unstable? So a patient who is hemodynamically unstable, the patient is in shock. If I take this patient for a contrast enhanced CT scan, which is a time taking procedure, the patient will go alive inside but come out dead outside. Okay, so that's the important thing. We do not have time to perform a CCT abdomen in an unstable or a shock patient. Okay, that's important. CCT abdomen, usually here we need to check for what? We need to check if there is any penetrating trauma. No? So see, there is a penetrating trauma to the abdomen. You need to check, okay, if the abdominal wall is damaged, no issues with that. But if the peritoneum is damaged, then there is a problem. Why? Because if there is peritoneal injury or there is a peritoneal breach which is seen, then the patient will land up into peritonitis, and peritonitis is a indication for exploratory laparotomy, because peritoneum does not okay, so peritoneum, please remember, sorry, peritoneum will not handle any kind of nuisance. It will immediately undergo inflammation and the patient can die due to that. That's the reason. Okay, so you need to check for any peritoneal breach in the patient. Okay, check for any peritoneal breach in the patient. If peritoneal breach, important is, if peritoneal breach is seen, definitely take the patient for a surgery, and that is what we know, exploratory laparotomy. But if peritoneal breach is not seen, that means it is only an injury till the abdominal wall, the peritoneum is not breached, then only go for a local wound exploration. Then only go for local wound exploration and suturing. Only explore the local wound, clean it properly, and go for suturing. Local wound exploration and suturing. Next, if the patient is hemodynamically unstable in a case of penetrating abdominal trauma, okay, and the fast comes out to be positive in most of the conditions, even if the fast is not available, guys, even if the fast is not available and the patient is having a penetrating abdominal trauma and the patient is hemodynamically unstable, in this condition, always take up the patient for surgery. Even if the fast is available or not available, does not matter. Take up the patient for surgery always, that is exploratory laparotomy. Now, what are the indications where we will always go for exploratory lap? That is a very important thing. Okay, so there are few conditions. That means any one of the following where the patient is always taken off. Okay, so any one of the following with penetrating abdominal trauma. Any one of the following condition with a penetrating abdominal trauma where the patient will always be taken up for, okay, where the patient is always taken off for a exploratory laparotomy or a surgery. And what are these conditions? First, if there is an impaled object. What is the impaled object? That means the knife or the sword is still intact over there itself. And we know, we ask all of them, don't remove the knife or the sword. Why? Because if you remove the knife or the sword outside in the emergency room or anywhere outside, what will happen? Maybe this sword or the knife is having a tamponading effect and it has stopped the bleeding. If you remove it, maybe there will be more bleeding and you can lose the patient. Therefore, if there is an impaled object, only remove the object in the OT, and that is done by exploratory laparotomy. Second important thing, definitely, apart from this, important is any patient who is having a features of peritonitis. As I've told you, peritonitis hai, that is always an indication of surgery. Third important, if there is evisceration. What do I mean by evisceration? Viscera is nothing but the internal abdominal organs. Intestine, for example, intestine is coming out from the injury. Definitely, you need to perform a proper expiratory laparotomy, or if there is any bleeding from natural orifices, मतलब कान नाक गले से खून आ रहा है, okay, if there is bleeding from ear, nose or throat, so bleeding from natural orifice, or anal bleeding if there is, okay, rectal bleeding is there, so bleeding from natural orifices, okay, so that is also an indication. And the fifth indication is plus minus, because Bailey says now depending on the severity of injury you will manage the patient. That is a gunshot one, okay. So these are the 5 indications. Chalo, that was all about your abdominal trauma. Now going back to your question, guys, here now definitely please answer me in the chat box, okay, that till that time I'll cover the next topic. So please answer me in the chat box. Just see the question once. 17-year-old girl, edema आई है, which type of trauma? Stab wound, so it is a penetrating trauma. Blood pressure is 80/50 and heart rate is 120. Okay, so if the blood pressure is 80 and heart rate is 120, shock index is more than 1, patient is unstable or stable, patient is unstable, that means she is shocked. So penetrating abdominal trauma and unstable patient, if fast is not even available, we can directly take up the patient for surgery. So here the better answer should be expiratory laparotomy. Even if fast is not done, we can directly take up the patient for a surgery as well. Okay, that's important. Next, if I talk about few points about fast only, as I've already told you, fast is nothing else, guys, but a rapid USG or a rapid ultrasound which is done in cases of emergency. There are only 4 passes in a case of fast. We only keep the ultrasound probe at 4 sites. One, it is kept in the subxiphoid space and it is to check for any pericardial collection of fluid, that is cardiac tamponade. Second, it is kept, okay, in usually west space. Second, it is kept in the right hypochondrium to check any perihepatic blood collection. Third, it is kept in the left hypochondrium to check for any perisplenic blood collection. Fourth, it is kept in the suprapubic region to check for any pelvic blood collection. Okay, so that's important. And if they say e-fast, so e-fast, as I've told you, along with the 4 fast or the 4 passes that we have 2 more passes as well, and these 2 passes are for the right and the left thoracic cavity. These are for the right and the left thorax to check any blood collection in the right and the left thorax. Fast is what? Fast, they might ask you the full form at times. They have asked earlier. It is nothing but focused assessment by sonography in trauma. It is nothing but focused assessment by sonography. Sonography is nothing but ultrasound. Okay, so focused assessment by sonography in cases of trauma is what is fast. Okay, so that was what you need to remember. No issues till anybody? That is important. Moving further to next question. Okay, answer the question. A 60-year-old male, known case of coronary artery disease, was taking a lot of NSAIDs, non-steroidal anti-inflammatory drugs, and was brought to the emergency with acute pain abdomen. On examination, tenderness was present all over the abdomen. So if you touch the abdomen, the patient is crying out in pain. That is what is tenderness. Guarding is there. That means if you try to palpate, the patient will contract his abdominal muscles. Therefore, you are not able to palpate. That is what is called as guarding. The blood pressure of patient is 90/60 mm of Hg. That means the patient is going into hypotension and finally shock. Chest X-ray has been given below. What is the preferred management? So one hint, if they talk about pain abdomen and they will give you a chest X-ray, they are going to talk about this condition only, and that is what is hollow viscous perforation. That means perforation of your stomach or your intestine. Okay? So usually here you can see what is seen on the chest X-ray. You can see there is blackish appearance beneath the right dome of diaphragm. Beneath the right lung or beneath the right dome of diaphragm, you can see a blackish appearance. And what appears black on X-ray? We know air appears black on X-ray. So you can see this gas or this air which is collected beneath the right dome of diaphragm. This is what is called as gas under diaphragm. This is what is known as the gas under diaphragm. And gas under diaphragm is also known as which sign? It is also known as the cupula sign. And if it is on both sides, it looks like mustache, right? If it is also known as the mustache sign. So gas under diaphragm, also known as cupula or mustache sign. Okay? Important. It is suggestive of what? It is suggestive of pneumoperitoneum in the patient. What is pneumoperitoneum? Pneumo ka matlab hota hai air. So if there is air or gas inside the peritoneal cavity, and when there will be gas in the peritoneal cavity, do we have normally gas in the peritoneal cavity? No. So if the intestines will undergo perforation, okay, the gas or the air from the intestine will go into the peritoneal cavity, and that will cause a pneumoperitoneum. That means here the intestines have perforated, or the hollow viscous have perforated, because it is not only the intestines, it can be the stomach also. So it is called as hollow viscous perforation. That has been a Sarkari question of your exam. Here my diagnosis is definitely hollow viscous perforation. And if I talk about hollow viscous perforation, guys, if I talk about hollow viscous perforation, important, it can be either a stomach or intestinal perforation. Why do I suspect hollow viscous perforation in this patient? Because this patient is taking NSAIDs, non-steroidal anti-inflammatory drugs, for a longer duration of time that are known to cause ulcers in the stomach as well as the duodenum, and these ulcers can finally perforate as well. Okay, and that is important. And what are all these signs shown in the question? Acute pain abdomen, diffuse tenderness, guarding, all of these signs are suggestive of if the intestine perforates. Will it be only the gas which goes into the peritoneum? No, it will also be the intestinal contents, and all these intestinal contents, fluids, food, all of this will go into the peritoneum. As I've told you, peritoneum does not handle any nuisance. It is a sterile cavity. It needs everything clean. If all this dirt comes into the peritoneum, what will happen? There will be inflammation of the peritoneum. That is what is called as peritonitis. So hollow viscous perforation can land up the patient into peritonitis. What are the signs of peritonitis? We know there will be diffuse tenderness over the abdomen of this patient. Okay, the patient will have severe abdominal pain as well. Along with that, what will be the other complaints? The patient will have guarding as well. The patient will not let you palpate, that is guarding. Then the patient will have cardboard like rigidity. Yes, the abdomen will become hard like a cardboard. There will be cardboard like rigidity in the abdomen of this patient. Okay, so that's important. And if there is peritonitis, the patient can also have shock as well. Okay, so all of these features will be present. The X-ray features that I've already told you, it is gas under diaphragm, cupola or moustache sign, which will be seen due to collection of gas below the right dome of diaphragm. Okay, so that is what is important. Now what should be the treatment? So definitely, if it is a case of hollow viscous perforation, you need to open up the abdomen, as it is a case of peritonitis. And as we are opening up the abdomen, that is what is called as exploratory laparotomy. Laparoscopy is not done in cases of shock patients. Yaad rakhna, any surgery is not done via laparoscopy if the patient is in shock. Okay, so it is always exploratory laparotomy that we give, and definitely as the patient is in shock, we will need IV fluids in the patient as well. Okay, so that's important. Okay, no issues with this, anybody? That is very important to be remembered, guys. Okay, and we will also do a peritoneal lavage in this patient. As the peritoneum has been infected, it is inflamed, we need to clean the peritoneum. That is what is called as a peritoneal lavage. Next, if I talk about this condition, what is this? This is what is telling you about the retroperitoneal trauma. If there is any trauma in the retroperitoneal region, that means behind the peritoneum. Now the retroperitoneal region is divided into 3 zones. The zone 1 which is there, you can see it is the central zone. And what lies in the central zone? The inferior vena cava and the aorta. So the major vessels are lying in the central zone. If there is damage to the central zone of the retroperitoneum, what should be done? So if there is damage to the zone 1, there will be very high chances of bleeding, because major vessels lie over there. And if there will be excessive bleeding in the patient, what will happen? If there is excessive bleeding in the patient, definitely the patient will go into shock. And therefore zone 1 always requires, zone 1 trauma always requires a surgical exploration. Zone 1 always requires a surgical exploration. Next is zone 2. Zone 2 is which zone? Zone 2 is the lateral zone. What lies in the lateral zone? You can see it is the kidneys and it is the renal vessels. Now definitely there is a risk of bleeding, but not so much, okay, which was seen in zone 1. And zone 3 is which one? Zone 3 is nothing but the pelvic zone. Okay, and in pelvic zone, which blood vessels lie? It is the iliac vessels which will lie over here, direct branches of aorta. Okay, now usually in zone 2, okay, in zone 2 or zone 3 retroperitoneal trauma, in zone 2 or zone 3 retroperitoneal trauma, what should be the treatment in the patient? The treatment in the patient, please remember, in this condition is usually, we try initially for angioembolization. Okay, we try to stop the bleeding with the help of angioembolization by embolizing the arteries which are bleeding. But if that fails, definitely we need to take up the patient for a surgery, that is surgical exploration. Okay, that's important. In the August examination, August 2020 FMGE examination, they asked that which zones require surgical exploration always. Now, if they ask you single best answer, we know the answer is zone 1. But in those options, it was zone 1 and zone 2, zone 1 and zone 3, zone 2 and zone 3. So these were the options and all of the above. So please remember, if you need to mark it as 2 zones, then it should be zone 1 because it contains the major vessels like IVC and aorta. And if you need to mark another zone, it should be zone 3 because it contains direct branches of the aorta, that is iliac vessels, which are major vessels again. Okay, zone 2 usually it contains renal vessels, one of the smaller branches. Okay, so that's the important thing. Chalo. Talking about burns, then I will complete. And just to answer your previous question. I hope all of you are quite aware. Okay, I have answered that question any which way. Talking about the last part for today, we will continue with endocrinal surgery tomorrow, breast and thyroid, because all of you will be exhausted as well. Talking about last part of general surgery, and that is what is burns. If I talk about burns, guys, definitely burns can be of two types. Either it can be hot burns, that is heat burns as well, or it can be cold burns as well. Okay, if they ask you which are the most common burns overall, I hope all of you are quite aware. Every day we have some hot liquid or hot milk falling on our surface, okay, on the skin surface. कुछ ना कुछ गिरता रहता है ना, गर्म दूध पानी कुछ ना कुछ गिरता रहता है और उसकी वजह से जलता है. That is what is the most common type of burns overall are the scalds. And the scalds are a type of burns which usually occur due to hot liquids. So scalds usually occur due to hot liquids. Next important is the most common hospital burns. If they ask you, the most common hospital burns are definitely the thermal burns. Okay, the most common hospital burns are the thermal burns, mainly the burns which occur due to flame. Okay, if they ask you most common cold burns which occur at freezing temperatures, the most common cold burns which occur at freezing temperature are known as frostbite. Okay, which usually occurs in the fingers or the toes. That is frostbite. No issues with this. If they ask you, these are one-liners that I am covering first. Now, in a case of burns, what can be the problems? Please remember. See, a case of burns can die usually due to three reasons. First of all, the patient will have suffocation and the patient will have decreased oxygen and the patient can die of hypoxia. Okay? So, the patient will have hypoxia. Why there will be hypoxia? So, please remember, hypoxia can be due to edema of the airway. Okay, so there can be edema of the airway edema. So, therefore, the patient is not able to breathe. Second, the patient has inhalational burns. Due to inhalational burns, again, there was a lot of edema and damage to the airway. The patient could not breathe. And third important, the patient was having a eschar. What is the eschar? A tight, thick, leathery skin which is formed around the chest. And it acts like a compression band around the chest. Therefore, the chest could not expand, the lung could not expand. The patient is not able to breathe freely. And that can also lead to hypoxia. Next is the patient can die due to hypovolemia. What is hypovolemia? Decreased amount of blood in the body. And why there will be hypovolemia? We know if there is excessive burns, there will be evaporation of fluid from the body, right? And the blood vessels will also be damaged. That will cause blood loss and the patient will land up in hypovolemia. Okay. And next important is the patient can die due to infections. And what are these infections? The patient will have sepsis. Okay. So usually the patient can die due to sepsis. These are the three main important reasons due to which the patient of burns can die or which we need to manage properly. If I talk about the most common cause of burns, okay, a patient of burns can die immediate on the spot itself. So what is the most common cause of immediate death in case of burns? So the most common cause of immediate death in a case of burns is definitely asphyxia. What is asphyxia? Suffocation. So due to suffocation, the patient was not able to breathe and the patient died on the spot. Okay. Why? Because the patient was having either some face burns or the patient was having some neck burns, due to which there was a lot of edema in his airway. The patient had hypoxia and the patient died. That is asphyxia. Or the patient was trapped in a closed room or a closed cabin which was burning. Now, definitely if there was a closed room, what will happen? There will be a lot of soot particles which will be released. These soot particles which are released now, the carbon particles, they contain a toxin and that toxin is carbon monoxide. That carbon monoxide toxin is definitely known to cause damage to the airways. That will land up the patient into suffocation and the patient can die. Next is, if that is not an option, go for neurogenic shock. Due to excessive pain, in case of burns, the patient can die as well. But that is the second most common cause of immediate death in burns. If they ask you early death in cases of burns, early death, that means usually within a span of 24 to 48 hours, the patient dies. So in a case of earlier, what is the most common cause of early death in burns? Within 48 to 72 hours, maximum 72. Okay. So usually it is hypovolemic shock. Okay. That we studied the second cause, that is hypovolemic shock. Next, what is the cause of late death in cases of burns? The most common cause of late death, usually late death means more than 3 to 5 days later. So after 3 to 5 days in a case of burns, if the patient dies, the most common cause is usually sepsis. Okay, and important to be remembered is sepsis is also the most common cause of death in burns overall. Sepsis is also the most common cause of death in burns overall. If they do not mention immediate, early or late, then the overall most common cause of death in cases of burns is sepsis. And sepsis is nothing but infection. What is the most common organism or the most common cause which causes sepsis or infection in a case of burns? That organism is known as Pseudomonas. Second most common is Staph aureus. but this is a previous year question and it is pseudomonas. Why I have highlighted it with green? Because we know pseudomonal infection will cause a green pus discharge. Okay, important. And they will also have green colored colonies, micro. Okay, and what is the source, most common source of sepsis in the patient? That has been asked once. So from where the infection starts? So the infection starts from the burns wound itself. So the infection starts from the burns wound itself. Okay, the source of infection is the burns wound itself. Chalo. Now moving further, talking about this question. A 30-year-old male was caught in fire, was brought to the emergency room. Doctor for assessment of total body surface area of burns. TBSA is nothing else but total body surface area of burns. We need to check ना कि कितना हिस्सा burn हुआ है, कितना प्रतिशत body का burn हुआ है, how many percentage of the body is burnt. So to assess the total body surface area of burns, they use the Wallace's rule. Okay, so Wallace's rule is used to calculate the total body surface area of burns, okay, or the percentage of burns in a patient. His both upper limbs were charred and the thorax was also charred anteriorly as well as posteriorly. Total body surface area of burns in this patient is. Now we know to calculate the percentage of burns, or to assess ki how much total body surface area in a patient has been involved with burns. We use this Wallace's rule of 9, which was given by Alexander Wallace. This, just a minute. This Wallace's rule of 9, which is there, guys. Here everything is 9% except one part of the body, and that has been asked commonly. Okay, so you need to remember the head and neck is taken as 9%. Okay, the trunk, that means the chest and the upper back. Chest is not the whole part. Please remember, the chest and the upper back is taken as 9% each, so total 18%. Then the posterior trunk. Okay, so please remember the abdomen and the lower back. Okay, so chest is 9%, upper back is 9%, abdomen is 9%, lower back is 9%. So again, it becomes 18%. Each arm, each upper limb will be 9%. Each upper limb is 9%. Please remember, anterior plus posterior. So 4.5, 4.5. Okay. Next is the leg. Each lower limb is 18%. Yes. Anterior lower limb 9%, posterior lower limb 9%. Anterior lower limb 9 and posterior lower limb 9%. Okay. Only part which is 1%. Okay. Only part which is 1% is the genitalia and the perineum, and that has been asked as a previous year question. Okay. So please remember, according to the Wallace's rule of 9, which part of the body constitutes, or which part of the body is only 1% of the total body surface area? And answer you know now, it is the genitalia and the perineum. Okay, so that makes a total of 100% of the total body surface area. Okay, so in this, coming back to this case, how much percent of burns are seen in this patient? You can see both the upper limbs are involved. One upper limb is how much percent? 9%. So if both the upper limbs are involved, it is 18%. Next, they are saying that the thorax is charred. Okay, thorax is charred anteriorly as well as posteriorly. So thorax anterior is the chest, 9%. Thorax posterior is the upper back, 9%. So 9 plus 9, again 18. So it will be total how much percent? Totally 18 plus 18 will be 36%. The total body surface area involved in this patient with burns is 36%. Important is, if there are patchy burns in a patient, so in a case of patchy burns, please remember, definitely we need to use the rule known as the palm rule. Okay, we take the palm of the patient, we cut a paper according to the size of the palm of the patient, and we keep this paper on the burnt part of the body, and we will try to calculate ki, okay, how much area of the body has been burned. Because it is patchy burns na, one palm will constitute how much percent? One palm constitutes 1% of the total body surface area. One palm of the patient constitutes 1% of the total body surface area of burns. No issues with this. But if they ask you, which are the best method to assess the total body surface area of burns? Okay, so it is the Lund and the Browder charts. Mainly used for pediatric population. But for pediatrics also, we have the Alexander Wallace's rule of 9. But if they ask you, overall best method is Lund and Browder charts. Moving further, guys. Next is question. A person was stuck in his cabin when it caught fire. He was rescued by the firefighters but was brought in unconscious state to the emergency room. What is the most important step in this management? Now, important step in the management of this patient is not fluid. Why? Because over here, the patient was stuck in a cabin. And I've told you, if a patient is stuck in a cabin which was burning, what will happen? There will be a release of lot of soot particles. And if there is a release of a lot of soot particles, what will happen? Definitely the patient will have inhalational burns. And if the patient is having inhalational burns, what will happen? There will be edema of the airway. And if we wait for some time now, definitely now the patient is not having respiratory distress, but the edema will keep on progressing, and the airway lumen will keep on narrowing, and finally we will not be able to even see the vocal cords of the patient. The airway will be completely blocked. We will not be able to intubate the patient. So if we are suspecting inhalational burns in a patient, how to suspect inhalational burns? So we suspect inhalational burns if there is any burns to the face, to the neck of the patient. Okay, to the face or to the neck of the patient, we suspect inhalational burn. Second, if there is signing or burning of the nasal hairs, that is an important sign again. Signing or burning of nasal hairs. Third, if the patient was trapped in a burning closed room, okay, so that's important. If the patient is having hoarseness of voice, or fifth, if the patient is having black carbon deposits in his sputum, okay, if there is black carbonaceous deposits in his sputum, all of these are signs that the patient has sustained an inhalational burn. And if a patient comes to you with inhalational burn, the most important and the first step in management is a prophylactic intubation. Yes, even if the patient is not having a lot of respiratory distress now, it will further progress. So it's always better to go for an early elective intubation known as prophylactic intubation. That's what the ATLS also suggests and the Bailey also suggests. Okay? No issues with this. That was a previous year question. Whatever questions I've taken, all of these are your PYQs itself. Now, if I talk about the degrees of burns, or grades of burns, there are 4 degrees or 4 grades of burns. Okay? If only the epidermis has been burnt, okay, it is a first degree burn. What will be seen over here? Only there will be redness of the skin, there will be swelling or edema of the skin, and the patient will have a lot of pain. Okay, so that is what is seen. Usually your scalds na, due to hot liquids or hot milk, जो पानी या दूध गर्म गिरने से होता है ना scalds, वो first degree burns होता है. Okay, or your sunburn. Okay, that is what is the first degree burn. Then second degree are 2 types. Okay, we have second degree superficial burns. Okay, second degree A or second degree superficial burns, and we have second degree deep, that is second degree D burns. Important is second degree के 2 types है. Second degree superficial burns, that is not only damage to the epidermis, but there is also damage to the superficial dermis. Okay, there is also damage to the superficial dermis. Here there will be redness of the skin, there will be pain in the patient, but important is the patient will also have a blister. And what is a blister? I hope all of you are quite aware. Blister is nothing but a balloon, you can understand, which contains fluid. That is a blister. You might have seen when you get burns, definitely you get this kind of a blister now. So it is a feature of second degree burns, and in second degree also you need to mark one, second degree superficial or second degree deep. So blisters is a classical feature of second degree superficial burns. Okay. Then if I talk about second degree deep burns, here the patient will not have redness, rather there will be pallor. The patient will still have pain, and the patient sometimes can have blister, not always. You can see over here the patient is not having a blister. So blister, अगर दोनों में से एक आंसर करना, answer should be second degree superficial. And if you need to answer it as second degree, so that's the best one. Here definitely there is damage not to the epidermis but also to the complete dermis. There is damage to epidermis as well as the complete dermis. Okay. Next is third degree burns or grade 4 burns. Third degree burns mein the patient has grayish or a grayish white or a blackish necrosis, and this blackish necrosis gives a thick leathery appearance to the skin, and this thick leathery appearance of skin is what is called as eschar. So eschar ban jata hai in the patient. Okay. The patient will have analgesia. What is analgesia? No pain sensation. Yes, third and fourth degree burns are painless burns. You will say, how sir? How third and fourth degree burns are painless burns? Please remember, third and fourth degree burns mein the nerves are damaged, and you know if the nerves are damaged, the patient will not be able to feel any pain. So the important thing is third and fourth degree burns, both are painless burns. Okay, both are painless burns. So usually here the patient will have analgesia, that is painless burns will be there. There is damage to the epidermis, plus there is damage to the complete dermis, even there is damage to the subcutaneous tissue. And we know usually if there is damage to the subcutaneous tissue, the burns are deeper. Okay, and this eschar I have told you, it can form around the chest and it can compress the chest, and therefore the patient will not be able to breathe freely. And therefore, to release the eschar, what we will do, we will give multiple incisions over this eschar. We will give multiple cuts over this eschar so that the patient can breathe freely. And that treatment is what is called as escharotomy, that has been asked in your pre-YQ. Escharotomy is done if the patient is not able to breathe due to an eschar formation. Next is grade 4 burns. Usually here there is damage to the epidermis, plus the dermis, plus the subcutaneous tissue, plus the muscle layer as well. So it is so deep burns that the muscle layer has also been damaged. Painless or painful? Definitely painless burns, because the nerves have been damaged completely. You can see all the deeper layers have been damaged. Okay, you can directly see the bone or the tendons of the patient. Okay, so these are grade 4 burns. If I talk about management, definitive management of grade according to grading, yaad rakhna, what is initial management? Initial management in a case of inhalational burns is always prophylactic intubation, but in all other cases, the initial management will be what? Because I told you, hypovolemia is a very important risk, because the patient can die due to hypovolemic shock. So initial management mein, we need to do basic resuscitation of the patient. What do I mean by basic resuscitation? That is the same thing that we followed in trauma. A, B, C, D, E. Airway, breathing, circulation, disability and exposure. We need to insert a peripheral IV line, and we need to start fluids in this patient to prevent any hypovolemic shock. Now coming to definitive management. In first degree burns, they were very superficial burns. Do we need any treatment? No. So first degree burns, only we treat them by exposure. Just expose them. Don't even do a dressing. Second degree burns. Second degree burns mein definitely the treatment is dressing. Okay, second degree burns mein the treatment is dressing. Which is the most common ointment used over here? The most common ointment or the cream which is used for dressing in a case of burns is usually 1% silver sulfadiazine, and that was the question. The most common ointment that is used is known as 1% silver sulfadiazine in a case of burns. Okay, but if there is a scar formation, will this silver sulfadiazine work? No. If there is an scar formation, that is usually in some second degree or most of the third degree burns, we need to use another cream, and that cream or ointment is known as mafenide acetate. Problem with this mafenide acetate cream is it will penetrate the scar, it will go deeper, but it will cause a lot of pain on application. Once you apply, एक बार लगाओगे ना, patient चिल्ला उठेगा, दर्द में कराह उठेगा, ठीक है? So that will be the problem, and it will also cause metabolic acidosis in the patient. For third and fourth degree burns, as majority of the tissues have been damaged, we need to go for a skin grafting in the patient. For third and fourth degree burns, we need to remove the necrotic tissue, and removal of necrotic tissue is what? It is nothing else but debridement, and debridement along with skin grafting has to be done. Okay, so that's important. Now here we have a child. Okay, a child who is 20 kgs in weight, who was brought to you with burns, and fluid resuscitation was to be started. The total body surface area of burns involved was 30%. Calculate the fluid requirement in the patient according to the Parkland's formula. Now there is an update in the Parkland's formula. Now in a case of burns, we calculate the amount of fluid or the requirement of fluid to a case of burns according to Parkland's or according to the ATLS formula. Parkland's formula का नया formula है, the updated version is 2 into body weight of the patient in kilograms, into total body surface area of burns in percentage. Total body surface area of burns in percentage. That is the Parkland's formula which is updated. And it is the same ATLS formula for adults also. It is the same formula of ATLS for adults as well. For adults also we use this same ATLS formula. If I talk about children, guys, important is what is the formula for children? Children need more amount of fluid. Okay. Therefore, it is 3 into body weight in kgs, in kilograms, into total body surface area of burns in percentage. That is the formula used for children. And if I talk about, this is only, okay, ATLS formula for children is separate. But for Parkland's for children also we use the same formula. For Parkland's we use the same formula for children's also. In only ATLS we have a separate formula for children where the multiplier is 3. In Parkland's we do not have a separate formula for adults and children. And the third formula which is given in ATLS protocol is for the electrical burns. In cases of electrical burns, there is excessive volume loss or excessive blood loss from the body. Therefore, more fluid requirement is there. And therefore, the multiplier is 4 over there. Okay, and that was the previous Parkland's formula. Now the Parkland's formula is 2. As I've told you, we do not use a lot of fluids now. That's the reason. Okay, so in cases of electrical burns only, the ATLS formula is 4 into body weight in kilograms into total body surface area of burns. Important is, please remember, they have asked you to calculate the fluid requirement to the child according to the Parkland's formula. So Parkland's formula is 2 into body weight into total body surface area of burns. So what is the body weight of the child? 20 kg. What is the total body surface area of burns? 30. So 2 3s are 5. So 2 3s are 6 and 6 2s are 12. So the total amount which is required is 1200 ml. So the total amount of fluid which will be required by this patient will be 1200 ml. Important is, out of this 1200 ml, the amount that we get, This is the amount which should be given to the patient over a span of 24 hours. This is the amount of fluid which should be given to the patient over a span of 24 hours. First half of this fluid, that means 600 ml, should be given in a span of 8 hours. Okay, so first half should be given in a span of first 8 hours. Whereas the next half, okay, the next half should be given over the next 16 hours. It should be given over the next 16 hours. Those who are having confusion, 0 to 8 hours, give half amount of fluid, that is 600 ml. And 8 to 24 hours, in these 16 hours, give the remaining half amount of fluid, that is 600 ml again. Okay, that's important. Next, if I talk about the last two topics, and one is, what is this? This is what is your frostbite. Okay, so as I've told you, most common cold burns, that is frostbite. Usually it only occurs at freezing temperatures, when there is ice freezing temperatures usually, right? Like in a Siachen glacier, our soldier who is posted at Siachen glacier is exposed to temperatures as low as -50 to -60 degrees centigrade. Over there, definitely the patient will have ice crystals formation in the tissues. Due to that, the blood supply to the fingers and the toes will be decreased, and if the blood supply is decreased, the patient will have gangrene as well. Okay, further. Next, this is a case of trench foot. It is not seen at freezing temperatures, but it is seen at sub-freezing temperatures. That means temperature around -10 or 0 degrees centigrade or 4 degrees centigrade, +4, +5, okay? At such sub-freezing temperatures, and usually moisture is there. That means a soldier who is standing in a trench, okay? Trench is nothing but a gadda which contains some fluid, okay? Water usually. And a soldier is standing in that trench for a longer duration of time. That person is definitely at a risk to develop trench foot, sub-freezing temperatures. Okay? In both these conditions, both are examples of cold burns. In both these conditions, what is the treatment? So treatment is rapid rewarming or gradual rewarming. धीरे धीरे करोगे और जल्दी से. Usually, please remember, it is a gradual rewarming. Rapid rewarming should be avoided because it can cause reperfusion injury. That is a risk factor. So gradual rewarming has to be done, and gradual rewarming is done with usually immersing the hands or immersing the foot in a warm water bath. What is the temperature of that water? That has been asked. The temperature of the water is maximum 40 degrees centigrade. It can be below 40 degree, but not above 40 degree. Okay, it is usually 40 degrees centigrade, the temperature it is. And if there is gangrene, we will go for a early amputation or a delayed amputation. We will generally go for a, please remember, we will go for a delayed amputation. Why delayed amputation is done? We wait so that a clear line of demarcation appears. Okay, a clear line of demarcation appears between the viable parts and between the non-viable parts. Okay, so you are able to see which parts. Okay, you wait for some time, you let that line of demarcation appear. Okay, so इतना हिस्सा काटना है वो तुम्हें समझ में आएगा. If you do it early, what will happen? You are not aware that this part is also having necrosis. Okay, if you have cut this part, amputated this part, the necrosis is still going on. That's the important thing. You wait for some time and then you go for amputation, delayed amputation. Thank you so much. So I hope you enjoyed the class, and please let me know in the chat box so I can end the session. Okay, if you are having any doubts, you can message me definitely in any platform possible. Okay, my every platform is with the same name, that is Dr. Omkar Sonone or Dr. Omkar Sangita Dilpra Sonone. You can find me on Facebook, Instagram, Telegram, everywhere. Okay, so that's important. I hope you have enjoyed the lecture of surgery. We have completed general surgery today. I know endocrinal surgery is left, but any which ways, I'll try to complete it tomorrow definitely. Okay, so all of you, I had a great time. Hope you all too had a great time. Okay, so like the video if you have liked the session as well. Recommend it to your friends. Okay, because FMG is the exam, please remember, where you need to take other people along with you. It is a qualifying exam, not a competitive exam. Okay, that's the reason why. Please take your friends along with you. Let them get benefits of this session as well, and I'll be more than happy to help you in any problem that you face. Chalo. Done with this? Let me know in the chat box a thumbs up. Thank you so much. Chalo. Tomorrow's topic, I'll be covering endocrinal surgery, and then I'll be starting with definitely vascular surgery, and then we'll proceed with GIT. Don't worry about that.